Hey, good morning, everyone. Sorry to, I'm not going to interrupt your breakfast. Carry on, get seconds, thirds. We'll go ahead and get started, though, because we've got a very full day. It's great to see everybody. Hopefully, folks made it out and about in Flagstaff last night. I know some folks were out hiking this morning. Apparently, there was a sunrise group checking out the sunrise from the observatory. Welcome back for day 3 of the Emergency Medicine for Rural and Indigenous Communities Conference. Excited to see everyone again. We've got another full day. I'm going to keep my comments this morning pretty short so we can get started, but our day includes a lot of content. We're going to have leadership from IHS talk to us briefly about the perspective from headquarters on emergency care. We're going to do another deep dive into some more clinical subjects today than yesterday. And we're going to have small group discussions in the middle of the day, as well as another working lunch. So at lunchtime, we're going to invite anybody who wants to, completely voluntary. But if you're in this room, you will be subject to a discussion about how we as a group continue to work together within and outside of the IHS system to work towards our shared goals of improving and optimizing emergency care for the communities we serve. And our colleague and friend, Chelsea White, I think he put it very well the other night when he said, this is a group of people working together to do the same thing. And it's something we all feel very importantly about. So I hope you all will join us again. Yesterday I was worried people were entrapped in this room during lunch, but hopefully we'll have the same turnout and it'll be voluntary. This is also a period of transition. I've had the wonderful opportunity to serve for the last 3 years as the emergency medicine chief clinical consultant, which is an internal advisor to IHS, kind of up and down the chain of command around matters of emergency medicine, clinical and operational. And as of this week, that role is transitioning to Paul Charlton. And he just received a 3-page document from me about all the things going on. So go easy on him because he'll be busy, but I think Paul has a tremendous ambition, achievable vision for what needs to be done in emergency care in this space. And I'm very excited and grateful. Thank you, Paul, for taking that. I really appreciate it. We're going to turn the mic over now to our friend and colleague, Dom Maggio. And before I get to Dom's introduction, I'm going to talk about another friend, a member of this community who's in Virginia, he's on baby watch. They're waiting the third in their family, someone named Ken Bernard, who many of you know. He wanted to be here. He was a part of the planning. He's been a part of this community and family for the last 4 years. He's a second generation Indigenous and IHS physician. And he's here with us, he's got to be there in case his baby comes. So I just want to acknowledge Ken. Without Ken, none of us would be here. He was a part of the planning of the first conference and was really the beating heart of that. And he made this conference possible as well through his contribution. So next time you see Ken, I'm happy to share his phone number with all of you. So feel free to send him a text. Say thanks. He'd love it if I send his cell phone number out. But we owe him our thanks for this community coming together. Dom, can I invite you up to you? I don't know if everybody should know Dom at this point. He presented many of our speakers yesterday. This conference is dedicated to the memory of a member of our community who we lost last month, Dr. Zach Stamili. You probably saw that on the website. He was a dear friend and colleague to many of us. He spent his career serving Indigenous communities in the IHS system in this part of the country. And Dom's gonna share the memory of Zach Stamili with us. And I hope you all will spend a little time. Those who didn't know him, you'll learn a bit about him today. And those who knew him, I'm sure you're thinking about him this weekend. But this conference is dedicated to his memory. And look forward to hearing more from Dom about our friend Zach.
morning. This is essentially never a scenario that I wanted to be up and talking about. But essentially, I've been talking to some of you scattered about the conference about what happened. And we lost Zach to suicide last month. And there's been, I became very aware that the Southwest region and our system in general, that it becomes knowledge. I've run into people who have randomly brought it up in Tucson or Phoenix, et cetera. So this is very real. And my intention was to just be honest about what happened and who he is and how we remember him and how we kind of imbue what we do with his legacy. Because I found an incredible part of our healing locally. Zach was, I've worked with Zach for 7 years now, and most recently at our site at White River, he was a full-time ER doc. And he was one of my best friends. He was an uncle to my kids. And yeah, and so we've been going through a lot. And the only way that that we've been able to move slowly forward is to be very open and to talk about him. And at work, you'll go through the day-to-day now, and essentially people will just share stories, and there are no barriers to that. And I've heard of scenarios where this has happened, where essentially then it becomes somewhat taboo to talk about it, and it's not. And that's been incredibly helpful. And so you work a shift and people share stories about Zach, and that's how we're moving forward. And that's how his family has taken this on. That's how all of our friends have taken this on. And that's how we're making slow and very, like very, very ugly progress through a really terrible event. So Zach was born in Oklahoma. He went to medical school in Oklahoma. He trained in Orlando. He was an IHS scholar. And so he came out to Tuba City. He was hired by Steve Conieris here. It's remarkable as we go through the history of things. You just see like the small little kind of tendrils of relationships with many of you who have worked with him or talked to him or otherwise heard about him. And that's where I met him. And he was my mentor from a clinical perspective. He was just an exceptional physician. Dr. Cantor said yesterday, he said, you never get points off for aggression, right? So he made decisions and he acted on those decisions. And that's just classic emergency medicine. And he did that, and that was his model. Again, very few of us who worked with him clinically are without a story of where he kind of rescued us from a rough situation with a patient. That's the type of clinician that he was. And if you've ever met him, so he would, he'd be the one with the belly laugh in the back of the room, right? Like he was carefree, and he was, like rough and tumble, big guy. And we loved him, and he wore his heart on his sleeve, and he was just gregarious and outgoing, an incredible friend and mentor and colleague, and we're devastated by his loss. And so I wanted to share a little bit on the topic of the risk of this to all of us. Part of owning this and part of accepting that this is a reality of something that happened in our life is also accepting the fact that we're at higher risk for mental illness. We're at higher risk for suicide, the clinical care community in general. And it is stigmatized, and there are barriers to getting care, and they're real. They truly do exist. And if you could ever find a positive morsel of anything that can come out of this, I've spoken with his wife about this, is that if somehow something that we say can in some way change someone's path from where Zach was, then it's entirely worth it. If you wouldn't mind switching to the next slide. So I've kind of had to become intimately related to or immersed in physician suicide, and then the resources that are available and how we do this, how we kind of walk through this scenario, because I immediately became worried about myself, my staff, all the way down to anyone who was working in the emergency department and the hospital at large. As you say, how do we protect ourselves? Because the stigma, the real stigma that exists is the risk to your medical license if you're ever deemed unfit, mentally unfit to care for patients. And I do understand the argument from a medical board where they say, hey, like, this is our charge. Our charge is to make sure that you are fit as a physician to work. But that threat, right, that is your lifeline to your profession and to what defines you as a person. That threat can be insurmountable, right? It can be insurmountable for you to go seek help when you need it. And so I've been having conversations with counselors, with psychiatrists as to what barriers exist and how do you navigate the system. And so I wanted to make some of the resources available to you that I found most noteworthy and helpful. The top one is essentially during COVID, everybody recognized that this was an inordinate amount of stress for all of you, right? The profession has not really gotten better. COVID made it much worse. And hopefully we're on the tail end of that. But essentially this is 600 plus psychiatrist volunteers who are essentially there just to answer your call, all right? Entirely anonymous. And you just end up on the line with a psychiatrist. And so it's 8 a.m. to 1 p.m. Eastern time. You know, it's not after hours, unfortunately. But this was in response to COVID, and it's literally just a call away, and you can immediately talk to someone about something that's going on. In the last few years, luckily, if you are acutely suicidal and you don't feel comfortable talking to a colleague, a family member, a friend, which I've essentially just shared with my staff, the only thing that I ask is that they make a call, right? Is all I could have asked for was to have a chance with Zach. There are so many of us that would have just done anything to change this. And so if you are uncomfortable speaking to anyone else, that's the 3-digit phone number. That's 24/7. Okay. That's immediate access. If you're a member of the IHS, the EAP system has been incredibly helpful. This is the Employee Assistance Program. You qualify for six counseling sessions, and you just call. It's confidential. The only way by law that they can break confidentiality is if you're a threat to yourself or to others. So if you are acutely suicidal, they will act to essentially try to support you. But that's the only way that they can break confidentiality. I'm speaking with them currently, so I'm enrolled in counseling sessions with the AP myself. And then if you're a director or otherwise a member of staff that is looking how to support your staff, yourself, the AMA actually has really wonderful resources. And most of all, there were no warning signs with Zach. You talk to his family. I saw him 24 hours before this happened, and there was no warning to this. And that's unfortunately relatively common. About a third of suicides, there is no warning. You don't get a advance notice, and you don't see the risk factors that we traditionally expect to see. And it really taught me that I have no idea what the person at the table next to me is going through. And so be gentle with each other, be understanding, and just seek to reach across the table and just be respectful of where the other person's at. And so the whole goal was just to say that this is very real. We just have immense gratitude for the support that we've found from the IHS as a whole. We immediately sought assistance from other sites to help us work and keep the emergency department open. And we've had physicians come from across the country, Utah and Oregon. Jeannie Ringbird came from Shiprock and essentially kept our doors open because our staff was like we were incapable of doing that. And so I have nothing but respect for Zach. And it's not, this is not, his legacy is not that this is what happened to him. His legacy is who he was as a clinician. And that's how we remember him in the emergency department. And if any of you have met him, that's his legacy within the IHS, is that he was here, he was building things, he was contributing to this community. And he's one of the reasons why many of us stayed here. And so it's been an honor to have him as a friend. And I just want, if there's anything that can come out of this, it's just remember to take care of yourselves and remember that resources do exist. So thank you.
So please keep Zach in your memory in this weekend and moving forward. And please share your contact information. And we've talked a lot and used the word community a lot. And that's what this is. And I'm going to speak for myself and say, I don't think that the system is optimized to support us well. I don't think the medical licensing process is optimized. I don't think employment, HR, credentialing. There's an excellent episode in MRAP this month, which takes this head on. And the bad news is the system is not built in a way to support us. That's my view. I speak for myself. But we can support each other and we can exchange our contact information and we can continue to build a community where there's resilience for us and a place to reach for. So please take that from this weekend, be in touch with each other, be there for each other. Thank you, Dom. Thanks for talking about Zach. Now we're going to move to our first speaker of the day, who was a part of helping get the support to White River that they needed following this event. Dr. Loretta Christensen is the Chief Medical Officer for the Indian Health Service. She's a trauma surgeon by training, and though she's very approachable, she's easy. And I hope she heard that. It's absolutely true, Paul. No problems there. Very approachable. You know it. Her bio is very, very long. And so what I'm going to tell you is that she's one of us. She's a practicing clinician, worked up until relatively recently at GIMC, among many other places. Interestingly, she incorporates acupuncture into her post-op care. So she's my experience is she had been a very forward-thinking leader in healthcare. I, for one, have been incredibly grateful. She's at the highest level in the agency as our Chief Medical Officer. Dr. Christensen is, in my observation, has been an advocate for the most forward-thinking initiatives such as academic partnerships, which we'll talk about later in the weekend, clinical pathway development, and so on. She has a strong understanding of emergency care needs and the emergency care environment as a trauma surgeon, and I think just as a good listener and someone who's interested in clinical improvement overall. And she's over my right shoulder in a bit of an intimidating way. Dr. C, good morning. It's good to see you. This is her second speaking engagement on a Saturday, so I want to be the first to very publicly thank Dr. Christensen for her time this morning. And the floor is yours, ma'am. Thank you again for joining us.
Oh, thank you so much. I hope you can all hear me okay. It is kind of daunting to be on a big screen. I'm glad I'm not really in the audience looking at this. It is my absolute pleasure to be with you today. And I'm so sorry I cannot be there in person, but between girls basketball games and other presentations, I was kind of tethered today, but I did not want to miss this opportunity to speak with you and just admire the work that you do together and the meeting that you've pulled together. I'm very proud of the work that's been done to elevate emergency medicine in Indian country, and I commend the ongoing efforts that continue. A few years ago, some of us, I did quote unquote grow up in the ED trauma room milieu, so very comfortable there. We began to focus deeply on the functioning of our EDs starting of course at our federal sites, and beginning with very straightforward looking at our standards of left without being seen, our throughput times, our patient flow. I looked at bed turnover rates, ratios of staff to patient, and of course I realized that we don't have enough beds, and of course we did not have enough staff. So that was almost pretty obvious, but not to just recognize that, but actually to start doing something about it. And we do have to have data. We have to have foundational information to start building what we want and what we need. So although I spent much of my career in EDs, trauma rooms, ICUs, and ORs, and thank you for the surgeon comment, I enjoyed that. And I have my own theory about surgeons, which we'll share at another time. I was very thankful for the new ED leadership, which has developed and strengthened immensely the ED programs in Indian country to where we are now. The ED ECHO program, this conference, the participation in multiple initiatives speaks to your dedication to providing the best emergency care services to our American Indian and Alaska Native people. We continue to excel looking at how we care for elders, how we prepare for the care of pediatric patients, and now the ALSO course to make sure that we're ready to deliver or provide obstetric care for those that don't make it to our regular L&D suites, or we don't have an L&D suite where we are. There's so many more initiatives I'd like to touch on today in response to our current challenges, but I'll keep it just to a short list today. As Sean will tell you, I'm very happy to discuss these when we have time at length, and we will be doing that moving forward. So let's start with behavioral health and substance use disorder patients. So what can we do about this? We all are very much aware that our EDs are too small. The flow is sometimes inhibited by waiting for transport, staffing issues, and still trying to improve our processes. So we know we get kind of backed up when we have people taking up beds that are really very much cared for, but don't have any place to go. So looking at the need, the exponential need for behavioral health and substance use disorder treatment that got much worse during COVID, we have to start thinking in an innovative way. So a couple of the things that we're looking at that I'm very interested in, I've been sharing this with tribal leadership groups, is looking at a 23-hour hold observation area. This would use very innovative and diverse staffing, which is one of my main priorities, is that we have to really diversify our staffing and find a way to fill in where we don't and will not have enough nurses. There's just going to be, unfortunately, a vast shortage for quite some time. And we have to still provide this care, and we're just pulling people in a million directions. So can we develop an innovative and diverse staffing? And I say yes. So with the advent of behavioral health aides, this is part of the CHAP program, or the new community health aid programs, that we are going to be looking immediately upon hiring a director of behavioral health aides to start educating, training, and certifying as many behavioral health aides as we can. And the purpose of that is to improve staffing. If they're become your sitters in the ED, if they're able to establish a 23-hour hold area, because we all know that over 90% of those that we think we need to send for inpatient will actually clear within 24 hours and do not have to be flown 6 to 8 hours away, where they can never get back home because they get sent down there, they don't even get admitted, and we're stuck trying to get them back. And I know that from working at GIMC. So can we have a observation area with a nurse available, but using our diverse staffing of BHAs to keep the, sitting with the patients, reassessing and doing their part to kind of help keep them safe, and then get them out of our acute ED beds so you can do your work. So we're going to be looking at piloting that in a couple of areas. My next initiative that I'd like to do, and this will take me a while, one, because I don't actually love traveling anymore, and two, because I just have to figure out a way to get to all these places. We want to really do an environmental scan. We know, or I know, that we don't use our beds effectively everywhere we are. I mean, at our bigger centers, we use our beds. They have good average daily bed usage, but there are several facilities across the agency that have 2 beds open out of 20, or 4 out of 12. And we have these empty beds sitting there that we're paying to staff, which we really kind of know we're not going to use. So when we do that scan, is there a possibility of converting any of these beds to these observation areas, to these short holds for either substance use disorders, alcohol use disorders, just to do the acute detoxification and or hold, and get them back home while they're still within the community. So we're going to be trying to do that. We're getting our list together of facilities that may have these kind of beds that are just really not being utilized. We want to also, while we do our behavioral health aids, is we're gonna, my goal is that, and I put this way in a call earlier this week, we're not Field of Dreams anymore. You build it and we'll come. We're more like, we need to go where the patients are. And I realize we're never going to get everybody we need to into our facilities. We don't have the access. We don't have the facilities that can handle it. And we do need to make sure everybody's getting the care they need to be healthy. So therefore, I have a big push to go out into the communities a lot more for doing some of the basic things like follow up and such that don't have to come into a facility. Along with that, and I don't want to get too granular here, is seeking reimbursement for our pharmacists, for our community health reps, our community health aides, our BHAs, is to actually have reimbursement for the work that they do, because that is distributing the load of what needs to be seen. And sure, it's more the low acuity things, of course, to be safe, but at least we're touching base, we're checking their blood pressure, we're doing the things we need to ensure some kind of health and wellness out in the community. We have our new life coach program. The first cohort will be done in early 2023. The second cohort will start, and then we'll deploy those into our communities to really work with people on the things that we need to do. So look for that. There'll be a lot more. I see them doing some basic screening, safety checks on those who were seen perhaps by you and sent with a safety plan. It's nice that we can touch base because we know what happens between those time periods, and just general follow-up and wellness in the mental health space. And then I'm really, the joke is I'm always looking at ads for 28-foot vans, which is very, very true. Not only for I actually want to get food out to the communities in these vans. There's some couple of really great programs around the country that I'm a little bit jealous of. So that's on my list. And of course, mobile health, we need more providers that are out in the communities, and some will really enjoy that, I'm sure. And then I'm going to be meeting with SAMHSA on developing some mobile crisis vans for response, because largely the 988 kind of ignored rural and what I call extreme rural areas, in that we don't have the resources suburban and urban areas have. So I'll be meeting with the principals from SAMHSA to look at ways that we might extend off of their mobile crisis van program for Indian country. Second on my list that is pertinent to you is holding patients for transfer. Again, that takes up room, it takes up your resources. Although you are all highly skilled in managing patients, managing critical care patients is a different milieu. And I know that because I worked the trauma room and then staffed a very large ICU the rest of the time and step down unit. And you do change paradigm slightly when you cross that imaginary threshold upstairs. There is a different cadence to that, and it doesn't really fit with the kind of work that you do in the ED, and you have many patients as you have to see and process through your EDs. So we want to find ways to strengthen that for you and help assist to make sure that we can find a way to have some protocols and guidelines for managing those that we can't get out. I'd love to say I can solve the standardizing to assist the actual transport, but we all have different needs for transport. So I'm trying to kind of wrap my brain around that for the entirety of Indian country, of what we can do to transport better. So that is more to come on that. Next would be rural ED support, hooking rural and extreme rural EDs with our tertiary hubs or our bigger facilities for that SME. Nothing's worse than being out in the middle of nowhere and feeling like you're all alone and having a case that, geez, nobody could figure out. And we've all had those. I mean, I've looked at traumas and thought, I'm not even sure where anything goes anymore on this patient. There's so much damage. And, you do have to do it, and we all do it. But when you're all there by yourself and you don't have all the resources and backup, it could be quite lonely. And I'm very, very acutely aware of the loneliness and isolation that is apparent in our very rural facilities. And I'm looking for ways to remedy that. So we want to be able to continue to share our training. I know you do great echoes and other sessions, but I want to make sure they're getting out all the way. And then maybe some peer review or peer interaction to really keep everybody honed. And we all know we came up through teaching programs. You know, I had occasion to be on a meeting that was very contentious the other day, and somebody said, you know, that was terrible. Are you okay? I said, I did surgical M&Ms for many years. That was nothing. So we kind of all know that we are our best critics. We're our best people to decide best practices and help each other. And I do say help each other, always be better. It's never a personal attack, and it shouldn't be, but we can really help each other just continue to be much better at what we do and more confident at what we do. And then we're looking at protocols for cases in these areas, especially our very rural areas. And that comes into our clinical pathway uh, initiative that Sean referred to. And then lastly, as I mentioned above, dealing with loss of L&D options. And man, this is happening everywhere. It's happening in private sector. It's happening in Indian country. A lot of L&Ds are shutting down. Nobody just wants that risk and responsibility anymore. So for things we're doing in conjunction with our maternal child health consultant, who's very good and is working very, very hard since she started with us, is the advanced life support obstetric training, is standardizing equipment, making sure everybody has everything they need to birth a baby, and then to monitor them until they can get where they need to go, and standardizing our training and protocols. So it's like ATLS for trauma, which you guys all know, is that if you do it the same way every time, you're very less likely to miss anything. And I do want to say that with great pride. It is something that surgeons did contribute to the system that I think has been very sustainable. And it has actually spilled over into STEMI alerts and stroke alerts as well, because they also learn having the same protocol, having people on call, having a staff ready has really improved their time to the cath lab and or interventional radiology. And then I did want to mention, because we have the new abortion laws that are just really kind of tearing us up across the country, in that they just keep changing every day. Every time we think we have our hands on it and we're good to go, somebody else has another court decision. And it is really quite frustrating. I just want to assure you, the IHS will exercise all aspects of our ability and flexibilities to provide for pregnant persons. The life of the mother and the baby will always be the most important to us. And that is what everyone should make their decision based on. I absolutely confirm the fear our providers have of prosecution and other issues. And all I can say, we will back you. We work very closely with DOJ to make sure that they are ready to support us if anything should come up. And please remember, we follow federal law, not state law. Met with PRC, we will be providing appropriate transport as needed for any mothers that need emergency services. And I want you to know, if you hadn't noticed, because I know you're very busy, we replaced the circular SGM, and we have actually formally requested the rescinding of the legislative laws, and which were outdated, that we were working under, to give us maximum flexibility under the Hyde Amendment rules. So that, just know that we're up on that, and we're working very hard behind the scenes. So a little bit about my philosophy, which Sean alluded to. My philosophy is nothing about me without me. And this is what I said to multiple agencies the other day. Please do not make decisions for us in Indian country without speaking to us. That is certainly true of our patients. We want to be patient-centered, and we need to let them tell their story, not the story we'd like them to tell us. And I know you don't have a lot of time in the ED, but I also know you're very skilled. And I think that connection to a patient can happen very quickly. And that bond that occurs does really help the care, and it helps you feel very connected to what you're doing as well. So I also want to say nothing to all of you without your input. This is creating a challenging matrix of communications for me, but I'm really hell-bent, and I'll just use that word, hell-bent, on knowing that I've been on the ground level. When headquarters used to tell me things, I was like, what are they talking about? I don't think they understand. Well, I don't want to be that person at headquarters. So I understand that we must work on what really happens in the field and create inclusive and sustainable initiatives and programs. From the 80-hour work week that we started way back when I was at GIMC and finally brought to fruition, and hopefully will be rolling further out across the agency, to our increased OB readiness and our rural ED support. You are the experts. You have skin in the game. You need to tell me how this can work, and work for you every day. In that regard, I am going to be calling an awful lot of big meetings. I know it's hard to kind of have a brainstorming session when we're on a Zoom, but that is the only way I can connect with all of you all at one time. And we will be getting together and working on some of these initiatives with feedback, suggestions, innovations from each of you. So I hope you'll join us when we send out the invitations. We will send out the minutes though to everyone. And this will be done for primary care, for the ED. We're going to be looking at credentialing and privileging. We're going to be looking at privileging and standardization of core privileges with all of you giving expertise to this. And I do rely very heavily on my chief clinical consultants. They are amazing group. We do meet every quarter, and we will continue to work on some of these initiatives together. I'm going to just shift gears for the last 5 minutes or so and talk a little bit about moral injury, which I know was alluded to by the prior speakers. So I just maybe want to bring that home a little bit. It is a distressing psychological, behavioral, social, and sometimes spiritual aftermath of exposure to such events as COVID, as a mass casualty event. Moral injury can occur in response to witnessing behaviors that go against our values and moral beliefs. The stress of COVID was far reaching. We lost family, friends, and colleagues to COVID-19 itself and an aftermath of COVID, which created deep pain in all of us. At many times, resources were not enough. Thankfully, we didn't have to get to pure allocation type protocols. We were close. We did variations of it when we didn't have enough resources, and we had to make difficult decisions related literally to life and death. Maybe it's time for a lack of a bed for a transfer. Maybe we didn't have ICU care, whatever, testing kits, whatever it was, it becomes very unjustifiable to us to have to treat one and not another. There's a great deal of overlap, I want to say to you, after a long career in trauma, over 25, 30,000 trauma patients, between moral injury and PTSD. And we never really thought of PTSD in healthcare. We looked at it in military for sure, and in some of our law enforcement. Did we ever really sit down and go, hey, healthcare workers have PTSD? And no, not till very recently. It can show you in hyperarousal, a fear of experiencing the same stressor when going to work and going, I can't do this another day. But having a moral injury in addition to PTSD results in higher risk of depression symptom severity and greater likelihood of suicidal intent and behaviors. Key issues must be discussed. We are the doctors, we are the leaders, and we feel the need to be strong and not show weakness, sadness, vulnerability. But we must break those boundaries. I could tell you, after a very long career in treating the most injured patients, those in extreme pain with their lives so rudely disrupted, we absorb cellular memory of that stress, of sharing those experiences with patients and families and our staff. And a quick example is we had a very bad case one day, CPR in progress, from a trauma who was very late in pregnancy. And we did a very fast C-section in the trauma room while doing CPR on the mother. And, you know, we were very, we honestly felt good that we got the C-section done and we got the baby out and got the baby to NICU. And then I took a moment to turn around and I just looked at the frozen faces of all the other staff in the room who doesn't do what we do. And it just stuck with me. I mean, we do this, this is our living, we're trained to do this, but what about everybody else who doesn't? What was the impact to that X-ray tech, to the respiratory therapist? And it's profound. And that is that cellular memory of that moment of stress and trauma. So we can't become desensitized, and we have to remove that stigma of admitting depression, burnout, and sadness. We have to ask the hard questions. Are you okay? Are you thinking about hurting yourself? Do you have a plan for suicide? We can't forget we're human. We feel more deeply than most of us will admit, at least out loud. We are vulnerable too. And we must take care of each other and ask those hard questions. I was very, very struck by an interview from the parents of some elite athletes that committed suicide in the last year, like 5 of them. Division I superstar athletes, great students. And the one comment from the parents is, we We tracked our child, we touched base frequently, but the one question we never asked is, are you going to suicide? And they regret that they did not take that conversation one step further. So I'm going to wrap up now. I think most of us have some element of PTSD, hard to admit, but I think it's very true. We can't ignore that. It is difficult to find ways to address burnout, especially in the government. I agree with you on that, because I think every day, what can I do to support you out in the field? We're always continuously on the first line. COVID didn't hardly give us a break at all. I know there were months I worked 7 days a week, and it just never ended. But we need to find better support and ways to help each other. I want to tell you, it is a sign of strength, not weakness, to admit you need help. You need time to process, time to enjoy your life. So speak up, take care of each other, and understand you need time to heal. I do not want to mourn another colleague, but instead I want to celebrate that we care for each other every day and we keep each other safe. So I'm going to end with this. To the heart in you, don't be afraid to feel. To the sun in you, don't be afraid to shine. To the love in you, don't be afraid to heal. To the ocean in you, don't be afraid to rage. And to the silence in you, don't be afraid to break it and reach out. So with that, it's again my pleasure to be with you. I look forward to having some town halls with you, and we'll see what great work we can do. Please enjoy the rest of this fantastic conference, and thank you so much for the invitation.
Dr. C, thank you so much for the insightful, detailed, and powerful presentation. For those who work for the IHS, who is happy that that's your chief medical officer, your chief physician in your agency? As I said at the outset, and then she really brought it home, she's one of us. She knows her way around a clinical setting. She's been there, and what I can tell you, and Paul, you'll see this, and I hope that you all will amplify this, she's got our back. She's got your back. She's incredibly accessible. She is the chief physician for a very large federal agency, and she's there for you. So I'm happy for all of you. I'm happy for our patients that she's our chief physician. And thank you again, Dr. C. Not sure if you can hear this, but thanks for joining us, and good luck with the basketball games. I'm very happy to turn it over to our friend and colleague, Dr. Safia Rubai from GIMC, to present our next speaker.
Hi, good morning, everybody. I'm super excited. It's my honor to introduce Ms. Jennifer Nanez as our distinguished speaker this morning. Jennifer Nanez, MSW, licensed social worker, master's in social work, currently serves as a senior program therapist with the University of New Mexico, Division of Community Behavioral Health, and the Department of Psychiatry and Behavioral Sciences. She is an enrolled member of the Pueblo of Acoma, New Mexico. She's a daughter, a sister, an auntie, and a mother to 2 young Indigenous matriarchs in training. Ms. Nanez has been in the social work and education fields for over 25 years, with experience working across tribal, urban Indian, federal, and university systems, all with an emphasis in serving our Indigenous population. She worked closely as a research coordinator with Dr. Maria Yellow Horse Braveheart. Ms. Nanez's interests lie in suicide prevention, mental health treatment support, and working within a healing from historical trauma framework. Within this framework, Ms. Nanez works to promote effective community engagement in clinical practice while emphasizing cultural resilience, connection to tradition, and Indigenous-based knowledge and healing in our Indigenous communities. Jennifer, thank you so much for coming to be our distinguished speaker.
Hi, Gwazi kay tawahapa. Shiname at yak kuch in hanu shita Americano wash di shita My name is Jennifer Nanez. I'm really excited to be here and nervous this morning to be here with you. I'm a social worker in the field, as was introduced earlier. And to be in a room full of emergency medicine folks is always nerve-wracking, period. But also to be in this space with you, because social workers, we tend to see things along the systems basis. That's our way of learning, way we've been taught. And today I was asked to come and speak in part for Maria Yellowhorse Braveheart. And in our discussions though, in prepping, came into this discussion about, well, let's move it into a little bit different. Instead of just talking about historical trauma, talking about this concept of cultural safety. So I hope you will bear with me as we move through this as best as possible this morning. I'm really blessed to be here at the base of Cepina, which is one of our sacred mountains for our community, our pueblo in the Pueblo of Acoma. And again, please feel free to reach out to me after if you've had questions today. So again, I really want to thank you all for being with us here in this space, this high stress environment. And I really wanted to just add really quickly too, as a former IHS employee, and I will say that I'm a former IHS employee, I'm really thrilled to see Dr. Christensen in that role. In her comments earlier about everything that you all have been through, we all have been through, our tribal communities, our relatives, our families, our children have been through over the course of COVID. It's very valid. And having the chance to have worked with her in the past, at least in the Albuquerque area side, I'm just thrilled to see her in that role here nationally to support everyone here in this room, but also, again, hopefully bring that vision forward for all of Indian Health Service as a whole. We know again too that she referenced that stress that you all have endured over the course of this past year. And so we want to extend our thank you to you, as community members for the support that you've given us over this past few years with COVID. And as we continue to move through COVID, COVID has not ended. And we know that we're still seeing losses within our communities on almost a daily basis still. And so your continued efforts and support are very much appreciated by all of us within our communities. And as again, Dr. Christensen said, please continue to also care for yourself. You can't continue to care for us if you don't care for yourself and have that picture full for yourself. So please, again, know that we thank you for your work, especially in these environments that we all exist within with limited resources. And we're going to talk a little bit about that in the course of this morning, as again, quickly as possible, when we talk a little bit about equity and how equity, of course, impacts the service provision that we see in our communities. So I wanted to start off just really quickly with this, because when we were first talking about what are we going to speak on for this presentation, and I brought cultural safety forward, we wanted to differentiate it from the culture of safety in healthcare. And just a reminder that, when we think about our service delivery in the healthcare system, that this culture of safety is still fairly new, that we've been working on improvements in service delivery, and that Institute for Health Improvement really has been the core piece that we follow in IHS and other service programs, health programs, to support this culture of safety in healthcare, how we provide service provision, how we learn, how that just culture is created within our systems, how we're accountable, and how our leadership supports that. And of course, looking at process improvement in QI. But this presentation is not about culture of safety. I wanted to just really quickly bring that forward, because we're going to talk about how this ties into cultural safety, but differentiate really quickly between, again, the culture of safety. So hold that in your head for the moment, okay? Just to touch base really quickly on this, though, one of the things I wanted to highlight was when the original white paper was developed about this culture of safety and in healthcare improvement, one of the key pieces that was in the original white paper was this statement here: that again, all of these pieces are important in developing that culture of safety, but we're also to recognize that safety in healthcare is more than the absence of harm. It's also the pursuit of dignity, right, in service provision and equity in that healthcare. And this is where we really can begin to examine this concept of cultural safety that we're going to bring forward here. So I just wanted to touch too really briefly again on our Indigenous worldview of healthcare. A reminder that it is again based for us in this relationship, this collective well-being, this generational look at our healthcare overall. It's based in our families. We look at it again in the process of we, not in I, and that it's in our tradition, it's in our ceremony, it's in our practices. And that again, we look at also our tie to our land and our environment because our health is reflected in that. Our care is reflected by the care for our lands and in our environment. And this is also what's been interrupted, of course, by colonization, this history that we've had over the course of time and continue to deal with. And when we see this, this is where we start to deviate in our overall health. So just really quickly, again, what we know too from all of the traumas and all of the experience that we've experienced is that those healthcare disparities out there are real. We have had them well documented, well known for a number of years, and these are just a few examples. Rates of depression, rates of, again, illness and chronic disease, rates of things like obesity, again, cancers, diabetes, HIV, drug use. We are, again, the highest, again, climbing population right now in HIV new infections, and same for opioid overdose deaths. Those are, again, very concerning in the work that we do within our communities. And our children, too, are also impacted now. This is not just happening for us as adults as we grow older. We're already starting to see, again, impact within our children. So let's talk a little bit about this role of trauma, and more specifically of historical trauma. Historical trauma to me has been, again, very dear and near to my heart, in part because when I was originally coming through as a student, this was the first time it was like the light bulb went off for me about things that were happening in my own community, things that were happening even within my own family system, things that were happening within our tribes as a whole. So historical trauma, of course, is defined as that cumulative emotional and psychological wounding over the lifespan and across generations from massive group trauma. And of course, for our populations, we know that that has been in existence. Here in the Southwest in particular, we've come through over 500 years of that, again, process happening to our communities, being imposed in our communities. But Dr. Braveheart, in developing this theory of historical trauma, also went on to talk a little bit about trauma response, and what she also phrases as historical trauma response, that we can see that reflected in behaviors, illness, risk behaviors that we may take on, internalizing behaviors, externalizing behaviors. And so that begins to also play a role in our overall health. So we think about what do those traumas look like, and they've been, again, multiple over the course of our 500 years, especially here in our communities. From that early entry of colonization through this region, the Pueblo of Zuni was the first contacted for our Pueblo communities by the Spanish government. We've gone through 3 different governmental systems, and we're currently in the 3rd right now. And we don't know if there'll be a 4th, but it's possible at this point. And again, all of these histories of trauma that we've experienced for our population as a whole, it may be, again, that era of boarding school that still has impact for us. I'm a 4th generation boarding school alumni. My youngest brother is the first in our immediate family to be raised at home fully through his childhood and adolescence in 4 generations. It can be these, again, histories of sterilization and systems that have been, again, not supportive of our overall healthcare. And unfortunately, we know that this has been a hallmark of some of the programs and services and agencies that we have worked with and continue to work with. Our advocacy, again, for our land and our environment, not just for us, but for everybody, has often been met, again, also with trauma. And so these are examples of not only historical trauma, but we have to remember that we have these present day traumas that we're continuing to deal with. So just really quickly again on the cycle of historical trauma, this is what we begin to see is that when we are dealing with trauma and trauma response creates these reactions, coping mechanisms. It may lead to increased risk factors, behaviors that put us at risk to traumatize ourselves and others. Then we therefore create new traumas within our communities and within our family systems. So trauma can beget trauma. And for those of us who are working out there in the field, we're tackling that top end right here of that iceberg, essentially. We're seeing it in healthcare. We're seeing it in suicide. We're seeing it in violence within our communities. But in truth, it's based in this deep history that we're still working to heal from, still working to move through. And this is why this concept of cultural safety in healthcare in particular becomes important, because it's going to start looking at this context. I want to also make a note too that in more recent critiques of historical trauma and historical trauma theory is that it doesn't necessarily go far enough to talk about, again, the chronic and pervasive traumas that we experience and the oppression that we experience as part of our communities, and especially for populations of color. And so in this particular slide, McKinley and colleagues talk a little bit about this in the theory of historical oppression. And what they put forward is that we have to think of not only historical trauma, but historical and current and contemporary oppression that continues to, again, play a role in our overall health, our overall communities, and our traumas within our communities. So again, we have multitudes of things that we're dealing with, including challenges to our tribal sovereignty. And you can see that happening right now all the way up to the Supreme Court level. There's plenty of cases right now that are pending that are on our radar, in part because they're going to challenge our sovereignty in very sticky situations that may put tribes in. We're dealing with, again, our populations being, again, missing, murdered, disappearing from our communities without justice within the systems. And again, that being another big trauma within our communities. Mental health, of course, and I'm a mental health provider. And mental health, again, is one of the key issues that we've seen grow as part of COVID. But overall, it's not been given the due that it has been needing over the generations. Mental health is health. Mental health is health. In Indigenous way of being, we never separated it. And we'll make that point here because we treated the whole person. And so please think about how your roles and your current roles and positions, how do you incorporate that mental health piece in healthcare, in assessment and in treatment? All of these traumas, again, that we're dealing with, violence against children, land loss, all of the environmental injustices that we continue to experience are part of those ongoing oppressions, part of those ongoing traumas, and they all impact our health. So you're probably familiar with what this concept is of trauma-informed care. We're not going to go over all of the principles of trauma-informed care, but essentially all it is saying is that in any system that we're working within, in any interaction that we're having, assume that that person has had some trauma. And in assuming that they have some trauma, our goal is to seek to not re-traumatize. And in trauma-informed care, it also looks at the system approach as well. How is our system-based in operating to not recreate those traumas, not re-trigger those traumas, not re-traumatize again, those individuals coming into our space. So trauma-informed care is something, of course, that's been pushed out there for a long time now through SAMHSA and other agencies, and really looking at our systems of care overall. Historical trauma-informed care, though, is now starting to pull these things together, talk about what is the context, though, of the population that I'm serving. And I heard that mentioned yesterday, thinking about the concept, thinking about the context, what has happened for this community, what has been the history of this program's interaction with this population. So again, take for instance, the Indian Health Service. What has been the history of working within the Indian Health Service in tribal populations, and how has it been viewed? And I'm keeping that in mind. What is my interaction going to convey? How do I begin to change that view? So historical trauma-informed care really takes a look at that and brings that closer. So this is where we're gonna now start talking a little bit about this concept of cultural safety, in part because it's beginning to pull all of these pieces together. And again, from a systems framework, when we as social workers, we tend to look at the macro, the meso, and the micro. And this is really looking at it from that macro level, that big systems approach. Because we can work on the individual, but we also need to start looking at the structures, right? So we're going to move here now with this component. So with cultural safety, this was developed by a Maori nurse, Ramsden, in the late 80s. And I loved her original paper on this in part because she writes, Maori people no longer accept that our world is a perspective on the reality of anyone else. We have our own whole viable, legitimate reality. We are not a perspective, meaning your view of us is not real. Our view, our experience is valid, and it's important, and it's true. And what she goes on to say is this leads to the question of choices in service delivery, examining that system of service delivery there in their community. The data on Maori mortality and morbidity and empirical experience has made it quite clear. The health service is not and has never been culturally safe for Maori people. The service has been designed, not been designed to fit the people. The people have been required to fit the service. Okay. And I hope that rings something for you, in part because it's very much true. Our healthcare systems have not necessarily been developed from an Indigenous lens, right? That Indigenous worldview that we put out there earlier about how we view healthcare is not how Western medicine works. And this is the system that we're forced to pull from for our medical care, our healthcare, our ongoing care. And it hasn't been designed to fit us, but we are forced to fit within this system. So we're all familiar with these steps, right? You've heard, of course, over the course of time, if you've been working through healthcare over multiple years like myself, you've heard first maybe of cultural awareness. If you're new to working with populations of color, you've heard about cultural sensitivity. For a long time, there was a big push towards cultural competence, even in my field, talking about how are we culturally competent as service providers. And then now what we also hear is cultural humility. That again, effort to create that evaluation of ourselves, our own biases, our own worldviews. How does that relate to the patient in front of me? What's that power differential that we may have? How do I seek to reduce that power differential? And a great example yesterday was that servant pose that was part of the presentation in the late afternoon. How do we get on level with our patient, correct? And that is something that we've been looking at and really, again, supporting across provider systems is really looking at cultural humility. But we want to take it one step further because cultural safety encompasses that, but it begins to look not only at that patient to provider interaction, but it's looking at our overall structure, our overall system, and it moves it into action. So cultural safety, the definition really is a concept based on respectful engagement that recognizes and strives to address power imbalances inherent in the healthcare system, because there are power imbalances. We're coming to you in our most vulnerable moments, right? We're coming to you when we don't feel good. We're coming to you oftentimes in crisis. And again, it's a system that hasn't been developed for us in mind, but we're still having to seek care there. And safety in this framework of cultural safety, it's defined by us, not by you, not by the system, by us as those who are receiving that care. It encompasses that cultural humility, but takes on those historical timelines, those histories, those inequities, the injustice. And it is actively and inherently anti-racist in its approach. And it takes on an active social justice and health justice stance. And coming from, again, my background as a social worker and social justice, that just completely rings, again, wonderful bells for me, because it is moving it into action. It's looking at it from a systemic level. And it seeks to transfer that power to the patient. We become partners in our care. So just again, really quickly, this is what it entails. It's looking at cultural humility. It's making sure we're, again, developing our cultural knowledge of our communities that we're serving. It's thinking about that history and those timelines and the context. But it's also understanding that it's contemporary, it's changing, it's ever moving. And this is where we're beginning to, again, move beyond just that individual provider perspective. How am I, again, serving the population? But how are we as a system providing service to the population as a whole? So let's talk a little bit about health equity here, because we're going to take a segue just for a moment. You all are probably familiar with all of the great little graphics out there about health equity. Again, what does equity versus equality look like? And in reality, what we're starting out with. And there's been movement, even with this graphic, to change it to reflect, we need to look at this a little bit differently. Not only are we still, again, trying to remove and get to a space where we all have equity and access, but are we removing the barriers there for that service delivery, moving into a space of, as this graphic puts it, liberation. And when we talk about equity, we have to remember that, unfortunately, equity is baked in. It's baked into our systems. And as a tribal provider, so just really quickly, I've worked in contracting and compacting from a tribal level before. I've worked on the Indian Health Service side. I've been in the table where I'm pointing the finger and saying, IHS, you don't do enough of this, or federal government, you don't do enough of this. And then on the other side, as the federal government saying, wait a minute, but we've got limitations. And it's in part because they do get baked in. So this is a great example here when we talk about expenditures, and this is from 2017, so not too old. And you can see expenditure per person. The Indian Health Service system, for an example, is way behind. And recently, everyone was hailing, of course, that, we're getting more money putting to our systems. We're at $9 billion in terms of a budget for the overall Indian healthcare system. I just want to make a quick plug, because back in 2010, there was a tribal tribal work group that was based on the budget formulations. And at that time, to phase into 100% of funding by 2020, the budget in 2020 for the Indian Health Service system should have been $21 billion. We're at 2022, we're probably at the expenditure level of the Bureau of Prisons back in 2015. So it gets baked in. This inequity in this position that we're putting for the lack of resources is baked into these systems. We got to think about that when we advocate. So why does this matter to you all in emergency medicine too? One of the things too that we see is that in your programs, in your service delivery, you have limited resources. Here in this study, there's 40 EDs, both IHS and tribal nationwide. That's not a lot. In fact, they're dropping daily. I'm from the Pueblo of Acoma. We lost our emergency department in the middle of COVID. I don't know if you're aware of that. So we're one less within our community from that number in that time frame. And 85% of EDs had 24-hour coverage, and only 13% of those were board certified emergency physicians available within those departments. And what was interesting is that Indian Health Service, local hospital and emergency medicine governing bodies to ensure that these providers are capable of delivering high quality evidence-based ED care would have to be more improved revenue for our systems, more money. And it's not coming. I just want to say that very blatantly out there. It's not coming. If we're barely getting to other federal levels of spending for our health services, and a reminder that for Tribal 638s, their funding comes from IHS. And if IHS is funded at 60% of need, so are tribal programs. And so for us to improve this care, that revenue is not going to happen. But we can begin to look at and examine how our systems, we can advocate, how we can provide care for our populations overall. And when we think about health equity and COVID again, COVID really highlighted those inequities. And I always loved that the news was covering it. Oh my gosh, the natives are most impacted. Well, of course, because we've been dealing with these inequities for a long time. And this was another great, again, find when we're talking about research in this area, that COVID is a pandemic, it's an endemic, but it's a syndemic for us in that it has traveled along this route with these inequities, and it has been exacerbated by those, right? So our populations have been inordinately impacted by inequities, and this is a good example. Navajo Nation in 2022, in one of the richest countries in the world, the leading country truly in the world, we still have tribal homes without running water, without electricity, without paved roads at times, and even food access, food deserts for our communities. And again, we talked about that inequity being baked in, right? This is an example of that, because we have the resources, but it's not being directed to those who most need it. Our children were also impacted exponentially by COVID in our tribal communities. 1 in 168 American Indian children lost a parent or a caregiver to COVID in the past 2 years. New Mexico and Arizona, New Mexico's #1, Arizona's #3 in parent and caregiver loss. And in New Mexico alone, 39% of all the children at the end of 2021, we're already halfway through 2022, 39% of those children that lost parent or caregiver in New Mexico were American Indian. We only make up 10% of the population there. And so let's talk about that again as trauma. because again, we know traumas can beget trauma. We've created trauma. COVID created trauma. But COVID created these traumas in part because these inequities. COVID created these traumas in part because we haven't had these systems of care that have been fully supported. And then two, we have to look at those health justice, health equity issues as part of this. Again, disproportionately impacted by COVID cases, hospitalizations, and deaths. They continue to this day. I lost several family members in our community, in my overall family system to COVID over the course of this time. And we know what those long-term impacts look like for our families. So, phew, take a breath here. There's a lot of information. And I want to help you tie it together, okay? Because as we're talking about all of these issues, talking about all of these processes, frameworks, where we begin to center this is oftentimes we look at trauma-informed care, okay? How do we provide that service provision in a trauma-informed framework? How do we look at working in collaboration with our patient versus working on? And trauma-informed care does see care in the context and the impact of that trauma. Historical trauma-informed care, again, also examines it, but it's also looking at that population history and those current traumas, again, that we're experiencing, because we are experiencing them because of this history, because of these frameworks. Cultural safety really, though, when we think about it, is this underpinning of it all, because it's looking at it from a systemic level. It's looking at it from the structures. It's looking from it from that basis of how do we change these systems to fit the people? How do we create a system that fits the people, not make the people fit our system? So I heard Dr. Christensen earlier to say this, nothing without us, nothing for us without us. This is exactly what we're getting at. So beyond, again, looking at equity and equality and even liberation, we need inclusion. We need inclusion at the table. And in the system development and examination of service delivery that's happening, include our populations in that discussion. Include us in how you're developing those processes. Include us in how we're developing those service delivery portions. Even in the emergency room, it can happen. So again, why does this matter in emergency medicine? Well, we know bias happens, unfortunately. In one of the largest scoping reviews of emergency services across the US and Canada, there was a 28-year scoping review of all articles that were developed out there and looking at emergency medicine. And again, working with populations of color. And again, looking at those, they analyzed triage, wait times, pain management, diagnosis, treatment, leaving without being seen or leaving against medical advice, and what the perspective of patient experience was. And just to summarize, you can take a look at this. I won't read them all for you. There's a ton of information out there. But in part, what it really says is that we see bias happening. We see it happening within emergency services. Whether we like to admit it or not, it's out there. And it goes back to these histories. It goes back to these systems. It goes back to these structures that happen, and it happens in this micro level in that service delivery. And why does that matter? Why does that matter? It's in part because when we come to you during this time frame of our most vulnerable moments, we want to be heard, we want to be respected, we want to be accepted, we want to be supported. We We don't want to be judged, especially for the reason we may be there. We want to be able to be a partner in our health in that moment. We want to be, again, in a space of regaining health. And we want to share with you what brought us there. We want to share with you what's worked and what hasn't, to be honest about that. Because when there's culturally safe care, both in that individual relationship, and we know that the system will support us, the structure will support us, we're more likely to be successful in our care, more likely to engage in our care, more likely to stay and talk with you and follow through with your recommendation. And therefore, on the flip side, we reduce risk, mortality, and morbidity and trauma in our community. Want to be a partner in our care. So cultural safety, just really quickly, we're behind in this. The United States is behind. And that was what was really interesting, is in reading up on all of this, this idea since its inception in 1989 has really expanded globally. And the US is like, what? What? We're just getting to trauma-informed care. We're just figuring that out. But if we turn to our relatives, there's lots of information out there on how do we implement cultural safety as, again, the basis for our healthcare systems. So again, developed by Maori, it's been adopted in Australia, in Aboriginal and Torres Strait Islander healthcare systems. In British Columbia, Canada, there's overall commitments to cultural safety as part of the overall healthcare system. In the United Kingdom even, they have a whole framework developed that begins to look at cultural safety in all aspects of service delivery. And there's plenty of research information about how does this look even in the emergency department. So again, for example, Dell and Firestone and colleagues take a look at how do they address cultural safety in emergency department care. They have 4 primary overarching recommendations. The Canadian Association of Emergency Physicians has 16 recommendations on how they incorporate that into the emergency department. Here's just a quick look at that. I won't again review them all with you. And then even a quality improvement component. How many of you have had to do QI studies, the PDSAs? I used to be on the mock survey accreditation team for area office, and we were constantly hearing about QI and PDSAs. There is, again, a way to look at it, and it's been done in several instances, and this is an example of one as recently as 2019. Again, in this one was in Australia, I believe. So to bring it really back quickly here, just to give you again that framework. So the culture of safety is that service delivery change. What are we doing right there in that service delivery? Historical trauma, trauma-informed systems is the system change, looking again at the context of our care, where we're coming in. What is this population and their experience that we're working with? And then cultural safety, again, is looking at that again, in coming from us, working with us, including us in the overall structure. Moving that, again, power relationship to us as the patient, to us as the population, and how we, again, seek to do that, and how we create that structural change. So how can you contribute? It's an open question for you all to consider. How can you contribute to culturally safe care for our Indigenous populations here? How do you include us? How do you ask us, what are our needs? How do you bring us to the table when you're creating processes, when you're doing your reviews, when you're looking at your quality improvement processes? Include us in those as patients, as populations. Don't forget, don't keep it solely internal. Involve us in that. And we can advocate, again, begin to advocate for social, racial, and economic justice. Meet with your local tribal leaders, of course, super basic, just meet with folks, get out there. I loved yesterday's presentation, it's the only one I got to see, but it's bringing that healthcare system out to the people, right? We're coming out to the people rather than saying, come visit me here. You have to wait and come see me here. Bring it out to the people, get out into your community. Really quickly, I wanted to just add, having been on all areas, I remember my frustration in trying to get our docs to come over and talk with our community members. Because when the docs came out to the community, health improvements happened. We saw it within our community. We know our system, though, as an Indian health service system, isn't always supportive of that. And our docs quickly got pulled back and said, nope, you can only see them 8 to 4:30 within this framework. And those are the systems that we're talking about. And I'm really glad, again, that Dr. Christensen is in that role that she's in, because maybe we can start seeing that change. If she's supporting that ability to go out and engage at community level, then we might begin to see the startings of a culturally safe Indian health service system. Support full funding. We have, the US has the resources. We shouldn't be sitting at the Bureau of Prisons budget from 10 years ago and be happy about it. We have the ability to meet the need. And it's because they're failing to meet that need that these inequities get baked in. So we need to address the need. So I want to thank you again for allowing me to be here today. I know this was lots of things to pull together, lots of thought processes, but there's lots of information out there for you, lots of wonderful references. Again, the majority outside of the United States, because we're very new to this concept here within our population, but you can find lots of information, and in part because it has been specifically developed around Indigenous Aboriginal populations. That's why this is such a neat concept for us to consider within our framework here. There is resources too, even in toolkits available to consider this, and even in emergency care too. So please take a look at these. The folks here have the slide deck for you to reference. All of those links up there should be live. You can click on them or easily find them and in PubMed or otherwise. And so please feel free to, again, take a look at that. And I want to thank you again for your attention to me as a social worker. I came here as a lowly social worker, in part because I really want to be a part of systems change, influence systems change, because this is what we need, and to bring it back into our population, in our worldview, in our lens, so our people can continue and can move forward in health. That 7 generations approach, we're in that phase now. Where do we turn that tide? Because we can, but we need your help. We need your help. Really, one last note. When we were having this conversation about prepping for this, there was a discussion about, well, you know, do we recruit more American Indian physicians, emergency med docs? Of course. But right now, emergency med docs and American Indian physicians overall, there's only about 3% nationally, right, that are Indigenous, and not necessarily all in tribal communities. So we need you. We need you to think about this, because it is going to take us a while to get to that stage where we are doing for us, by us. So until that time, please be a partner with us in that, and we'll be a partner in our care with you. Thank you, Dawae. Thank you very much.
Thank you so much, Ms. Jennifer Nanez. We really appreciate you coming out and dragging your family and kids out here across northern New Mexico to come here. And I can say from everyone in the room, first of all, we're not all emergency medicine physicians, but how many people here value social workers? My mom was a social worker. You're a highly esteemed member of our team. Thank you so much.
Jennifer, Ms. Nanez, thank you very much for that. I feel like that's a challenge for all of us to continue to start to implement this. And I think one of the positive things is I feel like when we talked about working inside the system versus outside, I think inside the system, we're at the point that we're ready to do this, like to see if we can move things up and shift the narrative. So thank you for bringing that this morning. We're going to take a 10-minute break, and then we'll come back. Before people go, though, just like last night, there was an informal gathering. Tonight, there is another informal gathering for people who are still staying in town. There is a Picking in the Pines Bluegrass Festival, and the shows this evening. Dean, what time do they start? So there are two other shows. One will start at 6, one starts at 8. You can get tickets for both of them together. We have a special opportunity to do that. It's $35. Is that correct? But it's a special opportunity, so we need to pick them up by noon today. So if you'd like to be included, Dean, can you stand up for a sec? Yeah, so just find Dean like maybe during this break, and let him know so that he can get your name and figure out how to Venmo him money. And then we would love to have people join so that we can celebrate the conclusion of the conference. So 10-minute break, and then we'll come back here. Thanks.
Hey, everyone, we're going to get started just in a couple minutes here, but going to give away some more free stuff from the Brigham. Couple of housekeeping items. So you notice that there's not a lot of paperwork at the conference. That was a very deliberate decision. We're trying to minimize the environmental impacts of this conference. So you use the QR code to get to the program. That was very intentional. And these name tags, these magnetic name tags, we'd like to recover them at the end. If you'd like to keep the part that has your name on it, feel free to remove that. But as you leave the conference today, please go ahead and drop off the plastic piece so that it can be reused. And you can drop those off at the desk with Jaylani and Cass out front. So before we go to the next speaker, who you're introducing, right? Are you introducing the next speaker? I don't know this guy. Some more free stuff, some trivia. I'm going to move around so that Chelsea feels comfortable moving around when he speaks. Okay, so here's a question. Last year, emergency medicine lost one of its elder statespeople to cancer. This individual founded a new subspecialty of emergency medicine at the time. And that in his obituary in the New York Times, he describes early formative experiences of working with the IHS in Montana and seeing challenges that happen to people when they are in remote settings as an early experience that led him to found what has become a popular subspecialty of emergency medicine. What's the specialty and who was the physician? I see a hand up in the back. It is, and it's a free water bottle for you. Commemorative edition, yes. Dr. Auerbach got his start after med school and residency, I think at Duke in the mid-70s, working in the IHS system where he saw things he never saw in residency, like a lot of us encounter when we're working in remote areas, such as lightning strike, environmental exposure, envenomations. things that those of you who practice in that environment are not unfamiliar with. And with that, so let's see, John, you just connect with Cass and Jay and tell them you're getting a water bottle. More trivia to come, and I'm going to hand it over to Dom again, who's going to introduce our next speaker.
Hi, guys. So the next speaker really doesn't need an introduction because if you've been in the IHS at all, you've leaned on him for advice about EMS issues, essentially all EMS issues. But Chelsea White, so he's a ER physician at UNM. He's also a paramedic. He's the director of the UNM Center for Rural and Tribal EMS. He's also the EMS director for numerous EMS agencies in the Southwest. I was a former EMS director at Tuba City, and I just leaned on him heavily for essentially just went to him and said, what am I supposed to do? So essentially he's our region's expert. He's essentially our local IHS expert. And if you went through COVID at all, you realize that this is a fundamental problem, interfacility transports, EMS in general, because the issues that we've had with transferring patients and finding the capacity to do so. So I'm going to turn over the mic here. Thank you so much for being here.
Thank you. Oh, that's loud. Thank you very much for the kind introduction. Ya'ate abene. Goate hopa. Thank you. Really excited to be here. And I really mean that. I look out across this room and I see the full-size faces of a lot of people that I've only seen in little squares on Zooms for the past couple of years. And only a few of you have I actually seen in person over the past few years. And it's so exciting to be here with so many truly like-minded individuals all working towards the same goal for the same people. And that's really inspiring. And I really appreciate all the hard work that went into making this conference. Really already can't wait for next year. So thank you again. So as Don mentioned, I'm the director for the UNM Center for Rural and Tribal EMS. And so what is that? So that is a center within the Department of Emergency Medicine at University of New Mexico. And our mission is to support and advance the field of out-of-hospital medicine in rural, frontier, and tribal settings through education, innovation, research, policy, and medical direction. And our center consists of two core EMS physicians. That's me and my wife, Jenna, who unfortunately couldn't be here, as well as a couple of other EMS physicians in our group that do spend a fair amount of time with rural and tribal EMS issues, as well as one EMS fellow. He's there in the back. He made it back into the room just in time. Peter Overton Harris. And one EMS nurse practitioner paramedic and one EMS physician assistant. And we cover multiple rural, frontier, and tribal EMS agencies in New Mexico, Arizona, and the National Park Service. We also work closely with the UNM EMS Academy to creatively address rural EMS education needs. And through our work in the rural and tribal EMS setting, we've really had the privilege and opportunity to interact with many rural and tribal patients in their own homes. So not really in the emergency departments, although of course we do in our regular ER work, but really had the good fortune to work with patients in their own homes in situ with the local governments, tribal governments, et cetera. So who here has had trouble transferring patients out of their hospitals to receiving hospitals? Okay, so there's a few of you, huh? Now, there's a lot of parts to that transfer process and all of those problems, right? And I certainly can't I can't help with all of those. I can help a little bit with the EMS side, and you know I think that really what I'm here to talk about today is the part after the receiving hospital has agreed to accept the patient. And just getting to that point is a major stretch right now. Still, especially in the post-COVID era. That was surprising to me. That continues to be surprising. But if you raised your hand, and I did see a lot of hands raised, this presentation is for you. But it's also a call for you to take an active role in the solution to the paucity of EMS interfacility transport resources in rural areas. And like we've heard already throughout this conference exists because no one is coming to help solve our problems. The problem solvers are in this room. You are the solution instigators for all of the issues that we're talking about. So this is an important slide. EMS and local hospitals are a team that must work together to treat patients from point of injury or illness to definitive care. Now, bigger hospitals, big city EMS agencies, the ambulance and fire truck you saw come out to the hotel this morning when we were coming back from getting coffee. You know, big metro areas can afford to have EMS and hospital medicine in separate silos or worlds. But small hospitals in rural areas absolutely must work side by side with their EMS agencies to get patients to where they need to go. And even though the funding for the hospital and for EMS may come from completely different sources, maybe you're an IHS hospital and it's a 638 EMS agency, and even though they may belong to completely different governmental or even private entities, for all practical purposes, small rural hospitals and EMS agencies form a health system that is or should be focused on the community and the mutual patients of the hospital and the EMS agency. And that's something that's very important. Now, we all know that EMS stands for Emergency Medical Service. I want to break these three letters down in a way that hopefully gets you to look at your hospital and at EMS a little bit differently, and will help work with your local EMS agencies to better serve and better advocate for your patients. So E is for emergency. So something like this probably comes to mind when you think of when you think of EMS. It's Navajo Med 42 out in Hajole, New Mexico. Really need that siren right there. Look at all that traffic. Look at all that traffic. So if you talk with a lot of fire chiefs or EMS supervisors or managers, you'll hear a lot that EMS is for emergencies, for scene calls, for readiness for the next call. And in the case of combination fire and EMS departments, that next call may be a fire, right? So we're talking about emergencies. So EMS agencies are really built around readiness for the next emergency. But what defines emergency? So sure, a motor vehicle crash, heart attack, trouble breathing, those are easy answers, right? All of those define emergency. But what about that super sick patient in the small emergency department that desperately needs to be transported to a larger hospital elsewhere? I mean, isn't that an emergency? That is absolutely an emergency. And so, of course, the answer to that question is yes. And what we really need to do, and so this is the E of EMS in this situation, we really need to redefine the rural EMS paradigm from 911 versus interfacility transport to 911 and interfacility transport, because they're all emergencies in some way or another. But we have to do it with patient acuity-based triage. So it's no longer, oh, scene call versus IFT. It's who is the sickest. And this is definitely a paradigm shift for EMS agencies, because depending on patient acuity, it may actually be best for the only available ambulance crew in town to take a sick patient out of the emergency department. And I'm sure that you have plenty of examples of that, and I can sure tell you about some too. Conversely, a less critical patient may appropriately have to wait in the local ED for EMS resources and more coverage to come available. It's all acuity based. Regardless, though, that means that local hospitals and that's you, right? Must work with EMS agencies together to balance the competing priorities of maintaining availability for emergency calls in your communities with emergent and non-emergent interfacility transport needs. And this needs to be in the moment on a case-by-case basis, and by developing guidelines for operational planning to guide future case-by-case decisions. This is a lot of talking back and forth about redefining that paradigm. Now, part of the problem though is that especially in rural areas, and this is actually whether tribal or non-tribal, is that EMS is funded for emergencies, but is it funded for that classical definition of emergencies for scene calls? It's not really funded for interfacility transports. And it's really rare that IHS or municipal EMS funding covers the costs of both 911 and IFT services for a single agency. And often if funding exists at all, it's really split into two separate pots, sometimes in two different budgets entirely, sometimes completely different funding streams that really need to be combined. And that makes it difficult for a single EMS agency to pay for personnel and equipment and all the things to cover the additional call volume represented by interfacility transports over, of course, the 911 coverage. But the EMS equipment and personnel can be the same. And a crew transporting a 911 patient into the hospital can just as easily take an IFT patient out, right? It's the same, and vice versa. And so funding a single agency to do both, especially in a small area where you don't need that much, as far as personnel and equipment, and triaging calls and patients according to patient acuity is really the best use of the resources at hand, particularly with personnel and equipment. All right, so we got through E. So M is for medical, right? Emergency medical services. The problem with a lot of the words and phrases used to discuss the transfer of patients is that they focus on the movement of patients and not the care of patients. Yes, patients must be moved from point A to point B, but they must be treated and cared for between point A and point B. And if you remember from algebra, that's from point A to point B by time t. And there's a lot of very long time t's in this room, right? A lot. And rural hospitals and EMS agencies must view and support interfacility transports, and there's that movement word again, as medicine, as patient care in the continuum of care and not just transportation. And that's what the M in EMS stands for, medical. EMS clinicians are going to be caring for your patients sometimes for many hours after they've left your emergency department, and the level and quality of care they provide is extremely relevant to you and as the sending provider. And that's something that's important to know, because different kinds of EMS clinicians provide different levels of care based on their levels of licensure. Now, you'll note they're just New Mexico patches here. I know there are different states in the room. The reason for this is New Mexico has the most beautiful EMS patch in the union. And I am proud to now have that paramedic patch for 10 years here, almost as long as I had a Michigan paramedic license. Michigan does not even have a paramedic patch. So anybody from Michigan in the room? There we go. Afraid. But anyway, it's important to know the capabilities of the crew that you have. And if the patient's needs or reasonably expected needs exceed the capabilities of the transport crew, hospital staff and EMS staff must work together to figure out the best way to transfer that patient, whether it means having hospital staff ride along, calling an air ambulance, etc. Long-term, local hospitals and EMS agencies must work together to advocate for more advanced training and equipment for EMS personnel to better care for the needs of the patients being transported to those more distant receiving hospitals. Of course, though, those additional capabilities should be available for 911 calls too, meaning that everyone benefits. And so finally, S is for service, but it also should be for system, because again, the local hospital and local EMS agencies form a de facto health system. And really, you got to plan to grow the system and improve its capabilities together. Jointly advocating in meetings like this one, doesn't look very exciting, Very important. Jointly advocating for more EMS personnel, more training for EMS personnel, like I mentioned in the prior slides. That's just a start. Jointly advocating for in-hospital improvements is critical too. One example facing one of my EMS agencies in its local hospital. The local hospital has a CT scanner, but doesn't have sufficient personnel to staff it all the time. So that results in a lot of wait in return transfers to a more distant hospital just to get a CT scan, even though a CT scanner exists in the local hospital. So how can the hospital and the EMS agency advocate together for the resources to have more consistent radiology staffing? That helps the patient. That helps the next patient. It helps reduce the need for interfacility transports entirely. So working together, pooling resources, pooling contacts to jointly approach area IHS, tribal government, other sources, maybe even state resources, depending on the situation, are important approaches to help solve issues that separately may be much more challenging to solve. So think to yourself, what issues are facing your hospital and EMS agency, and how can you work together to solve them, especially by thinking outside the box. So in summary, this is not the last slide. Summary is usually a cue that it's the last slide. It's not the last slide. It's a summary to what I'm trying to say. Just didn't want to get you too excited. In summary, it doesn't really matter whether this ambulance in this picture is going to a hospital or is leaving a hospital. What matters is that the hospital and the EMS agency are working together for the best interest of the patient inside. Rural agencies and hospitals must cover ambulance calls wherever they originate, whether they're on scene or in the emergency department. Local hospitals must see EMS as medical care and not just transportation, and must understand the capabilities and limitation of their EMS crews. And both local hospitals and EMS agencies must work together on their working relationship, their health system, and their efforts to advocate for the resources necessary to continuously improve all of the above. So what I ask each of you is I ask you to go back to your health system and view it as such. View it as a health system. Sit down with your EMS manager or EMS supervisor or fire chief and open the dialogue, because some of the things that I have said here are going to be foreign to your EMS agency. You really need to start talking about how you can collectively work to improve your system for 911, for interfacility transport, and for in-hospital care. And you need to help share that vision with your hospital and with your EMS agency. Partnership is key, and your leadership in the process is crucial. Now, just incidentally, of course, whenever you write a presentation, something earlier in the conference comes up and you think about something else. Incidentally, I'm talking about environmental poisoning. Just to the left of this frame here is the remains of the Jack Pile mine, which was at once the largest uranium mine in the world, near Powhatan Village in Laguna Pueblo. And two of the Laguna Fire Rescue EMTs from Powhatan Village are currently being treated for cancer. Those are anecdotes. It's not data. It's not proof of causation, but two anecdotes that are personally very near and dear to me. So environmental poisoning is obviously a big issue at all levels. Really quickly, there are many other potential areas of EMS and EM collaboration, and hopefully you can use today's topic as a segue for other partnerships between medicine on the inside and medicine on the outside of the hospital. This is Pueblo of Laguna community paramedic patient number 1, the one in the middle, with Fern and Tony, the community paramedics from Laguna Fire Rescue. And this is actually, this is a favorite picture of mine. I mean, obviously that's how it made the presentation. But this is actually a results picture from the community paramedicine program, as this patient was completely homebound and non-ambulatory before she became Fern and Tony's first chronic wound care patient. This was absolutely used with permission. I've used it many times. It was actually published in an article that on the program in the Journal of Emergency Medical Services, and she and her family were huge proponents of this program. And just a little bit more about that program. The Laguna Community Care Team actually is an example of a multidisciplinary collaboration between EMS and CHRs. And now that Laguna has opened its own 638 clinic, the clinic medical staff as well. So EMS providers, the EMS providers in your EMS agency can be that missing link in emergency care, in hospital and in clinic care and everyday life of your more medically fragile patients. And this is truly one of my most treasured photos when my daughter accompanied me and Tony and Fern, of course, on a community paramedic home visit. And it's with mixed emotions that I mentioned that this patient passed away in December of 2020. But it's mixed because obviously we were very close with her. But because of the chronic wound care that Tony and Fern gave her, she was actually healthy enough to get out of the house and go to Walmart and catch COVID. So it's, I think we really did improve the quality of her life, and she remains an inspiration to us in our program. And we definitely miss her very much. And just incidentally, that blue lion in the picture came home with us that day and remains an A-list stuffy in our household. And the parents in the audience will understand. One more quick point. This really is the last one. I'm really looking forward to Mark Newcomb's presentation this afternoon about Indigenous emergency care in Australia. And listen to that carefully, because in many ways, and especially with rural and Indigenous EMS, examples from Australia and other similar countries are much more relevant to the U.S. Indigenous EM and EMS space than urban U.S. examples. This picture is of me and my colleague Libby Melton. She's the EMS nurse practitioner who unfortunately couldn't come to the conference, with St. John Ambulance Northern Territory Supervisor Andrew Naden in Alice Springs, Northern Territory in 2019, right before COVID. I'll be going back in 2 weeks for the Developing EM Conference in Darwin. I'm really looking forward to that, and looking forward to bringing back some additional rural and Indigenous EMS knowledge from that trip. So, ayehe, dawae. Thank you very much for your time and attention. I'm happy to answer questions at any point, although I think we probably have to go on to the next presentation now. So thank you very much.
Okay, I think we're live. Good. So yeah, we were actually gonna Dr. White is the MRIC representative going to the Developing EM Conference in Australia. So huge deal, intercollaboration across countries. And that is the kind of the framework, the future framework of EMS and paramedicine. So again, I approach these clinical topics and organizing these essentially just by soliciting EM physicians on the front line and saying, hey, what do you want to hear about? And one of those topics was, again, another kind of underrepresented clinical education topic, which is ophthalmology for us, right? You see eye patients every day, all day, and also like kind of fairly frequently you go, okay, not exactly my perfect art here. Like show me a subtle STEMI and I got you, right? But when it comes to the eye, frequently people are like, okay. But that's kind of the goal here. So Dr. Melvin Clark, he's actually been 10 years at Phoenix Indian Medical Center. So it's always exciting to have our own resident experts. He has 30 years of clinical experience. Initially was in from the Kansas City area, spent 10 years as the director of eye care services at Kaiser Kansas City, and was also a professor of ophthalmology at the University of Missouri School of Medicine. This next 10, I love the career just breaks down in 10-year increments. The next 10 years he spent up working in the private sector for the Mayo Health System in Minnesota. And the last 10 years he's been with us at Phoenix Indian Medical Center. So he's going to speak to us about ophthalmology case reviews. So thank you, sir. want to walk, you can walk.
I'll probably stand to hide my COVID pounds.
There, yeah, exactly. There you go. And this is forward. If you just click that, it goes forward.
Okay.
Yep, go back to that question. So
Click
you're
the
in
top one
charge.
and it goes forward.
Right there.
Oh, the one where the thumb.
Right side. Yep.
Okay, perfect.
Yep.
Okay. Well, let me tell you a little bit about myself before we get into this. I'm from Kansas City originally. My dad was a pediatrician. He came to the US from Cuba. He was Cuban and Jamaican. I came from a family of 13. And my first day in medical school, my dad says to me, go meet the ophthalmologist. And I didn't know what I wanted to do at that point. A couple years in, he says, you really need to go meet the ophthalmologist. And I remember what I said to him at that time, which was, that's not real medicine. Yeah. And a couple of years later, I did do a rotation and I hated it. Thought it was the worst thing in the world. And my dad was persistent. He taught me into it, and I'm glad I stayed. But the reason I mention that is I understand where I was at that point and how I thought about ophthalmology. And I know when everybody's busy in the emergency room, you really don't think much about us until you kind of need us, right? And more often than not, it's usually after hours or after your local optometrist has gone home and you're trying to figure out what to do with this patient. Working in Kansas City at a teaching hospital, you get some different experiences, but you have access to a lot of different things. And we do a few things differently. We always taught our residents, if you saw somebody with a corneal ulcer, you saw them every day, you had to do bacterial cultures. Well, I found that once I went into private practice and working both at Mayo and here, those bacterial cultures are unreliable. And so more often than not, you end up starting them on antibiotics before you do any cultures. And then if the antibiotics don't work, then you do the culture and you know what doesn't work. So that being said, when I thought about putting this together for you guys, I thought, what's the most common things that we run into and the most common calls that we get? And you're fortunate because I was on call for a week before I came here, and some things are kind of fresh in my mind that may not necessarily be on the slide. So we'll touch base with those a little bit later. So practical approaches to the things that you see in the emergency room. So this is my goal for this presentation for you, okay? The chief of my department gave a similar talk and she had all of this information and she said, oh, look at my slides. You might want to use some of them. And I looked at this thing and I thought, oh, this is terrible. Yeah. She mentioned that when she gave her talk, only one person in the front was paying attention. So I'm going to try to avoid putting myself in that same situation. And so I'm going to hopefully get you to take away a couple of key points for some of the more common things that you see, especially before you call us, because we tend to ask the same questions of you guys every time you call us. So we're going to review some of these common problems, discuss some of the management that and the diagnoses that you can do in the emergency room, and then discuss the most important one, when to call us or when to send them to us. Now, I used to say for years that one of the reasons we go into ophthalmology is there are very few ophthalmic emergencies. And for the most part, this is what we're usually taught. Now, we can probably add one or two other things on there, like an acute swollen eye or acute proptosis. But for the most part, this is what the ophthalmologist is thinking of as an emergency to call us. This, however, is the most common reasons why people present to an emergency room. And we've all seen these going down the list, and we'll touch on most of these. Red eyes are probably the most common that people roll through the emergency room. Certainly blurry vision, sudden loss of vision, double vision, foreign body sensation, pain, of course, ocular trauma, and swollen eyelids. One of the most basic things that they always teach us in medical school is you got to get a good history. And I think most of the time when I get calls from an emergency room, they have a very limited history on what they offer up. Usually the call starts out something like, hey, I got this patient and
they said they can't see anything and they're, you know, and then they keep talking and I always stop them. So what's the vision? How long has this been going on? And they always, usually the response is, I don't know, hold on, let me check the chart, right? You know, for us, that's like, yeah, when you call the internist, he wants to know what the blood pressure and the heart rate is. So we always want to know what the vision is because that helps guide us on how soon we need to come in and see that patient. But the onset of the symptoms, whether it's one eye or both eyes, certainly pain, the fourth one down, itching, doesn't seem like a big deal, but that's actually pretty huge for us because that's probably the one thing that emergency providers tend to forget to ask a lot of times when they call us about patients with a red eye or a swollen eye. They never mention the itching part until we ask. Certain visual disturbances and of course contact lens wearers. Now, let's talk about the red eye a bit, since it is probably the most common reason why people show up. Conjunctivitis is probably one of the most common. And usually you guys manage those very, very well for the most part. Occasionally, you have to break it down into whether it's an allergic cause, whether it's a viral or a bacterial cause. With the allergic, sometimes that's secondary to after they've already started with a viral or a bacterial infection, then they've tried to self-treat. And so it's always good to know what the patient's been using in their eye, you know, before you call us, because we'll be confused and think the redness may be related to an allergic reaction to one of their topical medications versus a possible viral infection. I put allergies at the top because that goes back to the itching. If you have somebody who's got a red eye and itching is the #1 complaint, that's an allergic problem. That's not an infectious problem, unless they have, as I said, been using drops over the counter for a while, and that's good to know. Viral, very common. Duration of the redness is important when looking at a viral infection. You also want to be sure you check for lymph nodes. That's one of the things that people tend to forget. An allergy is not going to have palpable preauricular or submandibular nodes. So you always want to check for that. Even though it's not viral, chlamydia is something also that'll look like a viral infection, but they'll give you a history that it's been redness that's been going on for several weeks. Bacterial is usually pretty easy to identify. The eye is red and there's usually a mucopurulent drainage that goes along with it. And usually we treat that, of course, with topical antibiotics. Foreign body, the most basic thing certainly is a conjunctival or a corneal foreign body. We should also include underneath that corneal ulcers, because that oftentimes feels like there's a foreign body in the eye. The conjunctiva is easy to recognize. Usually you can flick that out yourself or you can flush it out of the eye. What people tend to forget is to flip the eyelid and look underneath the eyelid for something that might be hidden underneath. Corneal foreign bodies, everybody's got a different approach to managing those. I have found that I've never had a problem with an emergency provider trying to flick out a foreign body in the cornea or something they tend to get a little more uncomfortable if it's a central lesion or a central foreign body. But for me, it's usually not a reason to necessarily call us in after hours. Usually I have people take those out as best they can, and there's going to be some inflammation in those eyes. And one of the most common things that people forget is you need to cycloplegic that eye and they'll feel more comfortable. You don't necessarily need to give them pain medications other than Tylenol or Motrin or something along that lines. But if you cycloplegic the eye, they're going to feel comfortable. Usually I recommend, if you can't get it out, use a lubricating ointment, erythromycin, something along that lines, cycloplegic the eye and have the patient see us early in the morning. And that's a lot easier and it softens up that foreign body for us. So it comes out usually with a quick flick once we see them. I'm not a big fan personally of ophthalmic burrs. I know some emergency rooms have them. Most people are afraid to use them for good reason, because once that thing starts running and it gets close to their eye, they move and now we've got a track along the surface of the eye. I use usually a 30 gauge needle or 27 gauge needle, and I can usually flick something out without the collateral damage from using the ophthalmic burr. The two at the top, episcleritis and scleritis, oftentimes forgotten. You're going to know if you see a scleritis patient because they're going to have a lot of pain. And more often than not, that patient is going to have a history of a connective tissue disorder, rheumatoid arthritis. And that's a pretty serious problem if you see one of those. Episcleritis, usually blanch with a little phenylephrine. If you place it in the eye, the vessels will constrict and that redness will go away. That will not happen with a scleritis. Usually we treat an episcleritis topically with some mild topical steroids or just lubricate the eye, and it usually is self-limited and it'll go away. Eyelid inflammation, I don't normally put that on there, but this is one of the reasons we see a lot. A couple of times a month, we'll get a call from usually our own emergency department. Somebody will come in and they'll have a swollen eyelid, and usually they lead with, hey, this patient's got an orbital cellulitis. And I think most people don't really know the distinction between a preseptal cellulitis and an orbital cellulitis. And we'll touch briefly on that here. But with the eyelid inflammation, the simple things are blepharitis, which gets overlooked, inflammation around the eyelashes, which is fairly common. I would suspect 80% of the people in this room have some form of blepharitis. But it does bring people in. Usually they will have some itching that goes along with it. The hordeolum or sty, that is a fairly common problem, and most emergency rooms figure it out pretty well. Occasionally somebody will send us one of those that they think might have a developing orbital cellulitis, but that is just only in the eyelid. Now, briefly, talking about an orbital cellulitis versus a preseptal cellulitis, just keep in mind that if the orbit is involved, not only will you have CAT scan evidence of involvement, that eye's going to be in pain. They're going to probably have an elevated white count, and they may be febrile when it happens. We always ask the question when we get a call, if somebody has they say, oh, they've got orbital cellulitis, we want to know what's going on with the pupil. And usually the response is, well, the eyelid's too swollen, we really can't get a good look. The other is, we want to know what the movement of that eye is, because you can have a very swollen lid, but the septum will keep everything forward, and that eye should be able to move just fine. Orbital cellulitis is an emergency. They usually require significant amounts of IV antibiotics. Usually there's going to be a source, more often coming from a sinus or something locally. Preseptal cellulitis is fairly common. It actually occurs around hordeolums and chalazions. Usually that's not really an emergency. We can usually treat that the next day. Iritis. In our population, before I came to work with the IHS, HLA-B27, I probably saw that 1 out of every, 40 or 50 patients who showed up with iritis. And here, I'd say, 7 out of 10, 8 out of 10 will give you a history that they're HLA-B27 positive. They will usually have had an episode in the past. And one of the most important things to take away from this, because an ophthalmologist, you'll talk to us at night about this patient, and usually we'll want you to start them on steroids or something, or we'll want you to dilate the eye. With an iritis, the faster you hit that with steroids, the faster it's going to go away, and there's less damage long-term. The problem is a lot of our patients sit on it for a while before they come in, or they may have an old bottle of prednisolone sitting around and they'll use it for a day or two, and then they come in. And we end up chasing our tail trying to treat proteins that have leaked versus treating white blood cells. So it's important to certainly get a good history on those, but to start treating them with steroids immediately. More often than not, I don't use oral steroids unless there's a hypopion. But usually hitting them with Durezol or prednisolone, I have them use it every 15 minutes for the first hour. So When they call me from the emergency room, I tell them to start that and be sure they have a cycloplegic agent. Don't give it to the patient because they tend to not show back up. But cycloplegium with cyclopentolate, put a Maxitrol ointment or a steroid ointment in the eye, and then they can follow up with your optometrist or ophthalmologist the next day. Acute glaucoma, that's not what most of our patients have, but acute glaucoma, we're looking at angle closure glaucoma and neovascular glaucoma. Neovascular is fairly common in our population. When I started it in this business, it was one of the scarier problems for ophthalmologists because we had to stick needles in the eye to try to break it. Most of the medications don't work because the pressure's too high. And usually you had to try to do a laser, a retinal laser treatment to try to get the pressure down, but that was slow and they would just get more damage before it ever became effective. Now we have the anti-veg therapy with Avastin and Lucentis and Eylea, which will make those vessels go away quickly. I've seen patients get an injection and the vessels are gone in 24 hours. That's how fast it'll work. And it makes it a lot easier to treat those patients. I recently had a call from the emergency room about a patient who came in with a pressure of 59 as a 40-year-old guy, pressure of 59 in one eye and 20 in the other. And said, yeah, his vision's a little fuzzy. Vision was about 20/30, I think, in that eye and 20/20 in the other. And he thought the cornea looked clear. Now, normally with a pressure of 59, the cornea is going to take on fluid. It's going to get cloudy. You're going to see the patient's going to look like they're looking through water. And so for this particular patient, it was going to take me 20 minutes to get to the emergency room, but I wanted him to start medication because it was a presumptive diagnosis of angle closure glaucoma. He looked at the pupil and he thought the pupil didn't work. And so I had him start the patient on acetazolamide because usually once you get around 59 or 60, patients start throwing up and it becomes a problem for us to try to get anything in them to get their pressure down. Most eye drops that we use to lower the intraocular pressure do not work when the pressure gets that high because they can't get into the eye. So that's why we like acetazolamide. This is a pretty young crowd, but we used to use Osmoglen, which was like syrup, and they get a couple of shots down and they throw it all back up. And that was never much fun. The other was mannitol, which is even a little bit before my time. But ophthalmologists in general, we don't like to create cardiovascular problems, so we don't really use that one anymore. The foreign body is pretty easy to remove. Well, for me, it's pretty easy to remove. But the main thing I tell people is sometimes take a Q-tip, even if you can't really flip the eyelid. Maybe the eyelid's a little swollen for a couple of days. Put a little Alkane, proparacaine, tetracaine in that eye or put it on a Q-tip. And then you can actually sweep underneath the eyelid to be sure there's nothing there. Most of the foreign bodies that I see are usually welders or somebody that's grinding something, and usually they're wearing glasses. And what ends up happening is something deposits on their eyebrow or their eyelashes, and it works its way into the eye. And then, of course, it embeds itself, and then they end up calling us. But being sure you sweep underneath. That holds true also for chemical injuries, because particulate matter, we've had a few of those in the last year where particulate matter, you'll flush an eye for a couple of hours trying to get the pH down, and there's still a little particle or something that's underneath that eyelid. So being sure you look underneath the lid. Core and 40 bodies, most of that's pretty straightforward. I think most of you guys know that, so we won't really talk about that very much. Conjunctivitis. I briefly talked about that. Bacterial cultures. I haven't met a lab anywhere where anybody does this right. And so I kind of quit doing it. I don't really, I just treat it now. And if it doesn't work, then maybe I'll try in the early morning hours and I'll walk it over to the lab myself to be sure that it gets done. But for the most part, most of our, the antivirals, some of that's pretty straightforward. I don't think that's too complicated for an emergency room crowd. Subconch hemorrhages, the most important thing from that is I can imagine why somebody would wait for hours in an emergency room without any pain or any blurry vision from a subconch hemorrhage. but occasionally they do show up and they're blurry because their eye is dry because you have this bump on the surface of their eye. And when they blink, they're not flushing their tears across the surface of the eye real well. And so usually they don't have any staining of the cornea, but usually lubricating those patients is all you need to do. And then you can get them out of the emergency room and have them follow up with us in the next day or two if it doesn't go away. Main thing is avoid the over-the-counter meds. I can't tell you how often I've seen people who, oh, that's just a subconscious hemorrhage. Let's give them, an antibiotic. And then it doesn't work after a couple of days and they go see their local optometrist and he puts them on something else. And hey, this eye is staying red. And then they end up with us and they get confused when we tell them don't take anything. Yeah, but usually that's all it needs and it goes away. I talked a little bit about episcleritis and scleritis. Iritis, probably the most common thing I get called about after hours. And as I said, these patients are going to come in, they're going to be light sensitive. More often than not, they're going to have a history of having had it before. They're going to be uncomfortable and the vision's going to be blurry in these patients. Not necessarily because of the white blood cells, but usually the proteins and things that are floating around in their eyes. So they're looking through a cloudy space. Treatment, of course, slit lamp. This is no knock on the ED providers, but I think 1 out of 10 usually can tell me what they're looking at when they look at it through a slit lamp. So, and that's okay because they've got other things going on. But usually we want to know about, the redness, is it ciliary body or ciliary injection, the smaller vessels on the outside of the eye. We want to, because we're ophthalmologists, we don't like to have to come in if we don't have to. So normally we're going to tell you to cycloplease that eye. Again, when I tend to avoid atropine unless I've seen that patient, but I think it's okay to start them on cyclopentolate and get them in to see us within the next, 12 hours or so. That we're going to be much more comfortable. Once you dilate these eyes, they're so much more comfortable. You don't really need to give them any pain medications for this. Dexamethasone ointment, people forget when you use steroids on a regular basis. If they want to sleep that night, you have to give them a steroid ointment and be sure you put that in the eye. And of course, follow up. I'm being generous with the 12 hours. Usually I tell people to be at the clinic when it opens at 7:30 in the morning. We can skip that. This one's a little bit important, the sudden loss of vision or blurry vision. In our patient population, more often than not, it's going to be because they're a diabetic and they've had a diabetic hemorrhage is the reason why. They'll say they're seeing pink or red, and that's not basically what I'm talking about here. I'm talking about the more permanent vision threatening, life threatening type of problems that you run into with an acute vision loss. Temporal arteritis is a big one, of course. And those patients, if they aren't treated fairly quickly, they can actually go blind in the other eye. And the thing to keep in mind with a temporal arteritis patient is they're usually tender along their temporal artery. So if you palpate, they'll tell you that. They may have a little jaw claudication, but their vision's going to suddenly go, and we have to get them on steroids as quickly as possible. Any problem that requires a high dose of steroids, I usually like people to get started even if I'm on my way there, because the longer you wait to get them on those steroids, the more of a problem you're going to have long term. Other sudden causes of visual loss, not up there on the slide, optic neuritis. I don't see that nearly as much in our population as I saw when I was in the Midwest, but optic neuritis, they'll certainly come in more often than not. They tend to be female, tend to be in their 30s, 40s, 50s, usually being comfortable using a direct ophthalmoscope. How many of you guys use on a direct ophthalmoscope? Do they still give those out or make you use them? And yeah. See, I still use mine, and I'm kind of a dinosaur in our clinic because all of our optometrists, they say, "Oh, we've seen that before." They don't use it. I find that I can always see the optic nerve with my direct ophthalmoscope, even with a very small pupil. And it's going to give you a size so that you can tell whether it's bulging or not. And certainly that's important with optic neuritis, retrobulbar neuritis. Certainly distinguishing swelling in one optic nerve versus swelling in both optic nerves is important. These are things that, you know, I don't want to insult the ED because you guys already have figured this out. Usually you've already ordered a CT scan before you call us, which is a good thing, because we hate to wait after we get there and there's no CT scan. But usually that's going to require a spinal tap, which we're obviously not going to do. So we usually coordinate the care of these patients, usually with a neurologist or a primary care provider, usually our hospitalist. Retinal detachments are really not quite so sudden. Usually the patient will think there's something hanging down, and then all of a sudden when the macula gets involved, they'll tend to notice it, but that's usually not right away. But retinal vascular occlusion, retinal artery occlusions, check the carotids. I stopped checking carotids about, I don't know, 15 years ago, because I don't think the ophthalmologist should be pushing around in somebody's potentially occludable carotid. But usually be sure you check that or use an ultrasound to check that for somebody with a change. Unfortunately, even though that's an eye emergency, the problem is most of those patients, when it happens, they sit at home for a little bit, then they show up in an emergency room where they sit for a little bit, then they're seen, and then we come in to see them. And usually with the retinal artery occlusion, you have about 60 minutes to get rid of the occlusion if you're going to save the vision in that eye. And so unfortunately, by the time they come in, it's already a little bit late. But on rare occasions, somebody who might be working in the hospital will have this problem. And usually what we do is we lower the pressure in the eye by sticking a needle in the eye and removing some fluid or putting them on some acetazolamide, something to help that clot move further along once you lower the pressure. This is not a permanent loss of vision. Some of this is probably better for a resident. On the one at the top, myositis. I was in Parker doing a clinic about a month ago, and we got a patient from UCLA who came in who had swelling. The optometrist told me, hey, I got this call from this patient who's transferring over because of their insurance. They have what do they call it? Pseudotumor is what he says to me. And I was on my way out for my long drive back to Phoenix. And so I hung around, and then I found out it wasn't pseudotumor. It was actually a problem called inflammatory orbital pseudotumor. And I hadn't seen one of those in about 20 years, but inflammatory orbital pseudotumor may mimic an orbital cellulitis. And it's acute swelling that occurs usually around the muscles in the orbit. And the treatment's different. You're not treating orbital cellulitis with solumedrol or prednisone, but inflammatory orbital pseudotumor, you do. You don't give them antibiotics, you hit them hard with a steroid and it goes away in less than 24, 48 hours. But being able to distinguish that, you want to look for, there's usually not an elevated white count with an inflammatory orbital pseudotumor. Yeah, touch briefly on that. Let's go on. Diabetes, as I said, is probably the most common reason why people have vision loss and have double vision in our patient population. Usually when I see these patients from the emergency room, you guys already ordered a CT scan. If they have pain associated with their double vision, you need to be sure you pay attention to the cavernous sinus, because that's where you're going to tend to get the third and fourth nerve fairly close together. And sometimes our radiologists don't take good enough cuts through there to identify where the swelling is. But most of our patients with double vision, it's usually self-limited and it's usually related to their diabetes, and usually the pupil is spared. You guys don't usually call us, usually the call is, hey, I just want to bounce this off of you. That's how it always starts. Yeah, just bounce this off of you. And so the patient's got double vision, and usually we say, oh, it's probably diabetes. And if the CT scan was negative, we'll just see him, in the clinic to reassure him. You guys have easy access to your neurologist? See, we don't. So the ophthalmologist sometimes ends up doing a lot of the stuff that we would with the neurologist. So the hospitalist is my friend. Bell's palsy, you guys see those, usually manage those pretty straightforward, and you get them in to see it. So we really don't need to spend a whole lot of time on that. I think I just talked a bit about that. I got a little ahead of myself there. One of our young docs came on board about 2 years ago, and one of the first patients he saw was a guy who had some industrial cleaner or something that was in these pellets, and he got some splashed up in his eye, and he came in, and it was a nightmare. Something had happened with our flushing station in the ED, so they couldn't flush the eye, and I think he went through like 40 lactated ringers trying to flush him out of this guy's eye. And then everybody was running around trying to find some pH paper because they wanted to know, hey, this guy is no longer a basic solution that's in his eye. And we learned that day that they do have pH paper that goes in 0.2 increments. You just have to order it and find it. We didn't have any in the eye clinic that wasn't expired. They didn't have any in the emergency room. And so he ended up using some strips used by the urologist. So I guess they were the strips that you normally dip in urine to check. And he spent hours irrigating that eye, hours. And in my experience, that's the first time I'd ever seen a patient who showed up, granted it was 6 o'clock, but it had showed up in the eye clinic that hadn't already been irrigated in the emergency room. And certainly having the pH paper helps. I always want that pH to be less than 8. We did a little research after that, and it turns out, depending on how dry a patient's eye is, your pH actually goes up and down. So you can actually be slightly basic to begin with. So you don't want to be chasing your tail because it's 8. The only difference on the strip is 8 and 7, right? And then you're wasting all that fluid. That patient did fine. I think we saw him for several days, and we kept saying, "Oh, he's still basic. He's still basic," but he was fine. His vision was fine, and so normally with you want to be sure that if it's a basic chemical, remember the wider the eye is, the worse the situation is, because usually it's melted through the blood vessels on the surface of the eye, and that's a problem. Usually I worry less about acidic injuries. Usually just irrigate and treat them for the symptoms of this, and usually not causing any permanent vision changes for a patient. I jotted when I was sitting over there listening, I thought, what's a couple of things that we always want when you guys call us? We always want you to be sure you've checked the vision, certainly the pupils if you can. Now, we'll say this, that even in our own clinic, our techs aren't that great at checking pupils. And now that I'm over 50, I find it's harder for me to check the pupils unless it's obvious also. So I won't fault you for not being able to tell me what the pupils are. Just tell me whether it works or not. That's probably the most important thing. The eye pressure. It's a lot easier now that we have devices like eye care instead of do you guys know what a Shiatz tonometer is? Is there anybody in this room? Oh, okay, good. Yeah, I didn't think they used those anymore because the tono pen tended to replace that. And then we now have eye care where you don't really have to touch the eye, and it's a lot easier. I think we supplied our emergency room with one, and then they went and bought their own. But the pressure is important for us to know. The extraocular movements, only important when you have the swelling in the lid or you think they might have an orbital cellulitis, as far as I'm concerned, or if they have a sudden diplopia. And finally, a slit lamp, if you got it. I'm amazed by the number of times our own emergency room has called about a patient, and you say, hey, is there any staining on the cornea? But we can't find the Woods lamp. Or it's, we don't know where our slit lamp is. But I think it's so weird that, a facility our size, our emergency room doesn't have a slit lamp that they can look through. But certainly that helps us a lot. A couple other minor things for you guys. Just remember the same thing I always tell my residents, and I would tell them this when they were studying for their boards. I said, you're going to flunk if the patient goes blind or you kill them. So the main thing is just to remember, when you see these patients in the emergency room, ask yourself, is this something that they're going to go blind from? And that'll help guide you in how soon you need to call to get us in. We love the calls that say, hey, we just want to be sure somebody's going to be available to see this patient tomorrow, because that means we don't have to come in. But again, ask yourself, is this something that the patient can go blind from? And that's usually an inflammatory problem or a vascular problem like we talked about earlier. Most diabetic problems, if it's a fresh hemorrhage, nothing's going to happen that night. One quick true story, one thing that's not on my bio is I had a National Health Service scholarship and I owed the government 2 years of service. So I had a year and a half, 2-year spot. That's how I found PIMC. I came in January of 2001. And I had been in the private sector for 10 years at that point. And I got a call from our ED about a guy, a one-eyed guy who had had a gunshot wound, had lost an eye when he was younger. And the other eye, he had gotten his life together and he was moving an engine. He was a mechanic with a friend. And the friend had a screwdriver in his hand while they were trying to move the engine and drove the screwdriver into his only seeing eye. And so I go see this guy when he comes into the emergency room, because this is the only eye he's got left, right? He's got, vitreous that's coming through the lateral aspect of his eye, and we're concerned. And where, and where I came from in Kansas City at the time, the retina docs loved anytime they got a call. There's a lot of them, and if you call them, they come in right away to see that patient. So I'm thinking that's how things were done in Arizona. And I called up the retina staff and I said, yeah, we got this 26-year-old guy, and explained the history and what was going on with him. And this was at 7 o'clock in the evening. And he said to me, I never forgot it. He said, so what do you want me to do about it? Now, that's the worst example of what you want your ophthalmologist to say, right? We didn't operate on that guy. When I came back, I voluntarily came back to PIMC, 10 years later. And I walk in, and that guy, he came back and he was still seeing out of that eye. He had had multiple surgeries. I think I sewed him up, and I think I removed his lens, and then I later went in to put a lens implant in the eye. And then he had a retinal detachment at some point in that eye, and that got fixed, but he still had vision after, a decade. And I was real happy about that. But again, that's generally the ophthalmologist. I'm embarrassed to say that's generally the ophthalmologist's attitude when you call up after hours. So what do you want us to do about it? And so you'll save, and I apologize for that as a group, but ideally you want to, again, ask yourself, is this something they're going to go blind? And is this something they're going to go blind tonight from, right? And usually we can coach you through most things over the phone. I think that's about it. I think I'll stop it there in case you have any questions about anything. I haven't looked at the clock, so I don't know how much time there is, but any questions? Sure.
Department.
You mean topical steroids?
Yes,
That's
that's a no-no. I don't know.
well, you don't want to do it unless you've talked to the ophthalmologist, right? You don't want to just drop them on the steroid and then send them on their merry way and say, oh, follow up with the ophthalmologist tomorrow. No, you don't want to do that. But you can start the steroid if you've talked to the ophthalmologist. We do that all the time. We say, oh, this patient's got a history of ankylosing spondylitis, and they've had 4 of their bouts of iritis. They're out of their steroid at home, and usually we'll get them started on it. You get the usual history, the vision, the pressure, to be sure they don't have a pressure at 35 or something. But if you talk to the ophthalmologist, most ophthalmologists will let you go ahead and do it. What I don't like is when the patient takes the cycloplegic agent and they take the steroid and they disappear. And that's why you don't typically like to give them the steroid. One other quick thing, when I was in private practice in Kansas City, I saw this guy who came in, he was riding a city bus, which is kind of similar to some of our patients, but he was riding a city bus. He was grinding and at work, and he got foreign bodies in both eyes. So I see him in a private emergency room, and I take the foreign body out of both eyes, but I could only patch one eye because he was by himself and he was trying to get transport home. What I didn't know is when I went out to talk to the emergency room doc, the guy palmed the Alkane. And so he never showed up in our clinic for a follow-up, and I never thought anything about him. He was a private patient then through Humana. And about 8 years into my teaching, one of my residents told me one day, hey, I saw this patient that you saw about 8 years ago. And turns out this guy was apparently they had done a corneal transplant on him at the teaching hospital. And he had gone hospital to hospital as he ran out of his Alkane. And he was basically stealing the Alkane and treating his developing corneal ulcers until he perforated. So the moral of that story is I don't tend to leave any drops around the patients anymore. And when you guys send them in the room, just be sure they don't have anything sitting around that they can palm. Any other questions? Okay.
All right, the whole concept of an ophthalmologist on call. Respect. Yeah, so so again, kind of in the vein of how to approach rural problems. Another topic that came up is TIA, stroke, the kind of where we're going in the direction of that, because oftentimes, especially nowadays, if you're in a highly rural site, many of us don't have telestroke capacity. And if you call a center and you say, hey, I could really use some advice, many centers are no longer willing to give that advice. So I personally have stopped calling. And so I make the decision to lice or not, and that's my decision, and we go from there. So it's lovely to have our next speaker, Dr. Kumara O'Carroll. She's an assistant professor of neurology at the Mayo Clinic in Arizona, the medical director of the Comprehensive Stroke Center, program director for the Vascular Neurology Fellowship. You have got to be the busiest person here. I mean, thank you for taking your time. And then the telestroke director for the Southwest region. So has a special interest in stroke in the young, medical education, global neurology, and healthcare disparities, which is incredibly pertinent to us. So very grateful that you're here. Thank you so much.
Thank you so much for having me. It's a pleasure to be here. And I'll just start off by saying that we still do take those phone calls at Mayo Clinic at any time. Any time of day and night, there's always one of us that's willing to answer any questions on the other side. So my objective today is really to provide you with a practical evidence-based treatment approach. I'm going to move this a little bit so I can see the screen a little better. Towards TIA as well as ischemic stroke. We're going to talk about the changing therapeutic window in acute stroke care, and then we're going to talk about some novel treatment approaches, including large vessel occlusion, so endovascular therapy for large vessel occlusion, alteplase for wake-up stroke, as well as tenecteplase as a thrombolytic option, and dual antiplatelet therapy in the setting of stroke prevention. And so I learned through cases, so this is all case-based. And we're going to start with a patient who's 64 years old, history of hypertension, diabetes, presenting to the emergency department with abrupt onset of right arm and leg weakness, lasting 75 minutes with complete resolution. His blood pressure is 166/92. He's not on antithrombotics, and you suspect that there's a TIA. So which of the following would you consider starting in this patient? So I'll give you a second, but not too long since there are many slides. And the answer is actually aspirin and Plavix. So this has been a change in our practice, and it's in our AHA, so American Heart Association, American Stroke Association guidelines since 2018, 2019. This is routine practice now for patients with TIA. And I think it's always important to understand where these guidelines come from. And so I'm going to talk to you a little bit about the trials behind them. Now, this was in part based on the CHANCE trial, which was aspirin and Plavix in acute ischemic stroke or minor TIA. And in this trial, they randomized more than 5,000 patients within 24 hours of a minor ischemic stroke or high-risk TIA to either aspirin and Plavix or aspirin monotherapy for a period of 21 days. Now, how was a high-risk TIA defined? This was an ABCD2 score of greater than or equal to 4. And for those of you who might need a reminder, the table is here. And so we go through that table depending on, the patient's age and what their blood pressure is on presentation and what their presentation characteristics are, we assign a score. And then minor stroke was defined as an NIH stroke scale score of 3 or less, okay? And so in this trial, they looked at a primary outcome of stroke, both hemorrhagic and ischemic. And what they actually found was that the dual antiplatelet therapy group with the aspirin and Plavix had fewer strokes than the aspirin monotherapy group, and the rate of hemorrhage was the same. And they found that, they concluded with this trial that among patients with TIA or minor stroke who can be treated within 24 hours after onset of symptoms, the combination of aspirin and Plavix is superior to aspirin alone for reducing the risk of stroke in the first 90 days and does not increase the risk of hemorrhage. This was the first trial that actually showed that this did not increase the risk of hemorrhage. Now, this trial was published in 2013, yet this was not widely accepted nor implemented in our practice until, as mentioned, 2018, 2019. Why was that? Well, Chan's trial took place in China with 100% of the Chinese population that tends to have higher rates of both Plavix resistance as well as higher rates of large vessel disease. And so many people in the Western world thought, well, this isn't generalizable to our population. How do we know it's going to work in the United States, for example? And they were waiting for the results of a POINT trial, which was enrolling at the same time as CHANCE, but wasn't available till 2018. So what did POINT tell us? Well, same principle, aspirin and Plavix randomization. The difference here was that they randomized within 12 hours of symptom onset. They used the same criteria for high-risk TIA and small stroke. And again, the difference here was that they used aspirin and Plavix for 90 days instead of 21 days. And again, that they started the treatment within 12 hours. This trial was international with about 83% of patients being enrolled in the United States. And they looked at a primary outcome of risk of composite of ischemic stroke, MI, or death. And what they found was that there were actually fewer major ischemic events in the dual antiplatelet therapy group, as well as fewer ischemic strokes, but there was more hemorrhage in the dual antiplatelet therapy group. And what they did was subgroup analysis, and what they found was that their benefit of the aspirin and Plavix was actually greater in the first 7 days and the first 30 days than at the 90 days. And the risk of hemorrhage also kind of increased the longer you were on the dual antiplatelet therapy. And so many of us took this to really confirm the results of CHANCE, that the shorter exposure for the 21 days would give you that benefit without increasing the risk. And since then, there was actually a pooled analysis of the two trials that confirmed this formally, with the main benefit of dual antiplatelet therapy occurring in 21 days. And then the formal recommendation being, this analysis suggests in patients with acute minor stroke or TIA that dual antiplatelet therapy should be initiated as soon as possible, but preferably within 24 hours after onset and continued for a duration of 21 days. So moving on to our next case, we have an 83-year-old guy with history of coronary artery disease. He's seen in the emergency department 70 minutes after onset of hemiplegia and dysarthria. His NIH is 19. He's found to be an AFib, which is a new diagnosis. He's not on any medications at all. His CT of the head without contrast is shown above. There was no evidence of ischemia or hemorrhage, but there appear to be bilateral ICA terminus and M1 aneurysms on both sides. You can see them there, and they measure about 10 millimeters and 15 millimeters. This was also new. And so would you administer TPA to this patient? Yes, no, maybe? So the answer is no. And the reason I highlight this case is that the guidelines changed in 2018. So prior to 2018, if anybody had an aneurysm of any kind intracranially, TPA was actually an absolute contraindication. The guidelines changed in 2018 to say, hey, if your aneurysm is 10 millimeters or less, then it's okay to give TPA. And so in this gentleman, one of them was 15 millimeters, which is why we didn't give him TPA. We have a 34-year-old female who presents to the emergency department within 2 hours of a thunderclap headache, neck pain, vertigo, nausea, vomiting. This all occurred at the gym during one of these squat and snatch exercises. Her exam shows right sensory loss in the body only, some incoordination of the left upper extremity, suggesting maybe a posterior circulation phenomenon, CT head spine. There's no evidence of acute ischemia or hemorrhage. And then you get a CTA of the head and neck, and you see that there's a vertebral artery dissection. So would you consider giving IV TPA in this patient? Yes or no? And so many people would say no, but the answer is actually yes, and which is why I'm highlighting here. So a vertebral artery dissection is not a contraindication to receive IV TPA. And this is of particular importance when you consider who is affected by vertebral artery dissections. These tend to be young people, and they tend to have posterior circulation strokes, which can be quite disabling. And so the guidelines formally support this. This is a long list. I've kind of highlighted some of the big points. I'll leave this for you for review, but these are general contraindications to receiving IV thrombolysis. Okay, so we're moving on. We have a 71-year-old who presents to the emergency department 90 minutes after onset of left-sided weakness and dysarthria. Her blood pressure is 172/80. All her coags are normal. CT head's normal with no evidence of hemorrhage. You decide to thrombolyse. 40 minutes into the IV TPA infusion, she complains of severe headache and begins vomiting. Her blood pressure suddenly shoots up to 230/110. Neuro exam's worse. Now she's completely plegic. So which of the following is the most appropriate next step in the management of this patient? So you could argue that all of those are appropriate next steps. But the most appropriate next step, since the TPA is still actually infusing, is to stop the TPA. And the reason I highlight this, so you stop it because you're suspecting that this patient is having a symptomatic intracerebral hemorrhage. And the reason I chose to bring this up is that, you know, we've all dealt with this. We've all dealt with symptomatic intracerebral hemorrhages. And it wasn't actually until 2018 that we even had guidelines on how to manage this. And so this is directly from the AHA-ASA. There's a nice table in there, but I basically summarize it for you. And we now have formal guidelines rather than just throwing everything at it and hoping that it works. And the principle behind it, first and foremost, is to stop the TPA. And then cryoprecipitate is number one. And then you can choose either tranexamic acid or aminocaproic acid. Hemilingual angioedema. It's rare, but it does occur in 1 to 2% of patients. Tends to happen in those that were on ACE inhibitors to begin with. It usually starts towards the end of a TPA infusion. So usually you start checking and suspecting it in the last 20 minutes of a 1-hour infusion. And you look for any signs of unilateral or bilateral tongue edema. If it's unilateral, it tends to be contralateral to the stroke. And so what do you do if this happens? Well, same thing. The guidelines now have formal recommendations as of 2018, which was not the case before. And you stop the TPA, you hold any ACE inhibitors. And then, you know, the suggestion is to kind of give it in sequence, some methylpred, some Benadryl, and maybe famotidine. I personally don't do it in sequence. I will administer all three at once. And I find that that has worked very well for me, knock on wood. And I've never had to go to intubating someone when I've administered all three at the same time. Okay, so we have a 63-year-old female with history of hypertension. She presents to the emergency department with global aphasia, right hemiparesis, 13 hours after last seen normal. Her NIH is 19. She lives alone, was last seen by her son at 9 p.m. She was found on the floor. Her CT head shows early ischemic changes, and she is fully independent at baseline. So which of the following is the most appropriate next step? So the answer here is going to be a stat CTA and CT perfusion. And the reason for this case is to highlight how much the world of stroke and acute ischemic stroke treatment has changed since 2018, where the guidelines first stated that in patients that were presenting within 24 hours of last known normal who have a large vessel occlusion in the anterior circulation, meaning middle cerebral artery, proximally or internal carotid artery, that we really should be considering mechanical thrombectomy. This was all based on the results of 2 trials, DAWN and DIFFUSE-3, which we're going to talk about briefly. So DAWN came first. It was actually published in the New England Journal of Medicine in January of 2018. And this trial looked at thrombectomy in a 6 to 24-hour window and randomized over 200 patients with large vessel occlusion presenting within, again, the 6 to 24 hours to either mechanical thrombectomy or control if they had a small stroke, and a small infarct core on perfusion imaging. Now, this imaging was rapid software. It's a CT-based software, and it was a way to calculate how much of the brain was at risk. So how much had diminished blood flow and how much had already infarcted. And then whatever's left, you subtract the two. And if there's a penumbra, then you know that there's brain to save. And this trial showed that an overall benefit at 90 days in the treatment group with really staggering numbers of number needed to treat of 2 for lower disability and number needed to treat of 2.8 for functional independence. So remember, this was January of 2018. And then in February of that same year, also in the New England Journal, was the publication of the Diffuse 3 trial. And this similar principle as Dawn, but it was a 6 to 16-hour window. They also used the same perfusion imaging. And the trial showed benefit and functional outcome at 90 days in the treatment group. There was lower mortality in the treatment group and the endovascular group, and there was no significant difference in symptomatic intracerebral hemorrhage or serious adverse outcomes. So from a practical standpoint, let's say you don't have CTA capability, but you're thinking that someone could have a large vessel occlusion. One thing is an NIH of greater than 6. That's kind of a cutoff to keep in your mind. And the other is if patients are presenting with these signs that we consider cortical signs, it's likely that they have a large vessel occlusion. So aphasia is one of them. Neglect is another. Head or gaze deviation. Their eyes gaze is going to be deviated to the side of the stroke. A dense hemiparesis or hemisensory neglect, right? Or a visual field cut that would suggest posterior circulation. Okay, so we have a 62-year-old with a history of hypertension, hyperlipidemia, presents to the emergency department at 6 a.m. after waking up with right-sided weakness and dysarthria, an age of 7. CT head is normal, no hemorrhage, no large vessel occlusion on CTA head and neck. His wife confirms he went to bed at midnight. Which of the following is the most appropriate next step? So this is what we consider a wake-up stroke, right? And so this has also been kind of a shift in our treatment paradigm because in this patient, we would get a stat MRI of the brain. And this was all based on the results of the wake-up trial, which was published in 2018, that was MRI-guided thrombolysis for stroke with unknown time of onset. And in this trial, they randomized more than 500 patients with unknown time of onset of stroke to either IV TPA or placebo if they had an ischemic lesion visible on MRI DWI, but no parenchymal hyperintensity on FLAIR. Okay, what does all that mean? It basically means that you're looking at 2 sequences of MRI, and if there's a mismatch between the two, that you really know that this patient is in a 4.5-hour window. So you're still selecting for someone that woke up with symptoms, but technically they're in a 4.5-hour window. And when they thrombolyzed these patients, they found favorable outcome in 53% of them in the TPA group versus 42% in the placebo. And this trial demonstrated the benefit of IV TPA in patients with wake-up stroke using an MRI-based selection model. And really, we were selecting for patients in that 4.5-hour window. I bring this up because this is in the guidelines now, and it's the first time that is the case. Prior to 2018 and the publication of this trial, we would not ever treat these patients with thrombolysis. It was one of these situations where, oh, let's give you a rectal aspirin and you're going to be admitted to the stroke unit. So now we have a 56-year-old gentleman with history of hypertension, diabetes, hyperlipidemia, tobacco, presents to the emergency department in Tuba City, Arizona due to abrupt onset of right-sided weakness and dysarthria 2 hours prior. You promptly evaluate him and determine he's a candidate for IV thrombolysis. His NIH is 6. CT head is normal, no hemorrhage, vitals, everything looks good. You order stat alteplase, only to be told that they do not have it, but they carry tenecteplase. So do you administer IV tenecteplase instead? Do you transfer the nearest stroke center for IV alteplase? Are you going to order a stat CTA head and neck? Or administer rectal aspirin and recommend permissive hypertension? So the answer is you're going to give IV tenecteplase. And I'm going to tell you a little bit about the story and background on this. So again, these were the 2019 guidelines. And in the 2019 guidelines, I think they're worth reading directly. It says tenecteplase administered as a 0.4 mg per kg single IV bolus has not been proven to be superior or non-inferior to alteplase, but might be considered as an alternative to alteplase in patients with minor neurologic impairment and no major intracranial occlusion. So very specific, right? You're like, I don't know about this guideline, right? And it was really based on the results of one trial that was done in Norway called the NORTEST trial that randomized patients to either tenecteplase or alteplase within 4.5 hours of symptom onset. And in this situation, they were using a tenecteplase dose of 0.4 mg per kg. Alteplase was the traditional dose. And they found that tenecteplase or TNK was not superior to TPA in the primary outcome of a modified Rankin of 0 to 1 at 90 days, that TNK showed a similar safety profile as far as symptomatic intracerebral hemorrhage and death, but most patients enrolled in this trial had mild strokes, an NIH of 4, and there were no major intracranial occlusions in this study. And so many people thought, well, you know what, these results aren't generalizable to people that have larger strokes when you consider that in this trial, most people, 80% or more, had NIHs of 7 or less. And so that was the reason for the very, very specific guidelines. That same year, there was this recommendation, well, you know what, if you have a large vessel occlusion, let's try 0.25 mg per kg. And the reason behind that was a different trial called Extend-IA-TNK that gave either TNK or alteplase before thrombectomy. And in this trial, they used a lower dose of 0.25 mg per kg in the tenecteplase group, and they used 0.9 mg, the traditional alteplase dose. This was prior to thrombectomy, and the patient still had to be in a 4.5-hour window. In this trial, the median NIH was 17. And when they looked at the primary outcome, they found that TNK was non-inferior to TPA in restoring perfusion of greater than 50% in the territory of the artery occlusion. And they looked at secondary outcomes, and TNK actually resulted in better 90-day functional outcomes, but the incidence of recovery to independent function didn't differ. And there was no significant difference in symptomatic intracerebral hemorrhage. So this trial was 2018. So now we're with 2 doses, right? 0.4 mg per kg of tenecteplase. This one says 0.25 mgs. And so this year, this is really hot off the press. This was just published in Lancet Neurology in June of this year. And it was the results of the NORTEST 2 trial, part A. And their goal was really to establish the non-inferiority of tenecteplase at the 0.4 mg per kg dose compared to alteplase, but in patients with moderate to severe ischemic stroke. Now, if you remember the first NORTEST trial that we talked about, one of the criticisms was that, well, all the strokes were really small in that trial. And so we didn't know if we could use that dose in larger strokes. And so they specifically randomized only people that had NIHs of 6 or more. And they actually ended up having a median NIH of 11. They looked at primary outcomes of modified Rankin at 90 days. The trial was stopped early after enrolling only 204 patients due to more symptomatic intracerebral hemorrhage in the TNK group compared to alteplase. There were also lower rates of favorable outcome. There was a higher rate of mortality in the TNK group. Now, again, this was published in June, and this was the 0.4 mg per kg dose. Subsequently, in Lancet, in July of this year, are the results of the ACT trial, which is IV TNK versus alteplase in acute ischemic stroke in Canada. Thank goodness for the Canadians. They really, well, you'll see why later too, but really do some superb studies. And in this trial, they randomized 1,600 patients presenting with stroke within the 4.5 hours of symptom onset. and they used the dose of 0.25 mg per kg, or again, alteplase at the traditional dose. Their average NIH was between 9 and 10. They looked at modified Rankins, and they found that IV TNK at 0.25 mg per kg is comparable to alteplase in terms of efficacy and safety. And this was symptomatic intracerebral hemorrhage as well as death. There were similar functional outcomes at 90 to 120 days, similar rates of symptomatic intracerebral hemorrhage, and also similar rates of mortality. So why are we even having this conversation? Why are we talking about considering tenecteplase to begin with? Well, it can be administered faster. You know, alteplase is a 1-hour infusion, as you guys know, and tenecteplase is a 5 to 10 second infusion. This has very practical benefits when you're talking about transferring patients to a higher level of care. Maybe, you know, they need to go to a stroke center, maybe they have a large vessel occlusion and you need to get them somewhere where a thrombectomy can take place. The other very practical thing is that it's cheaper, and many places made the decision based on cost. And in theory, it has the highest degree of fibrin specificity and binding, and thus in theory has the potential to be superior in efficacy. We know that it's at least as safe as, and there are some trials that suggest maybe possibly having better recanalization rates in the large vessel occlusion. So that's why there's so much discussion around tenecteplase these days. And there are actually some centers that are switching completely to tenecteplase. So our last case is that of a 35-year-old female who's 29 weeks pregnant and has experienced hyperemesis gravidarum, is brought into the emergency department by her husband after the abrupt onset of confusion. 1 hour prior on your exam, she's severely aphasic and has right-sided weakness. Her NIH is 16. Which of the following is the most appropriate next step? Are you going to immediately page the OB on call, obtain a stat CT head, CTA, head and neck, start mixing the TPA, immediately page the vascular neurosurgeon on call, or transfer to another center? Or do you do all of the above? Correct. And so, you know, the reason I'm highlighting this is the US guidelines have no help. There's one line about you can consider treating pregnant women, but that's the extent of the American Heart Association, American Stroke Association guidelines. So this is why I'm very grateful for the Canadians who developed guidelines for us treating pregnant women. And I think there's some really key points, and I find these to be very helpful, especially when you're discussing with family members and the patient themselves, that in these patients, when they're presenting with acute ischemic stroke, that you should be obtaining immediate imaging of the brain with a CT, just like you would anybody else. A non-contrast CT head exposes the fetus to a negligible amount of radiation, and I love these numbers. A CT of the mother's head carries fetal radiation dose exposure of 0.001 milligray, and the occupational limit for fetal radiation is 5 milligray, 5,000 times less than the allowable exposure with negligible risk to the fetus. And an MRI without gadolinium does not carry any fetal risk at any of the trimesters, but of course that's not readily available even at, you know, primary stroke centers. When we're talking about administering IV alteplase to a pregnant woman, this really should be a multidisciplinary discussion with the patient or family taking values into consideration, as well as the OBGYN, neurologist, and all of that. There are limited numbers. They're all case reports or case series, but in every one of these situations, when women received IV alteplase, there were good outcomes regardless of the trimester. And we really base the decision of the alteplase, yes or no, on the maternal risk. So you still go through your usual checklist. And alteplase is a large molecule and does not cross the placenta. And so it's not expected to pose bleeding risk to the fetus. And then lastly, about endovascular thrombectomy, this is something that you should consider and pregnancy is not a contraindication. And many of us would actually say that if there's a large vessel occlusion, maybe you skip the alteplase altogether. And if it's possible and you can transfer a patient rapidly, of course, that's not always realistic. But you could even skip alteplase and go directly for mechanical thrombectomy, and that the risks of endovascular therapy are going to outweigh any risks. The benefits are going to outweigh the risks. I am happy to take any questions if there are any. Okay, sounds good.
Yeah, thank you so much for that. Incredibly, like, immediately useful, walk out of the room and engage in practice changing issues. So thank you for the update. So we will have our last speaker go right now and a little bit into lunch, and apologize. But Dr. Victoria Hogue, she is a current second-year critical care emergency medicine fellow at Brigham and Women's, originally from Maine, and then trained in the Chicago area. Later did her residency at University of Michigan and is now at Brigham and Women's. Her kind of background does have a focus when she was in Michigan at looking essentially coordinating critical care access to rural communities, which is incredibly poignant to us. Our purpose in having her speak today is the topic is essentially on critical care in the ED border, because again, this is, highly related to COVID, but is still just residual due to our nursing shortage, right? And I'm sure that UNM feels the same way that we do, in that you just sit there with these critical care patients forever in your ER, whether it's transport related, whether it's bed related. And so what do we do? Like, what do we do after a certain time frame? How do we ensure that we can bring a little bit of the ICU down to our emergency department patients? Because we all know that a lot of this care, this kind of very basic fundamental kind of housekeeping care, really matters in terms of ICU outcomes. So thank you again for taking this.
Hello. Oh man, you guys, every time I get invited to talk about anything, I'm like, what an honor and privilege. And then as I'm walking up here, I'm like, do I speak words and English? And get a little bit nervous. So regardless, I'm very happy to be here. I am, as Dom introduced me, a second-year EM critical care fellow at Brigham and Women's Hospital, which means I did emergency medicine at the University of Michigan. And now I'm in Boston. I signed for a job in very rural Maine doing an ED-ICU split. So I'm excited to be here. It's very relevant. I spent 8 weeks out at Fort Defiance in the spring. So I've loved this conference for the past 3 years, and I'm glad to be here today. Before I start, I wanted to tell you the story about Tim, who was a patient I saw in Boston last winter. Tim was a 28-year-old gentleman in very rural Maine who showed up to a very small critical access hospital with acute pancreatitis. Showed up okay. He was admitted to another hospital because the hospital he presented to actually didn't have any beds available. So was boarding in the ED waiting for transport. And over the next 12 hours, he became much sicker. He developed some difficulty breathing, his pressures got soft, his repeat labs were trending in a really terrible direction. His breathing continued to get worse. This hospital didn't have BiPAPs, they intubated him. His repeat chest x-ray had some fluffy infiltrate concerning for ARDS. They called around to a number of different hospitals before they got to me, and I was at a hospital in Boston, not Brigham, but another big quaternary care center. And at that point, they were like, we think this guy needs an ICU. Every ICU in New England was full. Can you please take him? So we accepted him and had transport arranged, and then there's a snowstorm. So he's stuck in this ED for the next 48 hours before we could get him. And it was a bad enough blizzard that ground transport wasn't an option. And even with ground transport, he was about 12 hours away from us. So over the next 48 hours, Tim needed all of the things you can imagine for critical care. He had complicated vent management. He developed DIC. He needed blood. He needed multiple pressors. And this hospital had none of those things. So what they did was they coordinated with the other 2 critical access hospitals within driving distance. They got blood from another hospital, When Tim developed abdominal compartment syndrome, they had a surgeon from another hospital emergently credentialed to come over and do his X-lap. They didn't have a third line presser, so they made dirty epi with the help of a pharmacist that was stayed in-house. And then the hospital called a nurse in who volunteered to come in and work an extra shift to provide one-on-one care. And I would call them every shift in the morning to kind of try to help coordinate things, but there was not a whole lot I could do over the phone. But eventually when Tim got to us, we switched up the pressers, we waited for 2 days, he got closed 2 days later, and he walked out of the hospital a week later. So that's incredible, right? Critical care, little hospitals are perfectly capable of doing incredible critical care, but it's not based on having all of the experts and all of the fancy equipment available to you. It's based on the community of people around you and the communication and collaboration between hospitals. I thought Tim was a wonderful example of why this stuff is important. So let's see if I can figure out the clicker. All right, so critical care boarding, it's a problem. I promise it's a problem. This is the only systematic review that looks at critical care boarding in the ED. And the TLDR of it is that there is about up to an 80% incidence of boarding in the ED, but it varies widely on where you are. Between 2006 and 2014, ED waits for critically ill patients increased by 80%. And this is pre-COVID, so you can imagine they got worse. And then boarding is relatively poorly defined, but 6 hours seems to be the place where outcome differences actually change between patients who are admitted directly to the ICU and patients who are boarding in the ED. But what about critical care boarding in the rural ED? So I looked and I looked and I looked and I Googled everything that I could think of, and there's nothing. There's really nothing on rural ED critical care. So take everything I'm going to say you with a grain of salt. It's all extrapolated from wide kind of research into critical care patients. So it is a problem, but why is it a problem? Why does it matter if we're talking about critical care boarding? And it matters because there's a change in outcomes that matter to us and matter to our patients. So on the left side of the screen is hospital length of stay, and the right side of the screen is mortality. And this was a big study, 42,000 patients in the US admitted from the ED. What they found was that 14% overall in the US patients were staying in the ED for 6 or more hours. And for the patients who were staying kind of in the 6 hour, and you can see they broke it up into different times, but for patients in the 6 to 12 hour mark, there's actually a big step up in mortality difference between these patients. So something is happening in the ED if they board, which translates to increased length of stay and an absolute increase in mortality. But what is it? So these nice folks here went to look at, they took 3 very common ED complaints, right? There's chest pain, cellulitis, and pneumonia, which is like the bread and butter of everything that we see. And they said, what's important for these patients? These aren't critically ill patients. These are just regular old patients with these things. What's important? And for chest pain, they were like, okay, repeat cardiac enzymes and PTTs for patient on enzymes. That seems important. Subsequent doses of antibiotics for patients with pneumonia or cellulitis, pretty good. And then restarting home medications. And they compared it to the patients who were admitted from the ED to the floor and patients who boarded in the ED, a little bit longer times. They started boarding at 12 hours, and then they looked at 12 hours, 18 hours, and 24 hours. And what they found was we do a darn fine job in the ED of getting cardiac enzymes and PTTs. We did a great job. We did it faster than the floor. We got the results faster than the floor. We did great. For subsequent doses of antibiotics, we did kind of medium. We ordered them most of the time. There was no clinically significant difference because the time they used for a delay in subsequent doses of antibiotics was like more than 2 hours. And their data showed about 1.8 hours. So it was close. And then restarting home medications, we did terribly. So 70% of ED patients who are boarded in the ED will have no home medication started at all. And that's important, right? Because there's a lot of home medications that are really important for your patients. And this was me talking with my orthopedic surgery husband about what he thought was important to restart. And I was like, hey, this is pretty good. But there are important things that we do in the ED. Please shout out for eye drops to the ophthalmologist in the room. That patients need, even if they're boarding in the ED. And some of these granular things probably translate to an outcome change. So the goals of this presentation are to give you very simple things that you probably think about doing reflexively, but sometimes are harder to do when you're actually in the middle of nowhere, trying to take care of a very sick patient that absolutely improve outcomes or probably improve outcomes, but are kind of logical. So the first of these things is manage the food. So this was a great study of patients who were intubated in the ED, who then boarded in the ED for more than 2 hours. This is a large tertiary care medical center, so they managed to get them ICU bed between the 2 to 6 hour mark most of the time. And what they found was that only 24% of patients in the ED had any changes made to the vent, and any at all, 24. So that's a good chunk of patients who you intubate, you set medium settings on the vent, which is fine, that's what I do too, and then you don't change it at all. And what these authors set out to do was find the things that make a difference for these intubated patients in terms of mortality, because that's what we're interested in. And they broke it up into 6 important interventions. And they looked at the patients who got all 6, who got more than 3, and had between 1 and 3 of those things done. And what they found was the more of the interventions you did, the better the patients did, the less likely they were to die. And those interventions were things that we kind of reflexively do and then less reflexively do. And the reflexive things are easy, right? It's the chest x-ray post-intubation. You just have to look at it, make sure you're looking at it. Place an OG or NG for gastric decompression, early appropriate sedation on the vent, looking at an ABG and then acting on that ABG, setting an ideal tidal volume, or having quantitative capnography, which the Brigham doesn't have, so I can't imagine that that's the thing that you're going to pick. But if you pick 5 of things, not capnography, then your patients actually have, you can see this mortality odds ratio goes from a very low number to 4.25, which is amazing. The chest x-ray and early sedation are independently associated with an improvement in mortality in those patients. So these are really easy things you can do, right? So the algorithm is intubate your patient, get a chest x-ray, start some sedation, then get some more information. I don't care what that information is, to be completely honest. It can be ABG, it can be capnography, it can be calculating an ideal tidal volume, it can, whatever it is that you want, get some more information about your patient and then do things about it. So change your tidal volume, increase your PEEP, lower your FiO2, whatever it is. This definitely improves outcomes for patients who are in the ED for any more than 2 hours. But really, if you focus on that 6 hour mark, if that patient's going to be there past the end of your shift, try to manage that, try to do something with the vent. Any one of those things in the vent, your patient's probably going to do better. The next thing is time the antibiotics. So we all know antibiotics are important, right? Like this is beaten into us in the surviving sepsis guidelines. This is the big study that makes it so that we get all of the annoying pop-ups on the computer. And it shows that from each hour of ED registration for patients with sepsis, there's a change in mortality for those patients, right? So it's a 9% increase in mortality. So antibiotics are important. And I will argue that the second dose of antibiotics are important too. And what you'll see here is that ED boarding is associated with the delay in subsequent dose of antibiotics, and that delay is more than 2 hours. So does that matter? And the answer is probably. Of the patients that had a delay in antibiotics, what they really saw was that patients who were sick with septic shock or pneumonia, if they didn't get that subsequent dose of antibiotics on time, while there wasn't much of a change in mortality or ICU admission, they did tend to do worse where they needed the vent, either for metabolic derangements or for respiratory support. So probably important, time your antibiotics. And then just a reminder that 50% of patients who admit to the ICU with septic shock will die in the ICU. So getting them the antibiotics early and then timing the antibiotics makes a big difference if there's any trend towards improvement in mortality. All right, the next thing, I wrote this presentation a little bit on post nights from the cardiac surgery unit. So I meant to write titrate your pressors, and you've got titrate your critical care, but regardless. So titrate your pressors and your critical care. But what you will see here is that when you have big delays in initiating vasopressors, there's a change in mortality. And this was a huge study. This is like 8,000 patients who presented with septic shock, and they looked at the delay of initiating pressors after the first initial documented episode of hypotension after fluid resuscitation. And this, you might see this graph because I, again, practiced my orthopedic surgery husband. He was like, well, it looks like you can just give them fluids up to 14 hours. And I was like, no, that's not the point. The part, depending on where you work, 14 hours is one shift, right? 1 or 2 shifts, depending on where you are. So if you can imagine yourself in the position where you have a 28-year-old man like Tim who has pancreatitis, whose pressures are kind of borderline, and you give them fluids and they get better. And then they're borderline again, and you give them fluids and they get better. And you repeat that cycle for your entire shift. At some point, you get to the point where Tim's gotten too much fluids and bad things happen. So sure enough, if you look at any information about fluid resuscitation and septic shock, you see that there's a trend. And that trend is for patients who become increasingly fluid overloaded during their septic shock presentation, their mortality changes pretty dramatically. And this is first day, second day, and third day of being in the hospital for patients who presented with critical care. And while you can ignore their fluid balance kind of up to that 0 mark, as soon as you start getting positive around 2,500 to 5,000 or 5 liters of fluid, there's actually a pretty big change in mortality. So don't be the person who keeps giving fluid boluses for the patients whose pressures are pretty soft. If you've met the 30 cc's per kilo of fluid resuscitation, just start the pressors. This isn't perfect. This will change on the patient. This will change based on the patient. But just kind of be mindful of the total volume you're giving your patients, knowing that as soon as you hit above the 30 cc's per kilo of volume, you start seeing that increase in fluid volume balance associated with a change in mortality. So this probably changes outcomes. And then the last thing is don't miss things. And this is ridiculous, right? Like I can't just stand here and be like, don't miss things in critical care. This is a critical care sign out. And this is also ridiculous. I saw this and was like, in no world. But this is what I do. So I was on a shift at a community ED, taking sign out on a very sick, critically ill patient. And I wrote, this is truly what I write, and I write it in the ICU too. I go through all the systems and then I put the big things. For the very complicated ICU patient that you have in your ED, and I know it takes some time, and I as an emergency physician, I know that that can be a big ask to spend another 3 or 4 minutes doing this. But if you do this, you're going to find the people who came in with normoglycemia, intubated for ARDS, who now have blood sugars of 600 and are opening up an anion gap. And those things matter. And this is probably why there's a mortality difference in going straight to the ICU and boarding in the ED. It's because if you go through these things, you'll find the stuff that's not really their presenting problem, but actually changes their care a fair bit. So part of that, you'll notice on that sheet before, I have that little section that says prophylaxis. And that's like the ICU in me, right? Like I want those things to happen. Some of these things are realistic for me to ask of you, and some of them are very much not realistic for me to ask of you. Don't start tube feeds in the ED. You don't need to. I don't want you to do that. Nobody wants you to do that. But things like GI prophylaxis, DVT prophylaxis, blood sugars, waking your patient up if they're there for a few days, and keeping head of bed greater than 30 degrees, which is a simple thing, but we intubate many patients completely flat, and then they stay completely flat. If you raise the head of the bed upper 30 degrees, there's a change in how long those patients will stay on the ventilator because they aspirate less. These are really simple things that people have studied and we do in the ICU because there's a change in mortality and outcomes. So think about the DVT prophylaxis, think about the GI prophylaxis. Your pharmacist can be a huge help in part of this, if you can find one, to do some of the, if you can do some of these things. And then finally, ask for help. Please ask for help. There is no shame in asking for help. Taking care of critically ill patients is a 2-year fellowship for me, and there's absolutely no reason why anybody should have to do it on their own in the middle of nowhere with this huge cognitive load. So please ask for help. Ask for the people that you're transferring to, or call Brigham and Women's Hospital and ask for the intensivist on call. We'd be happy to run a patient with you at any time. And that is the biggest thing you can do. If you feel like you're in over your head, there is no shame to calling and asking for a second opinion, a second set of eyes, asking your colleagues. It is always a good thing to have more eyes on a patient than less, especially if they're really sick. So this entire presentation in one side. These patients do show up into the ED. They do board in the ED, and it's not great for anybody, them or us. You can do some very simple things to change outcomes, and I hope that you'll remember at least one of these things. And then please ask for help if you need it. And that's it. Thank you, guys.
Right. I was just here to say thank you. That's essentially, we found ourselves about a year ago just saying this is a problem. We know it's a problem, and now we have an evidence-based solution. So that's exactly what we were looking for. So very much thank you. Now Paul's going to tell us what to do.
Hey, thanks everyone. Thanks for a wonderful morning. So we'll go ahead and go to lunch. Dr. Safia Rubais, can I introduce our next speaker?
Ugh. Good afternoon, everybody. It's my honor to go ahead and introduce Dr. Nomi Levy-Carrick. Hi there, Nomi. Nomi's a medical psychiatrist who currently serves as vice chair for clinical programs in the Department of Psychiatry at Brigham and Women's Hospital. She's co-chair of the Mass General and Brigham Informed Care Initiative and assistant professor of psychiatry at Harvard. Her experience includes working as a psychiatrist embedded in the medical ICU and the liaison to the burn and trauma unit. She's been a psychiatric consultant in the critical illness recovery program and the functional outcomes and recovery after trauma emergencies project at the Center of Surgery and Public Health. She's associate vice chair for ambulatory services since 2019 of September. And in the past, she had worked as the mental health director of the World Trade Center Environmental Health Center in New York City, 2011 to 2015. Throughout the COVID pandemic, in addition to her clinical responsibilities, she's focused on innovative work developing trauma-informed approaches to program development that advance mental health access and equity amidst the mental health pandemic that's still underway. I might add that we're experiencing currently. Her abiding interest is in integrating mental and physical health approaches in ways that are mutually reinforcing and in developing programs that support health equity in low resource contexts. Since 2018, she's been at the Center of Mental Health Teaching and Training for Navajo Area IHS, sponsored by Mass General Brigham Outreach Program with IHS. She's visited on-site at Northern Navajo Medical Center, and many of us involved with IHS and Navajo ECHO have experienced and shared in her expertise in trauma-informed care, moral injury, and resiliency that she's been offering her expertise for those of us who are currently working in Indigenous communities. Dr. Levy-Carrick, Nomi, thank you so much for agreeing to speak with us today.
Thank you so much, Dr. Rubais. That's a very thoughtful introduction. Hello to all of you. Is the volume okay? Are we good to continue? Okay. So I didn't hear a no, so I'm going to take it that was a yes. Okay. So I appreciate everybody's attention at the end of what I imagine is a long day and set of days. Wanted to talk a little bit about some of the resilience challenges we are amidst, but also understanding that we're in sort of another phase of the COVID response. Sorry, I'm trying to move my slides and they're a little stuck. I want to start by acknowledging the current situation in Indian country and beyond. First and foremost, that the inequities that COVID has demonstrated preceded COVID, and they've really been magnified and amplified by that. And that there were resilience and coping strategies that preceded COVID and that have been utilized, but also recognizing that this is unprecedented in so many ways, that it has kind of obliged all of us to kind of think and rethink, what do we know, what's working, what do we need? So we'll talk a little bit about resilience, both the individual and systems components, some of those challenges to resilience and thinking about a shared nomenclature around that, and then some strategies for managing acute and chronic stress. I start always by saying, stress itself is not toxic. Stress is how we grow, it's how we get stronger. But when a stressor is so overwhelming, or when there's so much of it that there's no time for recovery, or when it's both, that's when we have this kind of allostatic load that builds and it kind of leads to pathology. And that's what we're gonna sort of think about right now. Trauma itself, we especially, I guess, in the emergency context, we hear trauma, we think physical trauma, but obviously that definition has grown, and we appreciate that there are sort of individual trauma as well as interpersonal, structural and collective trauma, and we want to sort of appreciate that all of those end up kind of building in the amount of stress and adversity that people are facing. it's always really helpful to kind of think about what do we know and how, and how do we build on that. One of the ACEs trial, I don't know if all of you are familiar with this, but just briefly, it was published in 1998, and it was this cooperative effort between the CDC and Kaiser Permanente. They surveyed over 17,000 people, and they had these sort of 10 categories of types of adverse childhood experiences. And it was a landmark study, not only because even in this population, which was disproportionately white, disproportionately well educated and all insured, and even in this population, nearly 2/3 of those surveyed had at least one event. And what they found is that there was a dose-response relationship, not only with mental health and with substance use, but also with chronic medical conditions. And that work has been replicated and expanded over and over again. A more recent study that was done, it was published in 2019, over 25, I think it was 25 US states with over 63,000 people. It sort of demonstrated the ways in which, again, there's large exposure. It disproportionately impacts BIPOC populations and women. And again, that sort of dose response relationship we see is quite formidable also in all of these medical conditions, chronic medical conditions, as well as depression and alcohol and smoking. Just a word in general, that ubiquity of trauma exposures, you pick a population and 60 or 70% of them are going to have exposure to trauma. And that becomes relevant because of the ways in which trauma kind of affects brain behavior and engagement between individuals. It also means that in our patient population, we can anticipate high rates of trauma exposure, but also amongst ourselves. That we are part of this group, and we want to sort of think about the ways in which that's impacting us on a day-to-day basis. We think about traditionally trauma is this kind of the fight-flight response, right? You're walking in the woods, you see something, it might be a snake, that visceral rapid response where you stop, and that's, microseconds later, you say, well, it's a stick, it's okay, I can keep going. And some people re-regulate really quickly, and for others it takes longer, right? So that the initial response is not necessarily the issue. Sometimes, that can be quite good, but the recovery time, the time to recovery is sometimes, it can be very varied amongst people. And there's really interesting research about that, what that recovery time means in terms of levels of functioning. I won't go into the neurocircuitry here, but this, I think, is kind of a profoundly important snapshot of what goes on in the brain. What we learn from pathology is helpful in terms of how we understand ourselves. So this is neurocircuitry that's impacted in PTSD. And we just sort of look at these 4 domains. Emotion regulation and executive functioning, they're kind of inversely related. So the more dysregulated you are, the worse your executive functioning. So as patients come in, and when they are dysregulated, we are not seeing them at their best level of functioning. And similarly, when we ourselves are feeling dysregulated, we're not bringing our best selves in terms of executive functioning to the table. And that has, valuable, it's important implications in terms of our functioning. And it's also sort of valuable to keep in mind when we're seeing somebody very dysregulated in front of us. They're probably not encoding everything that we're sharing with them. And that means, in the emergency setting and sort of critical care setting, you may have had conversations with people and you come back an hour or 2 later and you seem to be having the same one again. And that's part of what helps us understand the ways in which that happens. The threat and salience detection, our experiences, our lived experiences will also impact the ways in which we respond. There's sort of the hereditary and epigenetic piece. There's the kind of environmental piece. And there's a special place in the amygdala that stores those fear responses. Think about the fact that we can have 16 things happen, 15 of which are great, and one of which was not great. And you come home at the end of the day and the one thing that sticks out can be that one thing that didn't go right. Again, from a survival of the species perspective, this is a good thing. You never want to forget where the line was. You never want to forget one of those things. In the best of circumstances, it says, all right, this is the thing I'm going to learn from and do differently next time. But we also want to kind of recognize that there is this kind of disproportionate memory for those sort of fear-based experiences. And so, when people are coming into a healthcare setting, they may be triggered just crossing the threshold. Again, we're sort of thinking about it both from the patient side and from the clinician side. And the last component, for those who have heard me speak before, this is kind of the contextual processing piece, I think, is really where a lot of the meat is here. So contextual processing, a way to understand it is if there's a bear, you're going to the zoo and you are behind a plexiglass and you're safe. You can see this bear and the cubs and they're going around and say, oh, wow, big bear, how strong, how big, and be curious and be interested in understanding and just the experience of observation. If you open your door and the bear is in front of you, your response is going to be completely different, as it should be, right? So it's about context. And that ends up being really relevant when people are sort of experiencing an event. Having the context of that event is important. And often, the way in which we process and contextualize and integrate some of those traumatic experiences is really important in terms of whether or not it goes through this path of kind of the trauma becomes isolated and becomes, functionally impairing and intrusive and so forth, or it becomes this very difficult thing that happened amongst many other things. Contextual processing happens during REM. And for REM to happen, the locus coeruleus has to turn off, right? When we think about sleep disruption and the ways in which it's impacting the ways in which we are integrating all of these experiences, it's a sort of important thing to recognize in terms of sort of when we're taking care of patients and what disruption sleep has for them, but also for ourselves. What the many different roles that sleep plays in terms of kind of well-being and our capacity to sort of have stamina in the face of this much adversity. When we talk about trauma, we want to talk about resilience. There are a lot of arrows here, but the sort of salient point is that all of these domains that are potential sites or moments of vulnerability are also ones with potential for resilience building, right? We want to sort of think about the ways to prevent trauma and adversity. We want to think about ways to use neuroplasticity to balance out some of the sort of negative valence memories, to have kind of other ones to recognize that epigenetics allows us some forays into that. And then to sort of think about some of the psychological factors as well. We'll talk a little bit about role clarity, self-efficacy, and empowerment, and the ways in which those cognitive reappraisals can be really containing and actually empowering. So we want to always make sure that we're talking about the same things when we use language, because there are lots of words that get thrown around when we're talking about trauma and resilience. And so we're going to kind of run through all of these and think about what they each mean and how they relate to each other. So starting with resilience, resilience is really an umbrella term. And there are lots of different resilience associated traits that kind of determine whether and when one is resilient. And it's helpful to sort of think about these two domains, right? There's this core domain of nutrition, hydration, relaxation, exercise, sleep, right? These kind of well-being ones that can be sort of foundational. And then there are these more existential ones, and your attitude, your optimism, your self-control and self-awareness, your sense of humor, your social supports, and so forth. And these are bidirectional. and some are online at different times than others. But it's helpful to sort of think about how that works for different people at different times, including ourselves. So for some people, if you haven't had a good night's sleep, you are not going to have a sense of humor or be social or do anything else. And for others, if you haven't gone out and been social and had some sort of positive engagement, it's going to be really hard to get to sleep. And if you tell somebody, oh, you know, you should go sleep, that'll help, and their life is falling apart around them, that can sometimes just sound and be experienced as totally not understanding what their experience is and what they're going through. And so it's helpful to sort of think about, again, for others and for ourselves, what do we need right now? Like if we go to bed, are we just going to be awake and we can't think? Maybe we need a good conversation with somebody. Maybe we need to go out to for a meal or a coffee or a drink or something. Or maybe we need some exercise, or maybe we need a walk, or maybe we need to really talk through an issue with someone. And sometimes it's just pure fatigue. And what we need is to just lie down and rest, and then sort of think about some of these other issues. And so sort of thinking about those two domains can be really helpful in recognizing the ways that they engage each other. And I also want to just acknowledge that resilience and what makes people resilient changes throughout the lifespan. And different developmental stages, the emotional brain is different, and we sort of tap different domains as we do this, and the protective factors kind of gradually broaden, right? And in childhood, we're really talking about that bond with the caregiver and the stability. Through adolescence, we're sort of looking for improving executive functioning, and relationship with peers becomes more important, and that sort of family support and stability plays a big role. And then in adulthood, as we're going into our professional lives, the kind of emotion regulation capacity is important, and it's kind of very exquisitely interrelated to executive functioning in some of the ways we spoke about. And it's where some of these kind of optimism or positive emotions, the cognitive reappraisal components come in. This is where we can think about active coping, where we can sort of proactively put into place things that might help. And meaning and purpose is really at the beginning, middle, and end of all of these conversations. Social supports, role models remain sort of important throughout. And in older age, where older age starts, I think is another kind of question, but intact cognition is sort of also kind of very important in this whole context. So the emotional vocabulary wheel, this is it's words matter. When you think about some of the studies that are done with PTSD, right, they put somebody in a scanner, and sometimes that trauma is decades ago, right? When we sort of think of some of the military vets, distant trauma, they put them in the scanner, and sometimes the challenge is they show them trauma-related words and neutral words, right? So even those words will differentially light up different parts of the brain. Words that are neutral for some are provocative or, triggering for others. It's not to make us feel so inhibited we don't know what to say, but to, think with authenticity and with a little bit of humility. If you say something and you can see somebody's face change colors, you sort of, it doesn't seem like to have landed right. Should have said that differently. The other piece of it is that we are more than sad, bad, glad. And the reason that can be important to sort of think about, again, in terms of our own self-awareness and when we're talking and with others, is because if somebody is sad because they feel guilty or they feel despair, versus someone who's sad because they feel very lonely, the kind of intervention that we would look to do would be different. And so the more that we can help people really feel and get more sensitized to the things that are driving these big emotions, it can be really useful. Similarly, if somebody's angry, it's very different if they're angry because they feel humiliated versus because they feel frustrated. by some other situation. And so just again, something to sort of think about. So there are all these kind of individual factors, but what we want to also recognize is that it's resilience in an organization, that individuals function within an organization, and certainly in a professional context, that organization is impacted and impacts the level of resilience of its members. And so how do you support resilience in an organization? And through COVID, things that we've known in other contexts have really been highlighted. For example, good, clear, timely communication, information, and training. And that's not always easy. The potential to either over communicate or under communicate is always there, and sort of thinking with your particular group, how much information is useful at any given moment, how to present that information, thinking about how you do it when there are different disciplines involved. How do you do it for admin versus clinicians? How do you do it for different types of clinicians? And really sort of being attuned to what's useful. Fostering team spirit and cohesion, promoting well-being through flexible, responsive resourcing. And that's, thinking about schedules for folks, and where can we find sources of flexibility realistically. This promoting of self-efficacy through skills building and training, this need to ensure that people feel as though they have the skills they need to bring to bear into the situation they have. We will not always have that match, but if there's a sense that there is an opportunity to gain that as we go, some of the struggles end up feeling a little bit less gratuitous because they are experiences we can bring to bear as we learn more. And then there's a sort of basic psychological and well-being resources for staff. Voluntary huddles can be very helpful and can be team building, but this is an opportunity to remind folks that is different than a mandatory debrief. So people need to know what they're walking into. And so it's one thing to have a kind of critical incident debrief talking about what are the systems issues that resulted in X. That's different than going around the room and asking everybody, how did you feel about that? Right. And kind of expecting every single person in turn, because people process things differently. They have different kind of emotional wherewithal in different contexts, and they may or may not be comfortable sort of sharing. And so when you're getting into that domain, you want to make sure that people are sort of self-selecting to come in and do that, and be very attuned to what the agendas are for these different meetings. And then really thinking about what are some of these resources for staff, getting those lists together that are appropriate, and getting those out in important ways. So burnout's a term that we've heard a lot. There's this idea, it's sort of this term that addresses specifically this chronic workplace stress characterized by exhaustion, negativity, reduced productivity. We know that sort of this burned out state decreases the quality of care. There are more medical errors and decreased patient satisfaction, and also increased turnover. And I think, some of this studies, just to sort of say, has been done with physicians, but we know this is true across kind of different clinical domains. And I think, nursing, PAs, and just medical assistants, and sort of at every level of the clinical spectrum, we know that this has been going on. There's that professional side, but there's a personal side as well, that can drive or is driven by broken relationships, an increase in alcohol or substance use to sort of as maladaptive coping mechanisms to deal with this stress. And it can, progress to depression, not just, this isn't just burnout, but actually sort of clinical depression and suicide. And that's why we have to take this seriously. We want to identify it early, and we want to think about the ways to intervene. I think it's poignant. It has been National Physician Suicide Awareness Week, and today is National Physician Suicide Awareness Day. And so in that context, I thought I would also just come and remind everybody about our national N988 number. for immediate attention. And there are also there's a National Physician Suicide Awareness Day website, and they have different kinds of resources for support, including a physician support line and a NAMI, the National Alliance on Mental Illness Crisis Line. And, important to sort of think about and have at the ready in different contexts, these kind of numbers. I think what we know is that intervention is impactful, that asking someone how they're doing matters, that on the one hand, we can't control what everyone does, and it's not, people can't feel responsible for people, staying alive or not staying alive. On the other hand, knowing that there are things to do. And we think about this a little bit like CPR, right? Everybody learns CPR. We know that the outcomes are not by any means very robust in the field, but they are impactful, and that's enough to make it worthwhile to sort of get as many people trained up and aware as possible. We know that public health workers are in particularly struggling, and the survey of state, tribal, local, and territorial public health workers that was done in 2021. In 2021, I apologize for the sirens behind me. Over 26,000, over 50% of folks were reporting symptoms of at least one mental health condition. More prevalent about those who couldn't take time off or were working over 40 hours a week. More time on the COVID response, younger and also transgender and non-binary individuals were kind of more at risk. And that's information that can, help us think about ways in which to intervene, being really thoughtful about work schedules and timing, and sort of ensuring that we're being proactive in providing that information. That study was repeated, again, a robust group of respondents. It's gone down a little bit. I don't know that that's within the margin of error from 52 to 48. So maybe we're trending in the right direction. This time where that in terms of hours per week, it actually went up, interestingly, if people were working more than 60 hours per week. And again, sort of similar vulnerabilities in terms of populations. And interestingly, in this study, they also noted if people identified as multiple races, that seemed to be higher prevalence of mental health symptoms. So some people will say, don't call this burnout. This isn't me being so tired about everything. Rather, I should never have been put in this situation, or I never expected to be put in this situation and having to make these kind of decisions in terms of resourcing or in terms of witnessing this sort of scale than as I ever thought before. And when we talk moral injury is the term that's often used on the battlefield. Some folks prefer to use moral distress in the more civilian context, but either way, it's really this injury to core values. And it occurs when you can't provide maximal care for individuals because of limitations that are outside our control. And that's a really kind of important thing. And it's something that has crept up a lot around COVID. Just this idea around everything from PPE to access to kind of vaccines and to care and to prophylaxis and so forth. Moral injury or moral distress can really cause profound sense of guilt or shame or outrage or distress or some very corrosive emotions when they are kind of kept inside. And here we sort of think about this biopsychosocial spiritual model, or that is a kind of a framework for addressing moral injury, that it can be different than depression and other kind of mental health symptoms, and that we want to sort of help people. And when we sort of think about the contextual processing again, it's the difference between feeling I've done absolutely the best I could with the resources I had at the moment, which is a different sort of perspective than it is unacceptable and outrageous that I had to deal with this set of circumstances because it was so utterly gratuitous. And I feel complicit in that process. And we're learning more all the time, but having that language and having that framework to kind of name that level of the kind of level of injury to core values has been very sort of helpful for a lot of people in terms of identifying where their sense of distress is derived from. In terms of grief, there's been a lot of grief and anticipatory grief. What are we going to lose as a function of this? But there's also just frank grief. So many people have died. And we are grieving as a country, we grieve as a community, we grieve as individuals. We think about these 6 stages of grief. We know that they are not linear, and that different people go through them at different times. But the kind of denial, anger, bargaining, sadness, acceptance, and this 6th stage that David Kessler has sort of put forward is meaning. That we need to find some sense of meaning, either to our lives or to the ways in which we honor those we've lost. And that has to be part of this healing process in order to sort of fully integrate and feel some level of resolution, that it's possible to both have the grief and the gratitude and to hold both of those in ways that that allow us to kind of move forward and feel connected to a future. So trauma and stress related disorders, people use the term PTSD a lot. All the time. And I think it's important to realize that. So PTSD is a very particular diagnosis. So some people will have a traumatic exposure and in the 3 days to 1 month period have symptoms of, intrusive memories, avoidance, difficulty with sleep, hyperarousal. But sometimes that sort of remits over the course of weeks, right? We sort of think about a normal response to an abnormal situation. And certainly in the sort of hours and days after a trauma, that's sort of, unsurprising to experience and to observe. But as it starts to progress and elongate, we then start sort of thinking about the potential for pathology. And when it lasted for more than a month is when it kind of falls into this domain of PTSD. So these 4 categories of symptoms, right? Intrusive symptoms are things like, it's not just intrusive memories, but nightmares, flashbacks. Avoidance can look like just not wanting to go to the place that reminds you, but sometimes it actually becomes avoidance of being around people who may ask you something about it. And so people can become quite socially isolated. And there's also sometimes numbing around that, a real kind of disconnection from people and from the world that some people will experience. Negative alterations in cognition and mood can go down. This is where we sort of talk about this a sense of a foreshortened future. Some people will have a really hard time projecting themselves into the future. What am I going to be doing in 5 years? How are things going to look? It's a very kind of, it's like time freezes and folds in on itself, and people feel very trapped in that set of circumstances. Alterations in arousal and reactivity, sleep disturbance kind of falls in there. So does hypervigilance and hyperstartle. And again, you can see how hypervigilance could be adaptive in one context and then becomes very maladaptive in others. Functional impact is sort of core to ever calling anything a pathology. And again, this is different than anxiety, where people are just kind of worried, but that not having nightmares, not having intrusive memories and so forth. It's different than depression, where people are having sort of hopelessness and helplessness that are, and sort of those kind of low mood that is, and the neurovegetative symptoms that are kind of part of that. One thing is when sleep is disrupted, that kind of cuts across lots of mental health symptoms. And so, a lot of our studies are based on screening tools, not diagnostic assessments. And so often on the basis of screening tools, we'll certainly see a lot of people who have a lot of comorbidity, but that comorbidity holds. People who have PTSD, there are also very high rates of of depression, of substance use, and also we're increasingly sensitive to the fact that there's a lot of high rates of medical issues as well. So there are like over 600,000 ways to meet criteria for PTSD. And some people are going to look angry and irritable and jumpy, and some people are going to look extremely flat and extremely quiet and extremely withdrawn. And oftentimes the quiet, withdrawn ones, people think that maybe they're okay. They seem fine, right? And we want to sort of become attuned to and not assume anything about how someone is sort of processing. And in the right context, we want to screen for all those symptoms and not sort of make assumptions about what the affect that we see, what they look like, is telling us about their internal experience. So, there's the potential for adversity to turn to trauma and to turn to PTSD, but we also know that there are other trajectories. And we talk about post-traumatic growth in this context because even you can have post-traumatic growth even if you also have PTSD. But many people will have these traumatic experiences or adversity, and it goes from fear to learning to growth. And that is a trajectory that's really important to keep in mind. People will, in that growth zone, say, you know, I have a new appreciation for life, or I didn't realize that I was capable of these things. This is a kind of sense of myself that has grown. I have empathy or compassion for others in ways I didn't. Some people have profound spiritual changes around that, and recognizing that the sort of surviving these experiences and navigating through these experiences also leave us with a potential for that kind of growth is a really important thing. Because what we don't want is to walk into these situations with this kind of fatalistic, everybody's going to have PTSD. Everyone will have distress. There will be a lot of adversity, but not everybody will sort of progress to this specific diagnostic space with sort of all of these kinds of symptoms. There are a lot of other ones, and it also needs to mobilize us. That means that we also need to feel compelled to be proactive in identifying things early and intervening early. Just want to kind of acknowledge that it's easy to say that. It's not always easy to do. But one thing I want to kind of put forward is, so what do we do with all of this, right? And so in this context, we talk a lot now, certainly I talk a lot now, about a trauma-informed approach. And what does that mean? So there are 4 R's and 6 principles. We sort of recognizing, if you sort of think about that slide of the brain as well, we realize the widespread impact of trauma. We recognize that there are paths for recovery, and that these will affect individuals in an organization, including the workforce. And so we want to respond by integrating knowledge about trauma into everything from policies and procedures into the way that we engage people at the bedside. And above all, we want to resist traumatization, and I would argue resist traumatizing people in the first place. How can we minimize the medical trauma that people experience as they come in? And that requires an organizational cultural change. It requires us all talking about it, us having a shared sort of perspective, and then really thinking about what that means on a day-to-day basis. So there are these 6 principles, and I'll run through them, one by one. I think we've got the time. Have we got the time for that? We'll do it quickly, and then I'll run through so there's time for questions. Safety, it's not just physical, but also psychological. People who have been through trauma are often very afraid that they're going to keep getting asked about that trauma at every other medical visit. So they're coming to you in the emergency room with abdominal pain, and somebody sees in their chart they have a history of sexual and emotional trauma and start asking about it again. And it's very triggering, it's very provocative, and they are in a moment of physical vulnerability. And so we want to really think about what history do we need to know about different individuals in different contexts. And similarly, from a clinician's perspective, how do we feel psychologically safe going into work? What do we need to do to sort of titrate to tolerance in terms of what we're experiencing? The trustworthiness that we expect people to have of us almost immediately, transparency often sort of is in service of that trustworthiness. And that's everything from like, how does it work when I walk in the door as a clinician or as an employee? How does, from a patient's perspective, like what's going to happen to me as I've come in? Collaboration, mutuality, really giving value to the lived experience that people have, giving choice, but real choices that are reasonable in these different circumstances, and feeling empowered to act on that. Cultural, historical, and gender acknowledgement. We now sometimes talk about cultural humility and responsiveness, recognizing that it's not whether, but how somebody's gender, race, historical experience is impacting them as they engage in healthcare. And finally, peer support. It's important for patients that we, the health system is only going to provide one piece of their recovery environment. So we want to put that in the treatment plan, but it's essential for clinicians as well, that there is something about talking to other people who share your lived experience, and whether that's professionally or in other domains, that is specific and important. And with more time, we can sort of talk about how that overlaps with contextual processing. Trauma-informed is very different than a trauma-informed approach from a trauma-focused treatment. So in trauma-informed approaches, we're talking about optimizing engagement in healthcare in general, or in education and in other contexts. We think about universal precautions, universal framing, avoiding retriggering, and there's going to be variability depending on your role in the context of care. Trauma-focused treatment is really very specific. You're addressing the trauma experience directly. The treatment is going to focus on resolution of those trauma-related symptoms, and in that context, you may require a detailed trauma history. I hope that's clear about the distinction. That's kind of an important way of understanding why we're talking about this in healthcare context all across the way. Trauma-informed care aligns very much with the psychological first aid core actions, mentioning those here. The VA also has an excellent stress first aid set of responses. And so kind of a whole other domain of conversation, but it comes back to these kind of core sets of issues. For resilience on the front line, we really want to pull out from this resilience umbrella some elements that when we are at the front line as clinicians, to sort of at a moment of distress or complexity, being able to sort of pause and say, what is the source of this? Is it real clarity? Is it, I'm not sure whether this is my job or not? Is it self-efficacy? Oh, I know it's my job, but I don't feel like I know how to do what I need to do. Or is it empowerment? I know it's my job. I know I have the skills, but I don't feel as though I can do it in the way that I want to. And sometimes being able to sort of locate the source of that can lead to some really constructive engagement around resolving it. I think in the interest of time, we'll just kind of wrap up here. In terms of these different strategies, we want to recognize that we are all have multiple roles. There's the clinician and colleague role. There's the advocate role, that we want to take our individual experience at the bedside and use that to feed advocacy efforts. That lessons learned will always be relevant. There's always another context within which we can apply it, which makes it feel less gratuitous and adds meaning. And we also have these roles as family members and as friends. The contextual processing is really important here. We're sort of, how do we come to terms with the limitations of the system, and then feel able to sort of function within those limitations, even as we advocate for more. And also, how do we identify resources that do exist within the system, interpersonally and individually, but also as an organization. And that's where we want to think about huddles and team-based care and EMR templates and other kinds of resources, and the ways in which we reinforce that to people. No individual is responsible entirely for thinking about you know, no, this is a no man is an island, right? Like you're not resilient because of only the things that you're doing, but also because of the context within which you are functioning. And that's why it's so important that organizations are held accountable and are engaged around this this effort. I want to end again with a note of humility. I am really humbled and astonished by what all of you have done throughout your careers, but over these last 3 years. I want to acknowledge the burden of that, and I'm glad that you're all here together with an opportunity to share. And I want to also sort of mention that at the Brigham, we are happy to provide support, and we have someone, John Fromson, who can even do that as well when called upon as a sort of an additional resource. But you know, above all, sort of sending all of you my greatest respect. And if there's time for questions, I'm happy to take them. Thank you.
Nomi, Dr. Levy-Carrick?
Yeah, know me for sure.
Hi, it's Safia. I think in the interest of our time, we wanted to say thank you to you, not only for your presentation today, but for all those times when you were there to support us with echoes that we hope will continue, because I know that you did have some information specifically on how we could integrate trauma-informed care into the emergency department, and some studies that you had to share with us too, that there wasn't quite enough time to do that. So I'm hoping that you're going to be willing to share with us in an upcoming echo session.
The other 15 slides, there was no time for.
Okay. But thank you again so much. We've greatly appreciated your support, your interest, and above all, your understanding of the circumstances that we've all been through in the past few years and we continue to go through. Thank you.
My very best. Bye for now.
Thanks. And I would like to echo your comments, Safia, on this. There was a lot of really excellent content in there. One of the things that I do want to make sure everybody knows, we are taking the content, all the slides that we're showing, putting them into PDFs, and they'll be available on the EMRIC website. So if you want to go back to revisit individual slides, such as what Dr. Levy-Carrick just talked about with short-term and long-term interventions, like these would be things that for us at JMC would make sense for us to talk about in staff meetings and things like that. So that'll be available for people. We'll try to get it up this week. And then Sean's going to introduce our next speaker.
With help. Thanks so much. Hi, good morning, Mark.
Good morning, Sean.
That's great to see you. We're very, very excited. We've got a very excited audience. I have to ask you though, how's the weather going to be tomorrow?
The weather is good here. We kick off in Darwin in about a week's time. It will be steamy in Darwin, and we've already been warned about that. It's called the silly season up there. So people start to go a bit loopy in the heat of Darwin. But right here today, it's a beautiful spring day in New South Wales.
Excellent. Well, we wish we were with you in person, or you with us, and one of these days we'll just make that happen. Okay. Thank you so much for taking time to join us. I want to share with our audience that, you know, I think from the start of this program, we recognized that we had colleagues serving communities and communities that were allowed to serve in other places around the world with similar challenges, similar clinical difficulties that are unique that our colleagues in the US and other countries who work in the big cities don't encounter. And we had the very good fortune Paul and I met Dr. Mark Newcomb a few months ago, who is one of the organizers of the Developing Emergency Medicine Conference. He's going to talk a bit about that. I'm going to talk quickly about Dr. Newcomb first. So Mark Newcomb is a senior staff specialist in emergency medicine and pre-hospital and retrieval medicine. He currently works for the Illawarra, Shohaven Local Health District and General Sydney Area Helicopter Emergency Medicine Service. He's worked around Australia and overseas in a range of critical care disciplines, including emergency medicine, pre-hospital and retrieval medicine, neonatal and pediatric medicine, intensive care, and anesthesia. Mark has a special interest in trauma, point of care ultrasound, and critical care, and is published and presented on a range of topics. And I'm going to turn over to Paul to talk about his involvement in developing EM.
Thank you. And Mark, thank you very much for joining us today. For the audience members here, one of the things that I want to point out is for us to look closely at what they have done with developing emergency medicine, developing EM in terms of the discussion we had at lunch today. What are the next steps in terms of ideas that we can do to foster connections across other countries, Canada, Australia, other places that have a lot of emergency medicine in Indigenous communities? And then how do we want to try to make further advancements to be fostering those relationships? So Mark, we'll turn it over to you. Thank you very much for joining today.
Thank you very much. I hope the conference is going well and that everyone's enjoying it. As a conference organizer, I get a good understanding of how stressful the organizational process is. I feel like I've aged 5 years since I've last spoken with you, a few bags under the eyes. This first slide shows you a great aerial shot of Darwin, which is the largest city in the Northern Territory. We're going to speak a little bit more about that, but it's a beautiful, remote, tropical place in Northern Australia where we're having our next conference in about a week. So in terms of, I was wondering whether I needed subtitles for this. Australians don't speak, well, European Australians don't speak many languages, and we really don't speak English all that well, but g'day to all of you people over there in Flagstaff. And our local Indigenous nation here is the Yuin Nation. So Wallawani is greetings in that language. And I'm here to talk to you about our conference organisation, Developing EM, and our current conference in Darwin, where we're thematically focusing on the challenges and opportunities in the delivery of healthcare for First Nations people. Before I start, I'd just like to acknowledge the traditional custodians of the Flagstaff region, where your conference is being held, and also the Yuin people as the traditional owners of the region where I'm broadcasting from, and pay respects to their elders, past, present, and emerging. Sovereignty over these lands was never ceded, and it was and always will be Aboriginal land. So thank you for the kind introduction. I learned a few things about myself there that I'd forgotten. I've been working in those fields almost 30 years. It just feels like I was newly graduated only recently, but actually I'm just very old. So I'm a co-director of Developing EM with 2 other emergency and retrieval physicians. As I mentioned, I'm not from the Northern Territory. I have worked there in the past, but I'm from the southeast of the continent, New South Wales, and I live within the Yuin Nation area, which is on the coastal and coastal ranges of southern New South Wales. It's an absolutely beautiful part of the world where the ocean meets the mountains. And this is my current hometown of Kiama, where I live, which is derived from a Yuin Aboriginal word, which means place where the sea makes a noise. And you can probably see within this ancient lava flow, which forms this headland, there's a blowhole. So we think that there's a connection there between the Yuin meaning for the place and the blowhole. Close by, we're lucky enough to have subtropical rainforests and waterfalls, and I feel incredibly lucky to live here and have grown up in this region. I don't have any conflicts. I'm employed by state government organisations, and none of us draw any salary from the conference organising group. So even though you'll see a few advertisements, we're not making any money from this. And look, I'd just like again to thank Emily, Sean, Paul, Ken, Tristan, and the entire Emmerich team for collaborating with us. We were introduced by Taryn Clark, who is an emergency physician from the United States. She's also a member of the Shearwater tribe in the Pacific Northwest. So we managed to meet in January remotely with the hope that we could collaborate with each other's efforts. And I'm really, really glad that things have panned out the way they have. So thank you once again. All right, so who are we? Well, I guess we had too much time on our hands. In 2011, an emergency colleague, actually another American, and I started developing EM as a not-for-profit conference organising group. We don't have any medical industry support. And at times, I'm wondering why we did that, but it makes us feel good. It doesn't make the bank balance feel any better, but I think it gives us an opportunity to not have influence over content. And 90% of our funding comes from registration charges from delegates from high-income countries. We do have some support for particular projects, especially supporting local delegate attendance from other organisations, but generally these are in either individuals or charity-based organisations, and we don't accept any funding from industry. Our aim is to have a regular conference in a part of the world where our specialty emergency medicine has particular challenges or is evolving, and to support the delegate attendance from that particular region. So in the past, our delegates from host settings have either paid $0 for workshops and attendance to the conference, or working with local societies, we've had a charge of perhaps 5 or 10%, which has been redirected back into their local societies of emergency medicine. So we have never taken money from regional delegates. The conference has core clinical sessions which focus on tips for senior clinicians who've been to lots of conferences before and have heard the talk on coronary artery disease and have heard the pulmonary embolism talk, but really want something that's going to stretch them and that they can add to their armamentarium for their next shift. And so we have, 3 big sessions on adult emergency medicine and critical care, trauma, and pediatrics. And then in the afternoon sessions, we thematically focus on people's experiences, usually from the setting of the conference. And we also have workshops allied to the conference that are decided by the host partners. So this is a photograph of what a lot of the Northern Territory looks like in the arid areas with red dirt, and this will be the main highway from Darwin to Alice Springs for much of its distance. So undivided single carriageway with, you've probably seen pictures of what we call road trains, which are trucks with 3 or 4 trailers carrying goods thousands of kilometres, and it's an absolutely spectacular countryside. So in 2011, we had a test, 2012, we had a test conference in Sydney just to test whether this was going to work, whether it was going to be viable, and to test the type of process. So looking at those short, sharp presentations to give people tips rather than hundreds of slides filled with references and graphs. It was going to be much more practical. And I think we were not responsible for this, but certainly I think conferences have changed in time with what we've been doing to approach things for emergency physicians who generally have a low attention span, so short presentations with key information. And this conference was fantastic, and we got a lot of good feedback, and somehow we didn't lose money. So it was something that we were able to move to other settings after that. And since then, we've had conferences in a number of settings. So Cuba in 2013, and I'd highly recommend going to Cuba to look at their healthcare system. And I could talk literally all day about the Cuban medical system, but I won't. And then we went to Brazil, to Salvador in 2014, back to Cuba in 2015. A little bit closer to home, but I think, as you probably understand, everywhere is far away from Australia. So even Sri Lanka is 10 hours flying away. And this was a fantastic conference in South Asia that was probably our biggest conference that we've had. We then went a little closer to home, Fiji in 2018. And Fiji is again an incredible setting, a hub country for the nations of the Pacific, with most physicians being trained in universities in Fiji. And this was a fantastic and very friendly conference, and our local partners were just a joy to work with. In 2020, on the eve of the pandemic, we went to Colombia, and again, a fantastic conference. During a presentation on COVID on March the 11th, the pandemic was declared, and I guess life changed for all of us at that point. But we were very lucky to all get home before the world shut down. And in fact, thankfully, our conference didn't cause any harm. No one got COVID. And so we were very, very lucky. And in many ways, even though we felt a little guilty about persisting with the event, I think it was one of the last good times people had for many, many months afterwards. So we were actually glad that we went ahead. So in that time, since 2012, I was going to say we have sponsored, but really it's our delegates, it's their funding that have sponsored the attendance of about 600 delegates from 37 host and regional countries. And I think that's the best way to look at our organisation, that really, as co-directors, we're just facilitators, and it's the delegates, and many of them are repeat delegates, it's becoming a little family really, are the team. Our faculty, our delegates, our organising team, we're all in this together. So to say that our organising team have sponsored the attendance is incorrect. It's really our delegates that have allowed this to happen. And also, in a similar vein, they've also been responsible for providing thousands of dollars of medical equipment to host countries, depending on the need of that particular setting. So as an example, in Cuba, it was very difficult to get electronics. And so we were able to set up a ambulance dispatch unit with screens, computers, and other devices that were very, very difficult because of the blockade to actually obtain in Cuba. But in other settings, it's been simulation equipment or ultrasound machines. And in that 10-year period, our delegates have contributed almost $750,000 to support systems around the world. And thankfully, there's also been pretty good feedback, and somehow we've still remained financially sustainable. But actually, it was something that we never anticipated, the ongoing medical relationships that have been spawned by like-minded people meeting colleagues and cooking up schemes, that has really been an unanticipated and long-lasting effect from the conference. And just as an example, although this is one of many, this is a group in St. Lucia with a paediatric training team from Australia performing what's known as the Pediatric Basic course. And it is not at all basic, it's an extension of the APLS course for people who are starting out in paediatric intensive care. So it's actually a very high level course. And this team, as one example, has conducted courses in 4 or 5 different Caribbean countries, simply as a result of meeting over a coffee or a mojito, mostly in Cuba or Brazil, with colleagues from the region. So this has been a really gratifying thing, and we really hope that similar interactions will occur at this year's conference. So this year we returned to Australia for a conference where the thematic 50% of the conference is going to focus on the delivery of healthcare for First Nations people. And the setting of the Northern Territory is important. So the Northern Territory, many of you may have been here, is absolutely huge and very sparsely populated. So it's 5 times the size of Arizona, and only with 3% of Arizona's population. And critically, more than 30% of the population is of First Nations ancestry. And there's over 100 Aboriginal languages in the territory. It's an incredible place. I love going there, especially to Central Australia. But basically, you've got tropical savanna in the north and ranging through to incredible arid red dirt desert in the south. So coming home to Australia, it felt to us as a non-Indigenous organisation that the natural intersection for our organisations was to look at First Nations healthcare. Now, we're not of First Nations ancestry. A number of our management team have worked in Aboriginal communities in the past and have seen the disparity. That natural intersection. So I guess in our previous conferences, we've been looking to support low or middle income developing emergency medicine settings. And so it seemed to us like this could be a natural intersection for us. And look, it is unfortunately incontrovertible that there is this absolute gap between Indigenous and non-Indigenous Australia in really one of the wealthiest countries in human history. So it felt to us like this was a topic that we should focus on. It's not really my place to intimately describe the history of First Nations Australia, but I'm sure you're aware that the history of our continent is similarly awful to the history of all colonised lands. So to set the scene, in the Australasian continent, there's been 80,000 years at least of diverse and continuous Indigenous culture over 250 nations that very much predate the states and territories in the Commonwealth of Australia. First contact with colonisers was in 1788, only about 120 kilometres from where I am. And amazingly, the last first contact occurred in 1984 when I was 15, not far from where we're holding the conference. Colonisation was devastating for First Nations communities, creating generational wealth for European Australians like me and generational disadvantage for the communities that survived that colonisation process. As I say, I don't think it's my place to educate you about our history, but I'd love to recommend this publication and TV series. It's on a free streaming service, an Australian government streaming service called SBS. And it gives a very nuanced and entrancing description of some of the aspects of Australian history. And it's a publication and production that is First Nations produced. And I'd highly recommend it. It's a great series. But look, just because we as a non-Indigenous organisation can recognise the disparity, do we have a role in examining this issue? We thought we did, but it was important to us to have partnerships to broach this topic. And thankfully, the Indigenous Health Committee of our Australasian Emergency Medicine College agreed with what we were trying to do and what we were trying to analyse, and from the outset have advised us on a management structure that would see these topics being led by First Nations clinicians and academics, with us in a support role. And they actually also helped us decide upon the themes for the conference. And ASEM, our college, has an active Indigenous Health Committee of Indigenous emergency physicians, and an evolving approach to cultural competence training and reconciliation. So look, as a result of that stewardship from the Indigenous Health Committee, we were able to generate interest with a broad range of clinicians and academics from across the country and around the world involved in making up the 50% of the thematic tracks to focus on First Nations healthcare. And as I say, those tracks are going to be led and in the main performed by First Nations clinicians and academics. And as part of that process, we're incredibly lucky to have essentially co-directors of the event, but co-cultural ambassadors from the host nation. So the Larrakia Nation is the nation that where Darwin now sits. So Alita and Richie Fijo are local Larrakia elders, and they've come on with us to essentially be the cultural arbiters of the event and ensure cultural safety, particularly focusing on the afternoon tracks, but also to govern the event, to make sure that the event runs culturally smoothly. Alita is, they're both incredibly interesting people, but Alita is a medical person. So she was the first Indigenous medical student from the Northern Territory. And she's now a senior family medicine practitioner working in remote communities with COVID vaccination rollout. And she's written an excellent book on just the experiences of what it's like to be a First Nations physician. And I'd highly recommend it. It's a great read. And interestingly, it has input from North American practitioners as well. So each of our afternoon tracks, and there's three, will have a cultural lead team of senior clinicians governing discussion along the themes of where are we now, active wellness and healing projects, and the future beyond life and death. And in total, and this is a small selection of our presentation group, we have 30 First Nations presenters. And much of our usual funding that we would direct towards regional delegates is being directed to assisting First Nations faculty with travel, accommodation and registration support. So it's an absolutely fantastic group. And I think the key thing is that we are a support team rather than a lead team in this endeavour. But we're also working with a number of agencies to support the attendance of about 15 clinicians from multiple Pacific countries, including Fiji, Tonga, Western Samoa, Papua New Guinea, Vanuatu, and Timor-Leste. So it'll be great to have them involved as well. And we have a co-located global emergency care symposium that many of these physicians will be speaking at. So the result is a program designed and performed by First Nation leaders, clinicians, academics, supported by our organisation with some really fantastic presentations across a wide range of topics, from the struggle to blend traditional and Western medicine to what will be a kind of a very moving presentation on the difficulties of dealing with child protection and domestic violence, to birthing on country. And I can send you some links to a film called Jackamere, which is being shown at the conference, about moving obstetric support to regional self-governing Aboriginal communities so that women don't need to be dislocated from family to have their children. It's a fantastic production. And, you know, even looking to things like how to appropriately provide aged care. And this will be a particularly interesting presentation in and of itself. Sharon is a good friend of mine who's our Aboriginal liaison support officer at the hospital that I work with, and also a key member of the organisation of one of the first Indigenous Aboriginal nursing homes in Australia. And actually the dynamic that she has found over the last 10 years is that because they have such a family-oriented, community-based and very individualised approach to aged care, there's a great desire to have this model exported to the general community, and many people who are going into the residential system are inquiring as to why don't we have this approach everywhere. So there is, as I've learned through this process, there's so much that the particular community values of Aboriginal Australia are just so relevant for our very individual, dislocated, non-family centred European Australian model. So look, I think it'll be an incredibly interesting afternoon sessions, and there is virtual registration. Sorry, I've got to get a little plug in there that are still available. So you're very welcome to join us online. And I should mention also that apart from our Aboriginal Australian First Nations presenters, we have also 4 presenters from Aotearoa, New Zealand. And thanks to Emmerich, we have 1 presenter from New Mexico. And this is Chelsea White, who many of you will know, who we met through the Emmerich team. And he'll be presenting on providing pre-hospital care on Indigenous lands. And interestingly and very gratifyingly, he's already attempting to get an exchange program between Navajo Nation and Northern Territory and First Nations pre-hospital providers going. So an exchange that would see people work in alternate communities. And that would be an absolutely incredible outcome. And hopefully other opportunities will be created during the conference that outlive the event itself. So this has been a massive learning experience for me. And although, as I said, I have some experience working in First Nations communities, there were just many aspects of life and work that I just hadn't comprehended. And I'm still very much in the learning process, as I think my entire European Australian community is at the moment. I think the thing that surprised me the most, and it was really good to realise, was that First Nations clinicians and academics amongst the busiest members of our healthcare community, they're unfortunately underrepresented compared to the percentage of the population. And so the people that are graduated through specialties are just pulled in every direction all day, every day, being asked to commit to this, commit to that. And because they're an incredibly generous group, it's actually a fact that burnout rates are much higher in this community than in other clinicians. So that was something I really just didn't realise beforehand. And I think fundamentally what I've learnt is that Aboriginal Australia, where I've had the most interaction, despite all of the tragedies that recent Australian history has brought to their communities, is really one of the most forgiving, understanding, and incredibly patient communities that you'll find. And I suspect that this is a factor in other First Nation settings. We've recently had a change to a more progressive government in Australia, and it is a time that may see real change in the next few years, with a movement from apology to actual constitutional change that could result in lasting improvements. I think this is a hundreds of year project, but there's hope on the horizon. And actually, one of the presentations from the conference, which I'm very much looking forward to, is the experience in Aotearoa, New Zealand, where just in the last few months, a Maori health authority that provides Maori control at all levels of health policy that parallels the unified health system is something that perhaps is going to provide a really great and practical example, certainly for us here in Australia, as we really do continue to struggle to close that gap between Indigenous and non-Indigenous healthcare. So look, I guess wish us luck. Only a week to go, still lots to do, but it's all actually coming together. And please feel free to virtually register via our website. I'd just like to thank the MRIC team again. It's been fantastic getting to meet you and to collaborate with you. And I'd be very happy to take any questions.
Thank you so much, Mark, especially with the reminder that it's in the final week in the lead up to the conference. You'll hardly find a more sympathetic group than at least about 7 or 8 of us here, but I think our whole audience shares my gratitude for your presenting during what's a very busy time. And look, the body of work you've put together with your team and your colleagues and your community is quite impressive. It sets a standard that I think we're shooting for. So thank you for your successes, which provide a model and inspiration for us. I guess I'm looking at Mark over here. Sorry, I'm looking at where I see you, but you're probably looking at me here. But really, your work is inspiring to us, and we're grateful for that. And we'll do our best to try to approach at least part of the successes that you've seen. And yeah, questions. Yeah. Mark, I don't know if you could hear that. The question was, it seems like you change location each time. Do you change theme for the conference? Is there a different thematic approach each year?
So this is our first attempt to go in slightly a different direction. The clinical 50% of the conference remains standard. And in many ways, I guess that's the thing that gets people initially looking at the conference as something that's an educational advantage for them. But actually, our afternoon thematic sessions are, without a doubt, always more interesting. In the past, what we've tended to do is have so it's a 3-day conference, and each afternoon is split into emergency medicine from the host country. And so you'll have a team from Cuba or Colombia or Fiji talking about the challenges and their experiences in developing healthcare systems. Then there'll be a second afternoon on the same type of approach from regional countries. So we usually try and get, 10 or 15 regional clinicians from countries that surround the host country, and they can present in a similar vein. And then usually our last afternoon has been sort of international emergency medicine. So people from outside the host country in the region, and often people in that session are people from high income settings that have had development jobs within other settings. So often people are working for the Red Cross or Médecins Sans Frontières have contributed to that session. So this is a little bit of a departure, I guess. In the Australasian setting, it was always going to be slightly different. So certainly for European Australian physicians in Australia, they are definitely not disadvantaged. Looking at an Australian context, we had to either look outside the country or look inside the country for content. And I guess I've probably inexpertly tried to explain why we went in the direction we have.
Thank you for that. A unique opportunity here to ask questions from a colleague on the other side of the world who's doing similar work. So if anybody else has any questions, please let me know. Happy to walk around the room, and otherwise we'll let Mark get back to the busy work of organizing this conference. Mark, you've really helped set up our conversation we're going to have at the end of today about where we want to take this organization and in these conferences. And a quick question I have for you is, do you have this? Clearly you're assembling a network, even if every time you make you land in a place, you have the conference, you have a local network, and now after 10 years of this, you must have quite a collective group of participants that have been involved. Do you all, as a developing EM team, do any work with that diaspora or that greater group of folks who have been involved in different parts of the world?
Yeah, look, absolutely. I think what we try and do as a management group is connect people. So it gets very difficult to both contribute to activities and run the conference. But just as an example, right here at the moment, I have a colleague from Germany who is staying with us pre-conference. So he's coming to the conference, and as a result of meeting people in Cuba, he has set up his own organization, which trains pre-hospital providers in the Caribbean. And so what we've helped him with is just connecting him to other members of teams that we already know. And I guess this is probably the ad hoc model which we've used, in that people will approach us for ideas about connections. And that's probably been the biggest contribution that we've had as a management team. I'm always jealous of the activities that are going on around, because I'd actually like to be a participant and to be an instructor in some of these amazing ventures, but I just haven't had time. And that's something that I've got to correct personally. But yeah, look, it's probably been more as a facilitator, but you're right, it's become a family of people, and we often have repeat delegates who only see each other every 2 years at a developing EM. So it has become a group of friends in a way, with, I guess, similar ideals. Just as an example, we wouldn't get over the line without the support of our faculty, who generally are unsupported by us. And in fact, 75% of the faculty will pay full price. they don't have to. We give them the option to reduce their rate, but the vast majority of our high income faculty members will pay the full price. So that probably gives you an idea of why a lot of projects have spawned, because I guess it's a group of like-minded people who sort of get the crazy concept that we had.
Well, thanks so much. I mean, for those in the audience who, I know the planners have heard this a few times, the financial success and that model. And once the dust is settled and you've had a chance to relax after your conference, you're almost certainly going to be hearing from this planning team to try to learn from your experience. But with that, if there's no more questions, I hope everybody will join me in another round of applause for Dr. Newcomb. And
thank you, everyone, and have a great rest of the conference. And it'll be great to chat to you again soon.
We'll plan on it. Mark, thanks for getting up early for us. Good luck next week, and we'll be in touch. Thank you so much.
Thank you. Thank you. Bye-bye.
Okay, so where are they coming in? In a moment. Okay. We recognize that some people have to be driving back to other places because it's getting late in the day. We still have one other excellent panel that we're going to talk about that feeds into what we had spoken about earlier, like how do we promote longevity and sustain ourselves in this space. Before we get to that, or as we're getting ready to get to that, I did want to do some thank yous for folks. So there was an awful lot of work that has gone into this, and people need to be recognized for that. But also, I really want to extend, this is an open invitation. If people would like to contribute to any future iterations of this, we would appreciate the help. The slides, also, there was another update. The slides will be up hopefully later in the week, but there will also be all the recordings. Those will be accessible. And there will be an email advertising that. If you could turn your badges in on your way out, because we are trying to reuse those. And then, so I do want to recognize everybody who has worked so hard on this. And I might ask people to come on up when I mention that. So I would like to thank the planning committee that worked really hard with the content. And so specifically Dom Maggio, and Dom, why don't you come on up? Who took the lead on the clinical content. Topher Gentoff, come on up, Topher. Along with Jeannie Ringelberg, come on up, Jeannie. You gotta come on up, Jeannie. So Topher and Jeannie worked hard on that content for some of the afternoon sessions around some of the social aspects of the care that we do. I'd like to also acknowledge Jason Kurland, who helped with early steering decisions about content and themes, which we really appreciate. Safia Rubai, please come on up for the help with a lot of our wellness components that were interspersed throughout the sessions. Ashley, who has already had to leave to head back for a clinical shift, and Emily were the people that took the lead on the skills day and a lot of the other background stuff that some of us otherwise hadn't picked up on. And then would also like to acknowledge Sean, who was an integral part of the organizational committee. Ken Bernard, who helped a lot with the transition and assisted with encouragement and specific suggestions. Sachita Shah from the University of Washington, who also helped with content both for the clinical day as well as the workshop day, as well as the other content of the rest of the conference. Andrew Ayer from Harvard, who assisted with the workshop days. Valerie Dobias from the FLIP program, come on up. Cass Georges, did she come in yet? Okay, we will have to catch them when they get out. So Cass Georges and Jay Hall, also from the FLIP program at the Brigham, were instrumental in keeping things moving forward and dealt with a whole bunch of logistics. It would have been even more difficult if we had needed to do those. And then David Stevens. David, where did you go? You've got to come up. So Northwest Portland Area Indian Health Board, along with colleagues Nick Cushman and Jessica Leston, who really have helped a lot with getting everything going with the disbursement and the rollout of all of this. And yeah. 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 Great. So I do want to give a couple of very special thank yous here. So one of those is to Emily Bartlett, who essentially shouldered a huge amount of getting this off the ground. This was a big deal, and like Emily, your involvement here was crucial. So thank you. And then also to Sean DeAndrea. So for not only the contributions with this conference, but all of the previous conferences and all of the leadership and the inspiration. I don't know if you're aware how much of an impact you've had on so many people that are here in this room, as well as the people that have worked in so many other ways to be in this space. That we really want to recognize how much you have done and how much you've contributed and how much you're still a part of this community going forward. So let's give a round of applause for that. And Sean, you may not realize that the Gallup Indian Medical Center in particular is notorious for people working 20 or 30 years, their whole career there, and then at the end of it, they get a piece of paper. And so you have a piece of paper. Along with some very Gallup specific mementos of appreciation. So I really do want to thank everybody for all the assistance getting this off the ground. And from my perspective is, I hope a very successful experience, building community, getting inspired to the big picture of what we're trying to do here, as well as some really concrete tips of what can we take back and try to make things better in whatever small ways that we can implement. Thank you everybody for attending. And I will, do you want to?
Just to add to all that, I think we've all learned a lot and been inspired by people we've been working with in planning this year's content. And we've already heard things that have inspired thoughts about the future. If there's anything that you would like to see, again, as Sean mentioned, this is really by us for us. There is a contact us form on the MREC website. You're welcome to email any of us, but you can also submit any thoughts, ideas, questions, comments, suggestions via that form. And we'd love to take that into account moving forward, both for conferences and then other activities the organization MREC could do. So thank you.
Great. So maybe we can do one other round of applause for everybody, and then we'll go to the last closing. And so one other question, David, for CME components, CME aspects of this, is there a way to access stuff later via the website if people forget to take a picture of those things? I get an email in about an hour. Okay, perfect. All right. Thank you. And Dom, I'll hand it over to you.
All right. Steve Esperanza, would you mind joining us? Huh? No, yeah.
Finish up here. Does it look like I'm flying?
I'll use my voice.
Oh, you're using your voice?
Yeah. Yeah. Don't worry. Something, all of a sudden you get assigned a panel. And so I was griping passionately one day to the committee about longevity and essentially where this comes from. And I imagine everybody can hear me. Good, I can do it when I want to. Yeah, what's that? Except the recording can't. Oh, except the recording can't hear me. Yeah, exactly. Yeah, let's talk. Okay. Now it's official. Okay. Yeah, I'll tone it down. Okay, so essentially, So some of the guardrails real quick, and I'll kind of progress through this. The guardrails are that I'm gonna add, my intention is to talk to some of the legends of our profession in the IHS and tribal systems. Who have set the foundations for a lot of our current very successful programs to build off of, okay? And I'm just curious to pick their brains about, like, how did you wade through these very difficult times and rough systems barriers and rough personal obstacles to get to where you did? Because each iteration, even if there was like a step back at some point in time, still grows and is essentially succeeding today. And so I'm curious as to how we get there, because I'm a new director. And I want to know how to keep my entire goal when I got hired was I said, I want this to be on autopilot. I want to be able to hand this off so that it is much better than when I came here. And I want that to be easier for the next person. And so I'm very curious from this panel as to how we got there. The guardrails, okay? This is not an assault on your predecessors. This is not an assault on the IHS or the tribal system. This is rural systems everywhere. This is rural hospitals everywhere, okay? It's hard to find longevity, especially nowadays. I'd even say inner city spots, okay? So the rise of the CMG, it's kind of churn and burn everywhere. And so these are examples of people who have created systems in these incredibly rural sites that have been historically understaffed, underfunded, and very difficult to recruit to, but yet they've been successful. And so that's my intention is like, how did we get here? You know, how did you do it? So first, so introductions. Sean DeAndrea does not need much of introduction, but essentially built the Fort Defiance program, okay? And so I'm going down the list where we're showing you like where we were. And there are people that essentially, everyone's used Sean as a mentor, and people at Fort I still converse with as to how they do things. Because from a systems perspective, I don't know if anybody does it better than Fort does. It is really remarkable. We have a lot to learn in the IHS from their system, okay? And I speak with some of like his kind of co-partners in building that system. So Esperanza Sanchez has been with the GIMC program since 2004, is that correct? 2003, get it right. Right, and so are you gonna get a paper? Yeah, is that you can get a piece of paper? Yeah, but all of you have been through these incredible, you've seen the system at their lower level with the most difficulties, with the least staff, and have built it into, I mean, gosh, like probably 25% of this crowd is GIMC, right? It's really impressive. And then Steve Conieris, he built the starting blocks of the Chinle program and then built Tuba into what it is today. So I kind of became a little doctor under Steve in the IHS, and I stayed because of what he built at Tuba. And I used his model to carry forward, and that's essentially how I do what I do at White River. Is I just say, how did Steve do it? So I'm curious for each of you, because you have had longevity in the IHS, first off, what were the personal obstacles? So like, what are the personal hurdles that you found as just an emergency medicine physician, just working in a rural setting, like encountering the things that you did, and how, like, what is your guidance? So one, how did you overcome these things? And then two, what is your guidance to some of our newer members as to how to make it stick? We'll start with whoever feels like it.
Hi, everyone. And so I was, actually for the past 2 weeks, I've been reflecting, why did I stay too long at GIMC? My goal was to only stay 2 years, and it's going to be 20 years next year. And I thought of how much emergency medicine has changed in 20 years. And I started writing about the challenges that I experienced when I started working at GIMC in August 11, 2003. And so one of the things that I think it has gotten better over the past 20 years is women in emergency medicine. when I started GMC. Women and more diverse women, women like me, women of color, and we're actually doing what we're trying to do now is getting more people from the community to be involved in emergency medicine. Up to 20, as of now, I think I've only met maybe one Native American who was an emergency medicine physician. And so 20 years ago, that was very, very challenging. And I think what helped me go through that, number one, was that I had a very supportive family. If you have met my husband, he's amazing and he's very supportive. And usually I tell them, if anything is needed, I'm going to ask you to go, or sometimes just send them, volunteer him to do things. And that definitely did it for me. What I think 20 years ago, working in emergency medicine was really different. I felt that there was the idea that anyone can do emergency medicine. So there was a lot of, to me, a lot of what it was perceived, a lot of lack of respect. And so I actually remember that I was working in the ER and I had to supervise ENT physicians working in the ER and sometimes radiologists. And I was just out of training a few months and I was doing their work. And so perspective, I could have been very angry and resentful about doing my work and their work, or I could actually see it some other way as a way of learning and both people around. And I like that. So that actually helped me to understand and show people that emergency medicine was not for anyone to do. It wasn't the idea that you can just throw anyone and say, hey, you can do it. I think 20 years ago, there was also the notion that if you had to deal a lot, for me, what was difficult is deal with the perception that if you couldn't find any job, you will go and work at IHS. And that was hard. And that because to me, it was about purpose. When I came to work to IHS, I had done a rotation at Chinle with Dr. Troy Levitt. And so I fell in love with IHS. I decided that after my training, I will come back. I interviewed in different sites and I chose Gallup. And, but I remember hearing people, well, no one works there, you're not gonna learn anything. But I knew that the reason for me to be there was there was a purpose and a reason, and that's why I stayed this long. I think one of the other challenges that I had experienced and a few, lack of mentorship for us women. And 20 years ago, nothing against guys, but there wasn't many women in emergency medicine. And I wanted a mentor who just was like me, a female. Back then I was single. If she was of color, great, but I didn't have that. So I kind of had to work on that myself. And I think we touched a lot about on it today. It's the mental aspect, the mental health aspect of emergency medicine. 20 years ago, the reality has not changed for our patients. A lot of poverty, lack of opportunities, death, especially in the young, violence. And when we see that, as we heard today, it goes into our cell, into our DNA, and it really becomes traumatizing. 20 years ago, we couldn't speak about it. 20 years ago, we can say, I'm broken, I've heard, I've just seen a pediatric code and who I talk to. I'm so glad that we're able to speak now about these things that affect us as providers. And 20 years ago, it wasn't that. And so for me, speaking to you guys is huge. Thank you. I don't consider myself an expert. I think that if I lasted this long in emergency medicine is because I've always gone back to my purpose. If you guys know, I'm originally from Peru. My mother was Quechua, My mother's Quechua, my dad was a mix of who knows. And so I understand what my brothers and sisters here have gone through. My mother never taught me her language because of discrimination, because she was afraid that bad things will happen if people heard me speaking with an accent. And there was disparity in care. My mother was a nurse, so I saw it all the time. And so for me, actually coming to work here was a dream come true. I could not serve my brothers and sisters back in Peru, but I could serve my sisters back here in North America. And that's why I think I have stayed here this long. I still, towards 20 years of emergency medicine, I'm looking of doing other things, hopefully reinvent the wheel. If you ask me, I will almost try anything. I've done EMS director, not as well as Alex is doing it. I've done teaching, not as well as you guys doing it. I've gone to the community. I've always tried to find things in my own way. What I love about the group that we have right now is that there is a structure. I hear Christopher Gentoff saying that the best thing that he did was hire you. And I think the best thing that happened to us is when we hired Paul. I don't say I hire you, it was because I think I had taken some time off because I actually felt that I was burned out. But when Paul came with his new ideas, and he was what we needed. He was what I needed for me to continue when I took my time, when I returned to work. And the innovation and the ideas that he bring, the freshness in emergency medicine. And I think one other suggestion is that in emergency medicine, to be able to continue, we really need the flexibility. I'll be honest, it was a little bit hard at the beginning because as you get older, you get more done in your ways. But that freshness, that hope for the future that we can do things better. I just tag along, and I've seen things in IHS now that I never thought that I would see in 20 years. So that gives me hope. Safi and I were talking about this last night. We have a new generations of amazing ER physicians who are full of energy, love, passionate about what they do. There is more respect for us in emergency medicine. People know that knowing anyone can do it. It's just for the people that are cut for it. There is more women in emergency medicine, and that is so amazing. People can look up to say, hey, I can be like her. So having the new team is definitely having a lot of learning for me. I keep learning. I'm still learning, and I thank you for the opportunity to grab the phone from these two guys.
Esperanza, that is very difficult to follow. I don't. But thank you for being here. And the first thing I want to say is, without Esperanza Sanchez, without Steve Conieras, there's many of us are not here today. And Ken and Zach and Dom may never work together, and Pinnacle never may be formed, and Emmerich may never happen. And none of us get to meet today without Esperanza and Steve and the people who, the topic of this is longevity, without the people who are the best examples of really sticking it out and serving through the most difficult times. So thank you both. I say that to a lot of people, that without you all, none of the things that are happening in the last few years or meeting or talking about pathways, protocols, difficult airway, you all made it possible because you stuck it out and you made it a place that we all wanted to be at, to come to. So I thank you both for allowing us all to be here. I think the question was around the difficulties or the challenges of overcoming, just getting here, right? Was that the? Yeah, well, I think, in contrast to Esperanza's path, I think my journey comes from a place of privilege. Frankly, I was at an academic center. So my journey to Fort Defiance was from a great job that a lot of people would really, I think, hope to have and would think was pretty crazy to leave. And it was overcoming my own prejudices and the prejudices of the system, I think, and the culture around us to make a move that seemed, I think, in the minds of many to be a downward move. I actually have this is being recorded, so I'll share this with those who are coming to Picking in the Pines, but like a very concrete example of a senior person in our space who, frankly said it was a mistake to make that move. And but I felt it in my heart, it wasn't a mistake. And I'm very happy to make that decision. So it was really about cultural prejudice, I think, for me, was the biggest thing, personal challenge to overcome.
Wow, thank you. Thank you all. It's pretty inspiring when I get to meet people, visit different facilities. The quality of care that you give is unbelievable, and I'm inspired. So thank you very much. I'm done. Yeah. Hello. I guess what I would say is I would take this moment to address longevity just from the things that you can control rather than anything outside you. There's certainly many things. Someone might say administration, and I think we could go on, but what are the things that you as an individual can control? Or in this case, for me, that I thought I'd control. And one of the first things was, how do you get rid of feeling like you have to get approval, you have to get gratitude or thanks from people? And it sort of struck me that I'm going to try and be like the sun. The sun comes up whether we praise it or not. Okay, it gets criticized, it comes up. And so to me, that's how I think about it. You show up at the ED, you go to a meeting, you just take care of the patient. And I think if you do that, a lot of things line up pretty dang well. The second thing I thought was, you got to be happy. If you're not happy, then it can be a problem. And certainly in our ED, when I first got there, me and two of the nurses got written up for laughing in the emergency department because this is a serious place and we don't have any of that kind of stuff. So we had to change that a little bit. And so you have to understand about what it takes to be happy. And that, to me, that's one of the things is gratitude. If you show gratitude and appreciation to your coworkers, to the nurses, to the techs, it comes back to you, but you feel good about it. And so every day when you leave your shift, maybe take a moment to stop by the lab and thank all the lab techs who help you make a diagnosis, and thank all the radiology techs who helped you make a diagnosis, and you couldn't do it without them. The learning mindset. I definitely see that in this group. I think if you have a learning mindset, you're going to do well. It's when you have that fixed mindset, you get stuck. So try and keep a learning mindset, keep enjoying. 7 times down, 8 times up. It's a pretty famous Japanese saying. If you really think about it, it doesn't make sense, because if you get knocked down once, you get up. So it should be 7 times down, 7 times up. But the saying is 7 times down, 8 times up. Just keep getting back up. I mean, you're going to get knocked down. That's okay. Get back up. And probably the last thing I think that really helped me was just care for the patient. Just see the patient. Oh, this patient's too sick for me to see, or this patient's not sick enough for me to see. Just enjoy your patients. If they come in with a sore throat, there's really nothing wrong with them. Enjoy the interaction that you get with them. Compliment them on their shoes or a piece of jewelry. Find out about what they're doing and the life they're leading, because the bottom line is we're all human, and it doesn't matter about anything. We're all human, and what's in my heart In each of your hearts, it's different, and each of our paths are different. And once you appreciate that, I think it can be a lot of fun. So thank you.
I think I was kind of trying to think as to summarize like everyone's unique experience. And to me, it really boiled down to, so one, the timeline. I think that's huge because I've been focused on a 3-year timeline for 3 years. Right, oh God, I'm like COVID and everything's terrible and whatever. But you just gave like this amazing insight into the fact that things are so much better. Right. And I'm like, that's so refreshing. Because you just say like, oh no, this is fundamentally better than it used to be. And that's really reassuring. So thank you. Right. It's just that, it's just that thing, like things move forward and have moved forward. It's like there's more female representation. There's like you have mentors, you had like and there's a new generation that has improved things. That's a wonderful perspective. And then the other thing that like the common unity among you all was a willingness to change your perspective on things, right? From the cultural barrier to you just saying like, no, like I'm gonna take the opposite perspective, to essentially the sun rising and setting, like I'm gonna take your critiques, right? To working other people's jobs. Because like you will go through the day-to-day and you all know what annoys you, right? Like, and what particularly drills you personally. But if you can flip that on its head and you say, I'm like, let's think about this, or let's approach this from a different direction. Because some things are right. It's like Steve said, some things you can't change. But no, like this is how the pros have done it to make it last really long. It's just very insightful. I then wanted to touch on what you guys felt. It's probably easier and to jump to the systems barriers that you still think exist, that you still see, where you say, hey, this is what I feel is one of the barriers to us creating long careers for people. And then what would be the ideal way around that? Like, how do we overcome those? And I'm asking hard questions, and I'm happy that I'm not sitting in your chair. So I just get to ask the questions. But then again, I get to go back and try to fix them. So help me. Cool.
So this is not an attack to a specific group, but I think the middle part is what we see when we back in Gallup, when, for instance, I'll just bring an example, the hiring of physicians. It is just such a cumbersome process that I'm really surprised that after almost a year that these providers who could have gone and worked elsewhere are still willing to come and work with us. In that actually, it can be done easier, I think, and it can be done in a way that it shows that we really want them, and we because they are going to take care of us and our families. But it's just very difficult and very, very trying. And at times, I think very frustrating for us on the other end, because we're representing our institution, we're representing IHS. But I can even imagine for the physician who's coming, who's eager to work, and then we keep telling them, no, next time, next time. I wish with our system, there would be better closed loop communication. One of the things that I think I'm better now is just not getting upset there. Every single thing I submit a document is signed. Please let me know if I need to do anything. And I don't hear anything 1 day, 2 days, and just I get an email Friday at 3 o'clock. It needs to be signed by 4 o'clock, close of business. Otherwise, your doctor is not coming. And but I've been asking, and I don't know how to go through that, except just take a deep breath. And eventually, when I have a chance, I will go and meet with the person, thank them for what they're doing, and just bring it back to the patient. What you've done is helping us to provide better care. It's helping us to see patients that are coming to the emergency department. Thank you so very much. And I think with time, I have become better at that. When I just took the job, and it was, someone said it earlier, it wasn't because I was inspired to do it. Honestly, when I got into emergency medicine, all I wanted to do was see patients, and don't give me any projects because no, that's not for me. And I always said, you know, if they would have interviewed me 20 years ago, they would probably not hire me because I would have said, no projects, nope. All I want to do is see patients. When I took the job, I did it mostly because I felt, well, I've done it for 13 years. Maybe there is something I can offer. And maybe I'll try it for 6 months, and 6 months now are 7 years. So there is a pattern here. But I think those are the things that we can do better, because we're showing us as an institution to people that are coming to want to work with us. And if somehow we bring that back to the patient, maybe our people that work at these different areas outside in the administrative part, they will understand that they are so important in this role, because if they don't sign this paper, or if they don't fax it, or if they do whatever they need to do, we don't bring this provider. Therefore, we'll have an opening. Therefore, a lot of people will walk without being seen. That seems to have helped me in, well, most of the time.
It has worked. You're here. You're right. This is a hard question. And this is, I think, the one that will really wear you down. That may force a lot of the directors to tap out at a certain point, because it's the system issues feel so immense. And I should say at this point, for those who have not worked in a 638, the differences are stark in the administrative regard, not in the clinical regard. My pitch for, and I think we have a very good collective and communal recruiting effort, even across the 638 IHS. My pitch was always like, best benefits in the world with IHS, little bit more I mean, I think this is true for the clinician, even a little more bureaucracy, like for the administrator, a lot more, for the clinician, a little more great clinical care in both 638 IHS. So just take your pick, just see logistically what's the best fit for you. And then everybody went to GIMC I tried to hire. And like, so I need to revise my pitch. But for the, you know, the administrative side, and some on the administrative side, this part, so the reason I make that disclaimer is because I think I had it a little bit easier at a 638, and I've heard all the war stories from my friends elsewhere. Though they were still present, and that the administrative challenges were there, and I think that a couple of approaches that I would recommend, and you don't have to be an administrator to do this. Like if you're in the clinician seat and you're coming in, I would recommend considering this perspective. First, figuring out what's the long game and what can be fixed, you know, what you can overcome, and like really understand that quickly, so that you don't start banging your head against the wall too early. Because if you start banging, you got to bang your head against the wall at some point. If you start too early, you're gonna be in trouble. And so if you can identify those things that you really can't move, and you approach them, you leave those aside and you address the things that you find that you can move. Or if you can't move that next thing, keep moving down until you can find the thing that you can push on and move. I think it's important to do this assessment as quickly as possible, particularly when you're in an administrative role, if you're a director, because this is a room full of people that cares, and these people have definitely cared a lot. And it's when you care so much and you meet this resistance, it is non-sustainable. And I'll share an example, pass over to Steve, but this whole thing about like we have the contract nurses that cost like 60% more than, or 100% more than it would be to like do 15% more for nursing salaries. A lot of nods. Like, what's that all about? I never got a satisfactory answer from anybody. And I think in the 638, it was kind of residual from the IHS days, but I never got a satisfactory answer for that. And I think a lot of people in the room continue at that one. And I continued at that till the day I left Fort, but I knew that at a certain point, like 6 or 12 or maybe 18 months in, I realized, okay, this one's probably not moving. I'm going to move on to the next thing. So yeah, I think identify what you think you can change, and then don't give up on it. if you're not making change immediately, but come back to it and move on to something else.
It is pretty amazing. I was just being reminded when I first came to the res, in the emergency department, you handed out drugs yourself at night and some drugs. So what was the drug that we handed out? We had Demerol in the emergency department, if you could imagine that. And if you went in the code cart, there was no beta blockers. So the quality of care that you guys give is pretty far. And we had providers that sent GI bleeds home if they were drunk. That gentleman lasted not even to the end of his shift. I think, and as a leader, you have to set the tone. You have to create that environment of excellence. And sometimes that means, yeah, somebody's got to go. Usually you can sit down and talk to them and have them resign without making a big deal out of it. But it's something you need to do. I think once you do that, then the next thing you do is what? Hire people smarter than you. Get out of their way. For example, yeah. Of course, Dom is thinking in his head, well, it's not very hard to be smarter than Steve. So, and there is a lot of truth to that part, but I think you just hire people that are smarter than you and never fill a position just to have a body. Yeah, deal with the locums. You won't like it. I always apologize to my IM friends. Sorry, we have this guy. He's not going to, yeah, you guys are going to pay the price, the consultants. A couple other things when you run into this problem. When I first came, one of my first shifts, I said, we had this patient, we're going to ship him out as a trauma patient. I told my clerk, call Good Sam, we're going to ship this patient down there. And she looked at me and she said, do you know how to use a phone? I go, yeah. Do you have a finger? She goes, yeah, well, go for it. So, and that person continued on. Dom actually still, when you were there, she was there. And she was a great clerk. And you're like, how do you get those transitions? I think one of the big things, in that case, we spent some time. We had a secretary at Tuba who was amazing. And so while I have the idea, she made it work. It's just like, I don't think our clerks really understand how important they are. And once people understand how important they are, and so I had an example where we had a patient come in, they were in VFib, and the clerk found out who this person was and handed me the summary, and I was able to see that this person was on a TCA. So it gave me an opportunity to do the right thing. And so that was the story we used. And that's why, as a clerk, you save people's lives. And for them to get aggressive and get out there and try and solve the problem, help your docs. And the same thing with your lab techs, and the same thing with, HR, which I was never successful in breeding that. But I think in the people that are close to you, if you can get them to understand why they're important, right? It's obvious to you why they're important, but do you ever take the time to thank them? Do you ever take the time to explain to them? And then once you do that, you have to make it part of the system. The system has to teach them that all the time. And it needs to come from the docs. Expectations. I think if you want good people, you want them to do well, set your expectations. And I just gave them a sheet of what my expectations of them were. Above and beyond sort of like, yeah, show up on time, blah, blah, blah. Okay. And I tried to break it down into what are things as far as caring for the patient, my expectations, what are the things you need to do to keep the department running? What are the things you need to do to keep the hospital running? What are the things you need to do to keep you running? And so I broke it down into 5 or 6 different things, including like how you're going to get your CME. How are you going to keep learning? How are you going to make it enjoyable? And so if you set those expectations, they'll get refined. Your docs will help you get better, but it gives you something to start with. good. I think, lastly, care for your docs. That's like, I see that so often, not so much in emergency medicine, but in other places. I like, you're talking to like the chief of whatever, and they're just like, oh yeah, the CMO said this, so I just shove it on down and treat them, like whatever. And I know Ken's work talking about IHS facilities around the nation. What was the #1 problem with docs? It's like administration doesn't appreciate us. Well, as chiefs, I'm in line. Everybody doesn't need to hear all that. So protect your docs and make them feel good about what they do.
And I would, thank you. So not only does, so this obviously is like a discussion very pertinent to the future leaders in here, which I promise you, you're sitting here and you don't even know it yet. So I'm like, maybe Paul like tapped you on the shoulder and was like, yeah, someday, but it's much sooner than you think, and you have no choice. Sorry.
So I went to Chin Lee, and there was one emergency medicine doc there. She was in charge. Everyone else was a locum. I was there 1 month when her husband crashed his plane. And so she went on leave for 2 years. So I was 1 month out. So when he says someone's going to tap on your shoulder, he's not joking.
Yeah. Yeah, there's like a direct lineage, but even in like just frontline clinical practice, right? The IHS and the tribal systems there's so much work to be done, and this underfunded, understaffed situation is such a reality that every single one of you have an administrative project. I promise. There are very few pure clinicians in this room, right? And so you all have your opportunity to bang your head on the wall, right? But this is just great advice, is like, okay, like recognize what you can move and recognize what you can't move and move on. And so I've, on the flip side, I'm gonna leave with some positive notes on the system, right? And this is kind of my spiel when I'm recruiting someone, is I say, hey, like if you're coming from the community, I don't have RVU-based compensation. I don't really pay attention to press gaining. I don't know how this works. No, and so there are a lot of systems things that still exist to allow you to be a physician and practice as a doctor. And then there's also a lot of mission driven and very eager people that you work with. And so it's really inspiring to be here. I love this topic because I've made my decision. Like I made my decision 5 years ago, and I just sat there with a list and I went head to head because I was already working in the community at my dream job in California. And I just said, I said, no way, like it doesn't hold a candle to what I found here. I work with friends. I feel valuable about the work that I am doing. You're infinitely more valuable where you are. And I have a community, and that's all it took, and that's all it still takes. And I've taken all of your lessons and we've built on that. And today is just really refreshing and some new takes on things that I haven't even thought about yet. So thank you so much for what you've done, what you've contributed to the communities here. And we all look forward to building on what you built. So thank you. Oh, yeah.
Hi, I'm not a chief, but I worked in IHS and tribal since 1999. And I just wanted to let everyone know you don't need to be a chief or director to keep working in the area. Things that I found really helpful were the inspiration of colleagues. If I ask myself, sometimes when I didn't think I could take it anymore, I'd say, did I choose hard or choose easy? And when I reminded myself that I picked a hard job, it left me able to return to hard because I had chosen hard. I didn't choose easy. So that was one thing that was helpful to me. other things, I was not invited to talk. I just thought I'd stand up and talk. And so that's the other thing about not being a chief. You can talk to everybody. Nobody is controlling what I say. I can ask my colleagues for money, for scholarships, for funds, for parties, for who, you know, you name it kind of things. So there's a liberation in not being a formal chief or a director. And so some ideas I want to express to people about longevity. So if you have an idea and you think about this idea and you think about it long and long and long, you know, it's going on a long time, but you're not able to achieve it. You try going around this way, you try going around this way, you still can't get it to happen, you go this way. And you just talk about it to every single person. And I discovered that if you talk about it to enough people, sooner or later, someone in power is going to come to you and say, you know about this? And you go, wait a minute, I started it, you know, but I'm not going to tell you that. So I would say, don't be afraid to play volleyball. I never played volleyball, but I think some people do. Don't you kind of set it up? You throw it around until someone else puts it in. So Esperanza couldn't get that any 2080. I couldn't get any 2080, but eventually Paul Charlton maybe could get any 2080, you know, and the same way, no one wanted to pay IHS or tribal emergency salaries. So we were stuck with the same system in nursing right now. People are willing to pay double to be a contractor. Hey, I was a contractor. I made a lot of money, but I was too lazy. I make more money as an employee because I didn't want to work. But I think that, but the deal is that if you bring it up over and over and over, eventually somebody with power listens and says, hey, look at, we should have emergency physicians. What do we have to do to get them? And then the contractors become employees. I mean, so I guess the message in that is, don't give up. Don't give up. Just pass the volleyball on to someone else and maybe they can, or soccer. I guess it's soccer. You score the goal. You pass it enough and somebody else scores the goal. Do they get the glory? No, the whole team gets the glory. So that's what I would say. Don't give up. And if you have a really, really bad shift, just ask yourself, did I sign up for easy or hard? And we signed up for hard.
Thank you. That was great. One thing people may not realize, so we did like a department retreat last fall, and we asked people to tell their stories about why they chose to work at the Gallup Indian Medical Center. 90% of the people in their story said part of why I came to work at Gallup was because of Safia. So I think we should wrap it on the high note. What I would love to do is for anyone, if you have 2 or 3 minutes, could we just come to the front and get one last photograph from things? Oh, yes, Cass and Jay are here now. You missed before. Thank you. Cass and Jay, please come forward. They have been the stars of this. It was kind of like them watching 3 blind position mice just going around in circles until they guided us in the correct direction. We want to say thank you so much for all of the help with making this possible. Great. Thank you so much for being here. And then any final words? Otherwise, I think, Sean, you want to end with something?
No, just on Safia's note, you know, and Paul mentioned it earlier, but you know, there's not a lot of big healthcare organizations, and this is a big health organization where you have access to like the CMO, and she's like one level below the director who reports to Congress, and you all have that. And sorry, Paul, not to put too much pressure on you, but I say that because, you know, we're all challenged by burnout at times, moral injury, being tired, feeling helpless, and you're actually not helpless. You've got like a direct line up to very high level people, and you don't always have that in an organization. So I hope on the hard days, or when the systems are broken, you remember that, and it keeps some wind in your sails. And I remember hearing, this is very simple, but I remember this, and I know that you all do it, but I heard, yeah, I'll leave them unnamed, but it was a celebrity say this: if you work hard and you're nice to people, amazing things can happen. And that's what I try to think when I do work. So, but it's not hard work working with this crowd. It's easy, but if it ever feels hard, just remember that, and hopefully that pays off. That's all I got.
We'll have people come up for a photograph. Yeah, yeah. We can do one fine.
Oh, yeah. Like a big photo?
Yeah, big photo. Yeah, if we could have people come up for just one final big photo, and then we'll get to enjoy the evening.